نبتدي إن شاء الله. Start. يلا. السلام عليكم. Morning everyone. It's our pleasure to be here in the Maternal&Child Health Congress. I think this is the second one. First one was pretty a success, and I heard that this yesterday was a success. Inshallah, today will be a success again, inshallah. We'd like to start our Congress today by inviting Dr. Saida Al-Belushi to present her lecture. Dr. Saida is a well-known obstetrician gynecologist. She is a consultant there, and as well as an assistant professor in the AGU. She has subspecialty and special interest in fetal-maternal medicine. So welcome, Dr. Saida.
Thank you, Dr. Malas, for the introduction, and thank you for the organizing committee for inviting me for this, to attend this ceremony and to be part of the team. So today's topic, my topic, will be about an overview of the preterm labor. All of you know the preterm labor is costing a lot, and more than that, it has a lots of morbidity and mortality for the baby. So without further delay, we will start for the sake of time. So I will start with my presentation. Something is like basic introduction, then I will go into the updates, and at the end of my topic, I'll tell you about the latest research in this field. So what is preterm labor? I think all of you know is defined as a birth before 37 weeks of gestation, which is completed. Now there are subcategories, okay? You have extremely preterm when it is less than 28 weeks, very preterm when it is 28 to 32 weeks, early preterm when it is 32 to 34 weeks, and late preterm we have from 34 to 37 weeks of gestation. What is the prevalence? The incidence is around 5 to 11% worldwide. So it's one of the causes of the major morbidity and mortality for the fetus and the major cause of hospitalization of the woman. Now, why we are interested in this preterm labor, and we are talking a lot about preterm labor, because we know that accurate identification of a woman in a true preterm labor allows us a that will improve the neonatal outcome, such as what? Antenatal corticosteroid administration, group B streptococcal infection prophylaxis, magnesium sulfate for neuroprotection, and to transfer of the fetus to a facility which has appropriate newborn care. I will skip this slide. This is just an introduction that what is true labor and what is false labor. False labor, what we call a threatened preterm labor, when a woman comes in with the contraction, but there is no cervical dilatation or effacement. So here we will call it as threatened preterm labor. What are the risks? Means if this woman goes into preterm labor, what are the risks for the fetus? So there are immediate risks. It will be more to the baby. There are immediate risks, which is birth trauma, hypothermia, respiratory distress syndrome. And we have long-term also morbidity in this fetus. They will have chronic lung diseases, retinopathy of prematurity, and some neurological cerebral palsy, mental retardation, blindness, and deafness. So what are the risk factors? Why certain woman goes into preterm labor and other doesn't go? So what are these risk factors that encounter the woman that precipitate her to go into preterm labor? The most important and the strongest risk factor is you need to understand when you are taking the history, you need to know that if she has an incident of preterm labor in her in the previous pregnancy, because that will add her risk to this subsequent pregnancy. Means in the current pregnancy, what will be her risk? So if she had one preterm labor, her risk will be 14.3%. But after 2 preterm births, it will be 28%. But just imagine, after 3 previous preterm births, it will increase up to 70%. So history taking is very important in these patients to know her risk in the subsequent pregnancy, what is her risk of having another preterm birth. The other risk factors, status, multiple pregnancy, cervical incompetence or uterine anomalies, cigarette smoking, overdistension of the uterus because of fibroid, because of multiple gestation, and then we have uterine anomalies, cervical anomalies, previous cervical surgery, tobacco chewing, bleeding in early pregnancy, bacterial vaginosis, periodontal diseases, medical termination of pregnancy, short interval between pregnancy and maternal age. Now, what is the pathophysiology? The pathophysiology, all of you see it, it is the premature activation in the mother or the fetus of hypothalamic pituitary adrenal axis, or inflammation or infection, overdistension of the uterus, and decidual hemorrhage. You need to know all of them will come into one pathway, which is what? Which is the lead to myometrial contraction, cervical ripening, ultimately which that lead to preterm labor. So, cases who are coming with the, or in a mother who come in the preterm labor, why should prolong this pregnancy? Because all of us know each day of delay between 22 and 28 weeks of gestation, it increases fetal survival by 3%. Now, if you see this graph, you will see that prenatal mortality rate decreases with the advances of the gestational age. If you take it at 24 weeks, this is how, because according to this graph, this is how we'll be able to counsel the patient. Because if she comes at 24 weeks of gestation with preterm contraction, you know that the prenatal mortality is 80%. Whereas if she comes at 32 weeks of gestation, you will know that the prenatal mortality rate decreases up to 32%. So what are the predictors in the preterm labor? We have the cervical assessment and we have fetal fibronectin. Now, if we are talking about cervical assessment, you need to understand cervical assessment, it has to be done vaginally, not digital, not abdominal, in order to assess the cervix. Now, if you see this graph, which is done by Goldenberg et al., probability of delivery before 32 weeks based on the cervical length, okay? If you see the cervical length more than 3 centimeters, means it's a long cervix, so her risk of having a preterm delivery is only 5%. 2 to 3 centimeters, it comes to 10%. But how about if it is less than 1.9 centimeter, it means it's a short cervix, so her probability of delivering a fetus before 32 weeks will be 20%. This is the same, means if it's more than 3 centimeters, you will categorize her as a low risk, and if it is less than 2 centimeters, the cervical length, you will categorize her as high-risk patient for preterm labor. Now, what is fetal fibronectin? Fetal fibronectin is an extracellular matrix protein present at the decidual chorionic interface. Now, disruption of this interface, uterine contraction, it releases this fetal fibronectin into cervico-vaginal secretion. Now, this is the basis for the predicting about the spontaneous preterm birth. Now, it is detectable in cervical secretion. You need to understand, it is detectable normally between until 16 to 20 weeks, but after that it disappears, but it reappears shortly before birth. So, appearance of fetal fibronectin in the cervical secretion after 24 weeks of gestation in a concentration of 50 nanogram per ml may indicate detachment of fetal membrane from the decidua. Now, how we are going to read the result of fetal fibronectin? It comes as positive or negative. Negative has high predictive value. What I mean by high predictive value means her chance of delivering preterm in the coming 2 weeks, it will be less than 1% if it is negative. But how about if it comes positive? Positive predictive value, it means her chance of delivering in the next week or in the next 2 weeks, it will be only 18%. Now, where we are going to use this fetal fibronectin? So it is recommended for symptomatic women between 22 and 34 plus weeks, okay, with cervical dilatation less than 3 centimeters, but the cervical length is between 20 to less than 30 millimeters. There at increased risk of preterm birth. Here we'll use the fetal fibronectin to assess us or to help us in predicting if this woman is going for preterm birth or not. I will skip this other laboratory because they are usually in the research, still they need to be tested, means if we are going to use it. Now, so the following specific criteria that we will use it for the diagnosis of preterm labor is uterine contraction, plus cervical dilatation, plus cervical length when it is between less than 20 and when it is between 20 and less than 30 millimeter. And I will explain in this one which condition that you should use the fetal fibronectin. Now, other laboratory evaluation, you have the rectovaginal. Don't ever forget you have to do rectovaginal group B streptococcal culture if it is not done before, because your antibiotic prophylaxis will depend on the result. The other one is the urine culture. All of you know is symptomatic bacteriuria is associated with the increased risk of preterm birth. Then we have to do testing for the sexually transmitted diseases like chlamydia and gonorrhea. It depends on the patient's risk factor. Now, how we are going to approach in these patients with preterm labor in a singleton pregnancy. Now, all of you know if she is more than 34 weeks of gestation, you will admit her, you will observe her for 4 to 6 hours. If there is no cervical dilatation or effacement, you can discharge her, provided that you have tested for the fetal well-being, it is reactive non-stress test, and the other thing, the obstetrical complication has been excluded, such as abruptio placenta, chorioamnitis, and preterm rupture of membrane. Now let's go. I will talk about this mortality more than 34 weeks later in my slides. Now, if these women are less than 34 weeks, they come with uterine contraction. Now, let's say if they are more than or equal to 3 centimeters, they are dilated. So this is the preterm. So here you will diagnose them as a preterm labor, and you need to initiate the therapy. And here you do not do the cervical length assessment or fetal fibronectin. Now, if the cervical length between 20 and less than 3 centimeters, and the cervical dilatation is less than 3 centimeters, here you will send the laboratory test for fetal fibronectin. Now, if the cervical length is less than 20 millimeters, it means it's a short cervix. This woman is symptomatic, so they're at high risk of preterm labor, which is more than 25%. Here you will not send the fetal fibronectin, and you need to start the intervention. Now, if cervical length is more than or equal to 3 centimeters, it means it's a long cervix, so the chances of preterm delivery is low, and it is less than 5%. Even here, you will not send the fetal fibronectin. Now, how about the twin gestation? Twin gestation, if they are more than or equal 34 weeks, we follow the same triaging we have done for the singleton. But if she is less than 34 weeks of gestation, here you will, of course, you will not send the laboratory testing for fetal fibronectin because it will not enhance the diagnostic accuracy. Here you have to make the diagnosis of preterm delivery, and you will start the intervention. Now, what are the treatment? The first line of the treatment, you give them antenatal corticosteroid. So antenatal corticosteroid, whether you give them betamethasone or dexamethasone, both drugs are effective in accelerating fetal maturity. In the randomized control trial, it is a single rescue course. You will give it to less than 34 weeks who are at risk of preterm delivery within the next 7 days. Now, why we are giving them corticosteroid? What the study have shown, it decreases the NICU admission, neonatal death, respiratory distress syndrome, early systemic infection, intraventricular hemorrhage, and necrotizing enterocolitis. So with this all the benefit, they need to receive the dexamethasone. Now, what is the dosing and pharmacology? Betamethasone is given 12 milligram, 24 hours apart. Dexa is given 4 doses of 6 milligram, 12 hours apart. With these doses, 70 to 80% of the receptors are occupied. Now, the other point is the study has found that with these doses, it is not reduced in a patient who are overweight. Then multiple doses of corticosteroid should be avoided. The other thing is we'll talk about the antibiotic. What is the role of antibiotic in patients with the preterm labor? As per Oracle study, antibiotic treatment is recommended only in the presence of rupture of membrane to prevent chorioamnitis. amnionitis, sorry. So empirical use of antibiotic in patient with preterm labor without rupture of membrane is not recommended. However, if the vaginal swab is positive for GBS, then yes, you will give them antibiotic prophylaxis to prevent the GBS sepsis in the newborn. Now, what the best antibiotic you will give for GBS prophylaxis, I think all of you will know, is intrapartum. You give them intravenous ampicillin. Now, if patient is allergic to ampicillin, you will give them a combination of erythromycin plus clarithromycin or clindamycin. Now, intrapartum antibiotic prophylaxis is effective also at least 4 hours before delivery. Now, how about the tocolysis? Now, what is the treatment goal of tocolysis? Why you are giving tocolysis? To delay delivery only by at least 48 hours when it is safe to do so. Because why you want to delay it? You want to allow for antenatal corticosteroid to be administered. Then the other thing is you want to provide time for the transfer of the woman to a facility where they have the facility for the newborn care. What are the contraindications of tocolysis? Of course, you need to understand tocolysis should be given only for 48 hours, and also continuation of tocolysis, it is not recommended. Contraindication of tocolysis, I'll go through them. It's intrauterine fetal demise. I think all of you know lethal fetal anomalies, non-reassuring fetal status, preeclampsia and severe features of preeclampsia, maternal hemorrhage, which is hemodynamically instability, and then you have intra-amniotic infection, preterm premature rupture of membrane, and so these are some of the contraindications for tocolysis. Now, how about beta mimetics? Beta mimetics, this is the best studied tocolytic drug so far. So according to Cochrane review meta-analysis, ritodrine and terbutaline, these drugs prolong pregnancy 2 to 7 days, but they do not lower the prenatal mortality. What is the dose of ritodrine that you are going to give? Is 50 to 100 microgram. You increase it by 50 microgram every 10 minutes until contraction ceases or side effect develops. Maximum dose you will give 350 microgram per minute. Isoxazoprine is not used in preterm labor. How about the terbutaline? Terbutaline, they say the best route to give terbutaline, it will be subcutaneous, even though you can give it IV, but oral route is not advised. Now the dose is 0.25 milligram every 20 minutes for 4 to 6 doses, withhold if the pulse rises. Now what are the side effects of this beta mimetics? Pulmonary edema, myocardial ischemia, and cardiac arrhythmia, tachycardia, transient hyperglycemia, and hypokalemia. Now, according to the NICE guideline, do not offer beta mimetics for tocolysis. This is, yes, in the NICE guideline, but it's still used in the US. And the most beta mimetics which is used in the US, it is the terbutaline. How about Nephidipine? Nephidipine, RCOG actually recommends to use the Nephidipine. The dosage is initial dose you will give 20 to 30 milligram followed by 10 to 20 every 4 to 8 hours until the uterine contraction subsides. Now the side effects, flushing, headache, dizziness, hypotension, and peripheral edema. Now the serious side effect, myocardial infarction and death, but these are rare. But it is, you need to know that it can be present. Etosibam, is oxytocin antagonist. Initial bolus dose you will give 6.7 milligram over 1 minute, followed by infusion of 18 milligram per hour for 3 hours, and then 6 milligram per hour for up to 45 hours. Duration of the treatment should not exceed 48 hours, and the total dose given during a full course should not exceed 330 milligram of etosibam. Indomethacin, a cyclooxygenase inhibitor. The dose is 50 to 100 milligram. You can give it orally or rectally, followed by 25 milligram every 4 to 6 hours for 48 hours, and the maximum dose that you can give is 200 milligram. They are contraindicated in a patient with hepatic and renal impairment. Now, prolonged use of indomethacin more than 72 hours or after 32 weeks of gestation is associated with premature closure of the ductus arteriosus and oligohydramnios. Now, prenatal, there is potential increase also of preventricular leukomalacia at a daily dose of 200 milligram. So it can be used as a first-line agent in a preterm delivery secondary to polyhydramnios, as it will reduce the formation of amniotic fluid. However, the evidence about this recommendation is lacking. Now, how about magnesium sulfate? Magnesium sulfate, actually, with the Cochrane review, they concluded that as a tocolysis in delaying or preventing preterm birth. So they are not using or they are not advising that magnesium sulfate should be used as a tocolysis. But yes, they are advising magnesium sulfate to be used because they have found it has potential neuroprotection benefit. In that sense, it reduces the risk of cerebral palsy and other types of severe neuromotor diseases. Now, when you are supposed to give it, for a woman who has imminent preterm birth between 23 plus 6 till less than 32 weeks of gestation. So you will give them magnesium sulfate for fetal neuroprotection. Now, administration, loading dose of 4 grams followed by maintenance dose of 1 gram per hour until delivery or for a maximum period of 12 hours. How about nitric oxide donors? Nitric oxide donors is glycerin trinitrate. It's given as 10 milligram patch every 12 hours, continuing 8 hours. But currently, there is insufficient evidence to support the routine use of nitric oxide donors. Now, regarding tocolysis, continuation of this topic, there is no clear first-line tocolytic medication. However, RCOG recommends atosibam along with Nephidipine as first-line in the management of preterm labor because what they found, they prolong pregnancy and has good maternal tolerance. Now, they can be used in a singleton and multiple gestation. Now, tocolytic agent choice in United States is magnesium sulfate, and terbutaline is currently the most commonly used beta sympathomimetic. How about progesterone supplementation? Progesterone supplementation, it is considered with the patient who comes with a history or a woman who comes with a history of preterm birth up to 34 weeks or of gestation. Now, in asymptomatic singleton pregnancy with a prior single preterm birth, you can give them 17 alpha hydroxyprogesterone, dose 250 milligram weekly from 16 to 20 weeks until 36 weeks of gestation. The other point is you start screening this woman with transvaginal ultrasound of the cervical length from 16 weeks and every 2 weeks until 24 weeks of pregnancy. Now, in this woman with a prior history of single preterm birth, if you found on transvaginal ultrasound that cervical length is shortening and it's becoming less than 25 millimeter at less than 24 weeks of gestation, then cervical cerclage may be offered. Now, how about in an asymptomatic woman without prior single history of preterm, but you did an ultrasound and you found that cervical length is less than 2 centimeter at less than 24 weeks of gestation? Here you can give them vaginal progesterone 90 milligrams daily from the diagnosis of the short cervix until 36 weeks. In multiple gestation, symptomatic preterm labor, premature rupture of membrane, there is no evidence that progesterone is effective. Now, how about bed rest, hydration, sedation? There is no convincing evidence that bed rest, hydration, or sedation is effective for prevention or treatment of preterm birth. Okay, thank you. How about evaluation of amniotic fluid for subclinical infection? There are no consensus as to whether women in acute preterm labor should be evaluated routinely for subclinical intraamniotic infection or the appropriate test to do this diagnosis, like amniocentesis. Now, my last slide will be how about the lower and upper gestational age limit? I think this is very important because still debate is going on. How about, mainly it's about the lower limit, it is still controversial. In United States, experts the consideration of tocolysis if antenatal steroids were concurrently to be administered, but in the American College of Obstetricians and Gynecologists and Society of Maternal Fetal Medicine recommend not administering tocolysis before 24 weeks of gestation, but consider it use at 23 based on individual circumstances. How about the upper limit? Upper limit, we have more consensus about the upper gestational age limit for the treatment of preterm labor, because according to the ACOG and SMF, that 34 weeks of gestation defines the threshold at which prenatal morbidity and mortality are sufficiently low that the inhibition of preterm birth and short-term delay of delivery are not justified. Now, this is my message. If you are going to prolong pregnancy, you should prolong it when it is safe to do so. So do not prolong pregnancy when they're mother. Thank you. On time?
Thank you so much, Dr. Saida, for the excellent presentation. I have just a small comment, if you don't mind, regarding the use of cervical circulation. You said that, when you are doing for a patient with ultrasound scan at cervical length less than 2.5 centimeter, you can offer them cervical circulation. The recent recommendation of the RCOG, which was done last month, a couple of months ago, they do not recommend unless if the patient has a history suggestive of preterm labor before or previous miscarriage, but simply in a patient who first pregnancy or who had uneventual previous pregnancies, finding a short cervix is not an indication for cervical circulation.
No, I didn't say. I said we'll do vagina if it's asymptomatic, without prior history, while you are doing like cervical assessment, 24 weeks, you give vaginal progesterone. But not cervical circulation. Yeah. Cervical circulation, what they have recommended, actually I went through a lot of literature because in certain studies or articles, they were not, let's say in up to date, they're saying progesterone doesn't have a role in a preterm labor. But then you go for RCOG, you go for this Maternal Fetal Medicine Society, what they have said, they have put a condition, which is the condition that you can use the progesterone. So they have clearly defined it that asymptomatic woman with a prior history of single preterm birth. Here they said there is a role of the progesterone that you will give them hydroxyprogesterone 250 milligram weekly.
Yeah, regarding the use of progesterone issue, it doesn't come to harm to the patient, but when having surgical issue, it's usually an invasive procedure, yes, associated with complications.
That's why even, when they are very meticulous with the words they are using, they have written cervical circulage maybe. Never they have ever said it, yes, you have to do it. They have written cervical circulage can be offered.
The RCOG clearly says no. The RCOG clearly says that, those patients do not offer circulation. For asymptomatic with no history, simply on the cervical length, do not offer circulation.
See, what I'm going to say about the recent researches, I was going to tell you. Now, there is now a new Maternal Fetal Medicine Foundation. There is a conference which will be going on in June, and the topics that they are going to discuss, part of it, because in the preterm birth, this is part of the preterm birth which is in research. One of it is what's the use of, is there a correlation between the thickness of the lower segment with cervical dilatation? Now, what is the role of having a woman when you take her in second stage for cesarean section? Does it affect the preterm birth? And then the difference between, is it cervical circulage or cervical pessary? There is a study going on, a trial, Potex trial, I forgot the name of the trial. It's a new trial, they are going to do it, and they will discuss it now in this one. And then the other thing is now they're going to assess the elasticity of the cervix in knowing if this woman is going to go for a preterm labor or not. Called shear elastography, something. Elastography. Yes, elastography, yes.
Thank you so much, Saida.
My pleasure. Any other question? Or I don't know if there is time.
One comment. Since the IVF babies are at high risk of preterm labor, We are doing the FFN test in our center. We do it at 22 weeks, and so far we have done something like 15, 16 cases. The prediction was excellent all the time. Although sometimes some patients might come a bit earlier than 22 weeks. And there is still doubt if it can be used earlier than the 22 weeks.
I think it would have been nice if we would have shared this study with you, means to know it. This is really excellent because we are not doing it in Salmonia, that fetal fibronectin, but
Yes.
I think it's a good, and they specified actually when you are supposed to do this fetal fibronectin, because in all other conditions they have said there is no role or doesn't add to the diagnostic criteria if you are using fetal fibronectin. They have specified it in which dilatation of the cervix, what is the length of the cervix, and what is the gestational age.
Yeah.
Yeah, okay. Thank you.
Any question? Thank you, Dr. Saida.
My
Thank you
pleasure.
very much.
Thank you very much. Thank you.
It's my turn now to introduce my friend, Professor Hosni Malas, for the next talk. Professor Hosni is working at King Hamad University Hospital. He's a senior consultant in obstetrics and gynecology, and he is the head of the Department of Obstetrics and Gynecology and IVF unit and laparoscopic unit as well in King Hamad University Hospital. And he is also associate professor at Royal College of Surgeons in Ireland and Medical University Bahrain. Dr. Malas, please.
Thank you so much for this nice presentation, Salam. Actually, the presenting person will be, on my behalf, is Dr. Rihab Al-Ani, who is one of our senior registrar in the King Hamad University Hospital OB-GYN department. She has her MRCOG and Irish fellowship. She's going to present to us about induction of labor comparison of guidelines. It's a common topic, which is all are practicing, and there are different guidelines. So what we are doing usually for the time being is comparing the guidelines that is laid down all over the world with our guideline at KHOH, and then see what we can do better for patients. So welcome, Dr. Rihab.
Beautiful presentation, and good morning to everybody. I have the pleasure to take part in this event. I feel it's very nice to share practice and experience and compare it between us, and then in the aim to give the optimal care to all the ladies who are living on this island. My subject was about induction of labor. We tried to compare it with the national guidelines to see where are we standing, as Prof. Malas just mentioned. First of all, I just wanted to go through some history that when was it started or discovered. 1810, the first physician was James, in which he presented to use amniotomy as an aim for induction of labor. And then in 1906, the first discovery that there was a pituitary extraction that causes myometrial contractions. And from then, it progressed to discover the prostaglandins, which were first established in 1968. So induction of labor is a very common obstetric procedure that is all of us, let us say that. It initiates labor prior to the spontaneous onset. It's advised when the benefits of terminating the pregnancy outweighs the risk of ongoing pregnancy. So what we had here, we had a systemic review in which we compared between our institute in King Hamad University Hospital to other international guidelines of induction of labor, which is very well known, WHO, World Health Organization, American College of Obstetric and Gynecologists, Society of Obstetric and Gynecologists of Canada, NICE guidelines, Royal College, and finally the Society of India and Obstetric and Gynecologists. Just a gentle reminder that whatever we compare with any national guidelines, we have to always put in our mind to respect our local guidelines, because always the local guidelines will be tailored according to the community that we are dealing with. And not even the community, I will go more specific, that each patient with her own preference will have to be respected, and the induction of labor practice it, we have to do it in an aim that is tailored according to the patient who is standing in front of us. Now, what did we compare in our guidelines? We took many factors. I will go briefly through each factor, and then I went specifically to each one national organization. First of all, about pre-induction assessment. We all know that it's very important to counsel the patient. After we took the aim to induce this patient or terminate this pregnancy at this level or this gestational age, it's very important that we need to explain to the patient the procedure, explain to the patient the method, explain to the patient if this procedure did not go on or it failed, what is the next step. Or if the patient herself refused the induction of labor, we cannot just leave the patient on the half of the pathway. We have to categorize and organize another care plan for this ongoing pregnancy. Consent, which is a verbal consent usually, and also we have to explain all the risk and benefit of terminated pregnancy at this gestational age. Then we'll go on to the next, which is the indication of induction of labor, and I think all of us are aware about the induction. Would be intrauterine growth restriction, going to intrauterine fetal death, going to the maternal issue, which could be diabetes, thrombophilia, renal damage at any stage, going to preeclampsia, and all of this, which is very well known. I will not go through all of them. Coming to contraindications of induction of labor, this is also, I think it's very well known, that any contraindication for normal vaginal delivery will be definitely a contraindication for induction of labor. And the most important ones is the placenta previa, vasa previa, and any fetal, abnormal fetal presentation will also be one of the contraindication for induction of labor. Or any history before of uterine rupture. Cesarean section, we all know that there is a chance for induction of labor when there is a previous cesarean section, after explaining to the patient and taking a proper consent about the risk of inducing this patient with a proper fetal monitoring and maternal monitoring. Coming to the Bishop score, we all know that Bishop score is one of the scoring systems that is used to assess by doing a vaginal examination and assessing how much is the Bishop score. Now, is the Bishop score important? We'll say definitely yes. It is one, it will give you the choice how to choose which method of induction of labor you're going to go through. For example, if it's a favorable cervix, we might go with syntocinon. If it's not favorable, we'll go out with prostaglandin. And then it will also predict us the success of the induction of labor. It will give you a hint that where are we going to go, and to give you a next plan for a plan B in case this will not succeed. Now, I will come later to these points. When we differentiated between all national guidelines, the ACOG, American, the Canadian, the Royal College, were all taking Bishop score as favorable after 7. But for the Indian Society and for NICE guidelines, it was above 8. Now, is the setting of induction of labor important? We'll say yes, because induction of labor will put strain on the labor room and on the vaginal delivery room. So we need to make a proper incitement when to induce patients, and mostly it's done at daytime. We need a proper fetal and maternal monitoring, and yes, we will need a place that is having a nearby occupied OT in case we need emergency cesarean sections. What about monitoring during induction of labor? I think all of us are well aware that induction of labor will need a continuous fetal monitoring in case we are inducing with oxytocin, which was practiced before, which is the main practice. They were inducing with rupture of membrane and oxytocin. So in that case, we will need a continuous fetal monitoring. For us, when we are inducing with prostaglandin, we will go with a 1 or 2 hours CTG, continuous fetal monitoring for 1 to 2 hours after introducing the prostaglandin. And complication of induction of labor, this is also rare, but it can happen. Starting from, we'll have hyperstimulation. I think all of us are facing this issue during induction of labor. We can manage it by several techniques to avoid taking up with this continuous tachysystole, and then it will cause fetal changes. And the other thing is that it's very rare that we can have rupture of uterus or even postpartum hemorrhage, or very rarely chorioamnionitis. Now, I came with each organization. I took the specific points that can be different from other things. The WHO does not provide recommendation for counseling during the pre-induction assessment or mention any contraindication to induction of labor. They took it so lightly. They do not give that much of time or that much of concern on counseling the patient about each step and the contraindication in a serious way. The second thing that was specific about them, that there was no specification regarding the Pcos score system and preferencing favorable or unfavorable cervix to help determine the method of induction of labor. That means they will not rely on the induction of labor, whether they will go with which method. They will not depend on that. They will not depend even on giving the more success rate of favorable cervix or not. They will just go ahead with the induction of labor when there is a specific indication for that. WHO also do not have any recommendation to induce women with uncomplicated twin pregnancy. And as we all know that twin pregnancy, we don't usually let them go behind 38 weeks. But WHO, they don't have any mind of continuing pregnancy if there was no other risk factors. WHO guidelines also, there was no advantage of adding amniotomy to the IV oxytocin or amniotomy alone it is not recommended for induction of labor. So they don't use this method for induction of labor. We'll go now to the American College. The first thing I'm starting with, as I mentioned before, that one of the reasons of induction of labor is IUFD, intrauterine fetal death. When inducing a woman with IUFD, they have the method of induction will depend on the timing. So if it's prior to 28 weeks, they will go with misoprostol and high dose of oxytocin infusion. If it's after 28 weeks, they will go with the local hospital policy, in which most of them, they will go with prostaglandin. And I think that's what most of us are practicing. The ACOG do not have any recommendation to induce women with uncomplicated twin pregnancy, so they share the same guidelines or the same practice as WHO. What about their Pcos score? The Pcos score is 7 or more when they consider it as a favorable cervix. Now coming to the NICE guidelines, they have another practice. They were so concerned about proper counseling and having a good assessment and pre-induction assessment before starting even the induction of labor. The healthcare professionals must explain the following to each woman who's undergoing induction of labor. First of all, as we just mentioned, the reason of offering the induction of labor, options of pain relief and support, how is the support going to be supported, offering her all the pain relief, and she has the optimal choice to choose which pain relief she wants. Options for failed induction of labor or refusing induction of labor. So in case of failed induction of labor, they will have the chance either to wait and give more rest and re-induction, or they will go up with cesarean section. In case of refusing induction of labor, as I just mentioned, we have to give a plan for the ongoing care for this pregnancy. And most of us know that most of our inductions are being done because of postterm, beneath 42 weeks. So in case the patient refuses, most of the guidelines just recommended that we'll go on with assessing the liquor of the fetus, the liquor around the baby, and doing a CTG almost bi-weekly, twice a week. When or where and how induction labor will be performed has to be explained very nicely to the patient, and the risk and benefit of doing this induction of labor. Especially for the risk and benefit of induction of labor, they are recommending that the patient has to be counseled by 38 weeks, giving her a hint that if this pregnancy goes beyond 42 weeks, it will give us more complications, and we all know that it will increase the perinatal morbidity and mortality by 2/3. What else about NICE guidelines? They go on to spontaneous labor before inducing them in postterm pregnancy. The non-pharmacological methods such as herbal supplements, acupuncture, hot baths, and other methods, they are not recommending it at all and not using it. Now, the same thing, they shared the same practice with the WHO, in which when inducing women with IUFD, I'll not go through it again, before 28 weeks, misoprostol, and after will be with prostaglandin. And the NICE also do not have any recommendation to induce women with uncomplicated twin pregnancy. Coming to Canada, in Canada they have a different issue or different practice, They do not consider the same thing. They do not consider amniotomy or oxytocin as effective method for cervical ripening. And the methods and indication for induction of labor do not change in the presence of group B Streptococcus colonization. I think the new practice in the Royal College and other guidelines in ACOG, when there is a group B Streptococcus and rupture of membrane, there is an indication and aim to decrease the infection and the NICU admission for the baby. But in Canada, they don't practice the same practice, and they will just do not take it into consideration to terminate this pregnancy or induce this pregnancy. What about the twins? The twins, they just practice just what we are practicing. They will deliver the patients who are uncomplicated twin pregnancy at 38 weeks or onward. They will not leave it beyond that gestational age. Bishop score is 7 or more as a favorable cervix. Now about the Indian society, they have some 5 factors. Recommendation of induction of labor, they do it earlier. They do it at 39 weeks onward in low-risk pregnancies. They don't wait beneath term or post-term. And the Bishop score is different in some way. They will add 1 point for any patient who has preeclampsia or each previous vaginal delivery. For example, a patient has achieved a score of 5. They will add 1 if this patient is a preeclampsia or she has a previous vaginal delivery. Point from post-date or nulliparity or premature rupture membrane. That means if the Bishop score is 7, they will go down to 6. So they take it from there to assess which type or which method of induction of labor. Now, they do not approve the use of Laminaria Tents. I think this is an old practice, although it's still practiced in somewhere in the world, but they do not recommend it. And for some few knowledge about it, it's some sort of cylinder tent that is inserted in the vagina and cervix. It absorbs the moisture in the vagina and then it will dilate. It helps to dilate the cervix. It was used before and it's still practiced in somewhere in the area. What about induction of labor for twins? They go a bit earlier. They go at 37 weeks for uncomplicated twins. And the Bishop score will be 6 for them as a favorable cervix for induction of labor. What about the Royal College? The Royal College have a specific point about the age of the woman. So in women age of 40 and above, they will prefer to prevent stillbirth. In researches or studies that confirm that there is increase in stillbirth about 2/3 in compared to 37 weeks in this specific age of maternity age. There is insufficient evidence regarding the use of laminaria tents and acupuncture or breast stimulation or any other options for induction of labor. And the induction of labor for twins, they also go by 37 weeks and above. Bishop score will be favorable at 7 or more. Now coming to our institute or our organization, King Hamad University Hospital, the physician we have a must that we have to explain the indication for undergoing induction of labor, the associated risk and benefits. And all of that will be done in the clinic while we took the decision for induction of labor. I assume that all of us are practicing the same practice. Induction of labor will be indicated when the benefits of terminating this pregnancy outweighs the risk of continuing it. Such indications will be post-term pregnancy, the most common, and other medical and fetal compromise. There's also a practice there's a place for membrane sweeping. It can be offered to women during vaginal examination by doing massage in the cervix and the vaginal fornix, which can be an alternative to amniotomy. It's not, it can be an alternative. It will help to reduce the number of patients that needed to be induced. Amniotomy is not recommended in our practice, so it is best combined with oxytocin. It will not be done alone. Prostaglandin is recommended for induction of labor for unfavorable cervix, while oxytocin is preferred for favorable cervix. And in KHUH, we do not mention any recommendation in using of misoprostol, mifepristone, or mechanical methods as induction of labor. Now, comparing international guidelines, I'll indicate the areas of improvement that are essential in enhancing patient care during induction of labor at KHUH. Such areas include recommendations on the timing of induction of labor according to the indication, the alternative methods for induction of labor, the proposal to how to manage particular complications associated with induction of labor. The practice of induction of labor in King Hamad must be monitored as well to ensure the practice in our institute consistent with both locally and internationally set guidelines to provide the optimum care to patients. And this must also be frequently audited to confirm that induction labor was indicated for a valid reason. And that's what we are practicing in our hospital. It's being supervised by Prof. Malas, in which we take audits. For example, we took in 2020, in October to March 2021, the number of induction of labor was 169. 127 of them went to normal delivery, and 29 had an elective cesarean section, which means induction of labor failed, and 13 had an emergency cesarean section for any fetal distress or so. So always the aim is to audit so we can see where are we, to monitor more and see where the effects that we have and where to work on to give the optimal care in future. And this systemic review was published, and it has been reviewed, and we're aiming to do now a new induction of labor for premature rupture of preterm rupture of membrane, to see does it outweighs the benefit of waiting for expectant management by enhancing the reduce of admission to NICU and better also for maternity satisfaction. I finished my presentation from my side. If Dr. Malas wants to add any comment or...
Thank you, Dr. Rehab. That was very nice.
Thank you.
Any question, any comments? Induction of labor is a very
Common practice.
very heavy topic. Decision making in these situations sometimes is not easy.
Exactly.
I have a question I would like to share with the audience, and of course with Salam. When do you consider induction of labor has failed? I mean, now we say, look, we're going to induce this patient, give her a Prostin, 1, 2, 3, 4. How many Prostin do you give? When you tell the patient, no, that's it, finish, we're going to consider as failed induction. I mean, I couldn't find any recommendation literature. I mean, the college say that, failed induction is after 1 cycle, which is 2 Prostins. The 2 Prostins, I mean, sometimes might not work, and if you do that, either you're going to cancel it or increase the resection rate. So I'll ask Salam first, and then anyone in the audience can help us.
Thank you. Yes, I had 3-4 cases which failed, and what I do usually, I give prostaglandin or Propis, but prostaglandin vaginal tablets is what I give every 6 hours for 4 doses. If the patient does not respond, I give her a break. I send her home for 48 hours to come back after 48 hours. Sometimes it depends on your judgment how you are going to tackle these failed cases of induction of labor. Usually, majority respond to the vaginal substitutes. I do not induce by oxytocin from the beginning. I think the prostaglandin method is better. But at the end, it's the experience of every one of us how to handle those small percentage of failed of induction. Of course, sometimes if the patient is not willing to wait and chooses C-section, I think Dr. Said.
See, in my practice, or I don't know, everybody, I think the first aim, I think whenever we are planning any patient for induction of labor, so we are planning for her to deliver. Mm-hmm. So the aim is to deliver this patient. So induction of labor, the first aim is to deliver the patient. Second thing, the other thing I think which comes into failed induction or successful induction, you have to select your patient properly. Now, which patient, it cannot be randomly because means it's the doctor's anxiety about the pregnancy that I will induce her to deliver her. It is mainly what is the proper indication for induction of labor. And then the other factor comes, is the Bishop's score patient favorable for induction of labor or not? Because that will tell you if what is your risk of having a failed induction of labor.
Even with these parameters,
There will be some, but it still means whenever I am planning induction of labor, my aim is to deliver this patient. So I will give her that doses. If she doesn't respond, then there should be another alternative. Thank you.
Yeah, I mean, sometimes you find, those patients, let's say, for example, that, the induction of labor for post-date pregnancy, I mean, she's 41 weeks or 41 plus 3, or some people, they do it at 42 weeks, I mean, these are the gray areas, I'm talking about. And of course, I mean, somebody with preeclampsia, for example, or somebody who has, abnormal problem with the baby, that's no doubt about it. I'm talking about, you may afford to wait a little bit, What we usually do in our institute at King Hamad University Hospital, and we give them one cycle, we call it as one cycle, give them one dose of prostaglandin, prostaglandin E2, repeat after 6 hours. If they go into labor or we find that the cervix has ripened, well and good. Otherwise, we give them another cycle the day after, and then, we reassess the whole scenario, the indication, the progress, the patient's what she wants, and then we take it from there. But we usually offer them 2 cycles that over a period of 2 days. Of course, if the indication is not really very, very strong, like post-date pregnancy, we can afford to do like Salam has said, we send her home, bring her back after 48 hours and restart induction. But of course, here is the patient's decision is of paramount importance in those scenarios. I'm talking about those gray areas. I'm not talking about the patient, let's say, for example, she's twins, she's 38 weeks, we have to get her delivered, or she's a preeclampsia, or she's a patient who has recurrent antepartum hemorrhage. I'm not talking about those cases. I'm talking about these gray areas. That's what we do in our institution.
Thank you.
Okay, thank you so much. Okay, now allow me to introduce Dr. Shaima Sayed, who is having graduated from Ain Shams University in Egypt, and then has done her residency in the cardiology department at the Demirdash Hospital. She has her admission board in 2015, and she has interest in congenital heart problems. She is currently working at Al Jazeera Medical Center, in particular in relation to non-invasive cardiac issues. So let's welcome Dr. Shaima.
Good morning, all. Thanks for being in attendance in the morning. I'm happy to be here with you all. Today we will discuss about cardiovascular diseases and its link to infertility. Infertility is a disease of male and female. Just 1 second. The reproductive system problems can cause for the male or female infertility. It is defined as failure achieved of pregnancy after 12 months or more of regular unprotected sexual intercourse. Infertility affects millions of people of reproductive age worldwide and has impact of their families and communities. In male reproductive system, infertility is most commonly caused by problems in ejection system, ejection of the semen or absence of the level of the sperm or abnormal shape, morphology, movement, mobility of the sperm. In the female reproductive system, infertility may be caused by a range of abnormality in ovary, uterus, fallopian tube, endocrinal system, among others. And it can be primary or secondary infertility. Pregnancy has never been achieved by person, and secondary infertility, usually at least one pregnancy has been achieved. Fertility can be encompasses of prevention, diagnosis, treatment of infertility, equal and equitable access of fertility care remain a challenge in most countries, particularly in the low and middle income countries. What causes of infertility? Infertility may be caused by a number of different factors, like in female reproductive system, infertility may be caused by tubal disorder, blocked fallopian tubes, uterine disorders caused by inflammatory such as endometriosis, congenital septate uterus, benign in nature such as fibrosis, and disorders of ovaries like as PCO or follicular disorders of endocrine system, which is imbalance, causes imbalance in reproductive hormones, and endocrinal system like hypothalamic and pituitary gland abnormalities and diseases. And these common disorders affecting this system include pituitary cancers and hypopituitarism. The relative importance of these causes of female infertility may differ from country to country. For example, the difference background for sexually transmitted infectious diseases. In male reproductive system, infertility may be caused by obstruction of the reproductive tract, causing dysfunction in the ejection semen, or hormonal disorders like abnormality of hormone, like in pituitary gland, hypothalamic, hormones of testosterone regulated by sperm production also can controlling it, and example of disorders that result in hormonal imbalance including pituitary or testicular cancers. Testicular failure to produce sperm, for example, due to varicocele, medical treatment that impairs sperm producing cells, such as chemotherapies, abnormal sperm function and the quality, condition, situation, and abnormal shape for morphology and the mobility of the sperm can affect its production. And the environmental lifestyle, like smoking, excessive alcohol intake, obesity, can cause fertility for the men. What is the secondary infertility? It is inability to conceive a child, to carry pregnancy to full term after previously giving birth. To classify as secondary infertility, the previous birth must have occurred without help from fertility medication or treatment, like in vitro fertilization. Secondary infertility typically is diagnosed after trying unsuccessfully to conceive for 6 months per year. A related condition is recurrent pregnancy loss, where patient and couples are able to conceive but are unable to carry a term. Causes of secondary infertility in women can be affected by problems in the quality or quality of the eggs, and problems in the fallopian tubes, problems in the uterus, endometriosis, PCO, breastfeeding, weight gain, or lifestyle habits. Causes of secondary infertility in men, like reduces testosterone level, which is affecting and play key role in sperm production. Testosterone level can decline due to aging, injury to urinary or genital organs, or certain condition. This condition called genital infection, thyroid, diabetes, tuberculosis, mumps, smallpox, blood diseases, benign tumors, emotional myocardial infarction, coma, stroke, respiratory failure, congestive heart failure, burns, sepsis, and surgeries, presence of mycoplasma, which is a type of bacteria, and anesthesia. Testicular varicocele, poor quality semen, prostate enlargement, prostate removal, late onset of hypogonadism, certain drugs after affecting sperm count and the quality, prostate cancer, enlarged prostate, UTIs, ulcerative colitis, arthritis, gout pain, cancer, seizures, schizophrenia. All of these and the excessive weight gain can make decrease of the testosterone level and increase estrogen levels. What are possible signs of secondary infertility? If a man or woman 35 or younger have had unprotected sex for at least 12 months or sex without getting pregnant, they should suspect secondary infertility. This is especially applied to women older than 30 who have experienced pelvic inflammatory diseases, painful periods, irregular menses, miscarriages, and to men with low sperm count. To consolidate the evidence of our topic, it is linked to cardiovascular diseases or no. There is many systematic reviews and meta-analysis investigate association between reproductive factors in women of reproductive age and their subsequent risk factor to the cardiovascular diseases. From menarche to menopause, reproductive factors were associated with cardiovascular diseases in women and men. In these cardiovascular health diseases, as we see in this figure, there is all making like insulin resistance from the patient is obese, fatigue, inability to lose weight, craving of sugar, fatigue after meals, migrating aches, upper abdominal obesity, increased fat storage, high cholesterol and tricuspid levels, hormonal imbalance. This make estrogen dominance and low thyroid levels, and increased fat storage, then PCO and acne, facial hair, and infertility, and all of these make insulin resistance impedance. PCO impact your health in many ways. PCO is a common cause in infertility among women, causing ministerial issues, problems ovulating, and hair loss, insulin issues, acne, even depression. PCO doesn't impact your fertility only, and women with PCO tend to have higher rates of high PP, high cholesterol level, high PP, and the risk factors for the heart disease. PCO goes untreated in the women's health and make some lifestyle change to our patient, it will be successful. There is many papers is conducting for this increasing cardiovascular diseases and the risk association with female infertility caused by conditions such as PCO, obesity, thyroid dysfunction, and endometriosis. One of these papers was interesting, and they make a study. Its method is around the 65 unexplained infertility females, and there is cardiovascular risk markers. They detecting LDL, HDL, total cholesterol, triglycerides, and high sensitive CRP. All of these are assessed. Then the results showing our conclusion in this study is that the women with unexplained infertility had an elevated high sensitive C-reactive protein and suggested for higher risk in developing cardiovascular disease in future. Further studies and the larger investigation linked in this problem. Our treatment for this PCO, beside the gynecological treatment, we give them the hint of nutrition therapy. Nutrition is the main issue for these PCOS females. Avoid sugars and avoid unlimited salt, fat brown rice, fat fruits, eat more fruits and vegetables. All of these can help them to decrease weight and decrease insulin resistance and increase their hormonal consumption, and this is all decrease the atherogenic lipid and triglyceride cholesterol impeding in the coronary vessels, which impact their cardiovascular disease. There is also another study problem associated with IVF therapy. If the female, trying to conceive by IVF therapy, there is problems to cardiovascular diseases. There is a paper is published in June 2020 showing cardiovascular problems associated with IVF therapy. They discovered that there is some cerebral and vascular events and heart failure following fertility therapy failure, and which is very complex mechanism. One potential mechanism is direct activation of RAS system, renin-angiotensin system, with ovarian hyperstimulation, which influence systemic vascular permeability, sodium balance, and blood pressure. Fluid shaft may result in depletion of the intravascular volume and interstitial edema that mediate ischemic stroke, heart failure, and venothrombotic factor. Whether these cardiovascular events could be prevented by long-term RAS inhibitor therapy is a topic for future more researchers, although some short-term success has been described for early adverse effects of ovarian hyperstimulation. Additional potential options to protect against thromboembolic may be control the risk factors or prophylactic antiplatelet therapy. In contrast, and observed decrease coronary heart disease and following fertility therapy failure appears inconsistent with hypothesis that endothelial dysfunction may already present in women at risk of miscarriage and may become accentuated by fertility therapy failure. It was recently found that there is a 7-fold increase in the incidence of pulmonary embolism during the first trimester and in IVF pregnancy as compared to spontaneous cause of maternal mortality, and is thus most important to understand pathophysiological mechanism for this disease. The estrogen surge during the ovarian stimulation has been hypothesized to be in the initiating pathophysiology event for PE. Fertility therapy failure also common and was associated with increased risk adverse cardiovascular events. Yes, there is many papers also about this topic. Largest relative increase with the heart failure and cerebrovascular events. Overall higher relative risk of cardiovascular events associated with fertility therapy failure and observed in diverse demographic subgroups irrespective of the number of fertility treatment cycles and regardless of whether diagnosis was primary and secondary infertility. The increased risk was particularly high among women with a prior miscarriage. The absolute risk was modest and mostly confined to the first 5 years following fertility therapy. Mechanism may be underlying our finding and suggested by past studies linked to fertility therapy, ovarian hyperstimulation, and vascular complications. This is another study and research about heart failure of the fertility therapy and subsequent adverse cardiovascular events. The background of this study was indicating underlying predisposition toward premature cardiovascular disease and little known about potential long-term cardiovascular events following fertility therapy. They investigated the fertility failure, and there is other short-term and long-term cardiovascular effect related to IVF, gestational hypertension, preeclampsia have been reported to increase during IVF pregnancy. That is could be related to absence of corpus luteum in some pregnancies. Corpus luteum is formed from the remaining of the ovarian follicle after the release of an oocyte. Corpus luteum produces hormones such as progesterone and estrogen until these will be provided by the placenta. An interesting hormone in this respect reduced by the corpus luteum is relaxin, which has many effects, including activation of nitric oxide pathway and the relaxation of smooth muscle cells with dilatation of systemic resistant arteries. There is a paucity of studies concerning long-term effect of IVF on cardiovascular safety, and there is heterogeneity of few existing studies precludes that the final conclusion, but a trend toward a higher incidence of stroke might be exist. For health issues. So if there is infertility, we should investigate the patient carefully for other hormonal issues and for cardiovascular, premature cardiovascular events, stroke, PE, and coronary artery disease, hyperlipidemic, atherogenic lipid profile. All of these are red flag for us is for infertility. So studies have not shown that infertility or treatment for infertility causes heart disease. Instead, infertility can act as a canary in the coal mine for future health issues. Men and women struggling with infertility face an increased risk for developing chronic condition later in life. Men in particular face a greater risk for developing diabetes, heart disease, subsequent of abuse problems, and also infertility. This is the end of my topic that was interesting topic to me in the usually the gynecology and problems and obstetric problems usually is away from the cardiovascular system, but it was interesting to read more about these articles, and I found many of terms of gynecology and like corpus luteum, all of these hormonal, it is away along mind, not reminding it, so it was very interesting to me. Any questions?
Thank you, Dr. Shaima.
Thank you, Doctor.
Yeah, Dr. Fadila, please.
Thank you, Doctor.
Just a second.
Sound?
Dr. Fadila, 1 minute.
Thank you very much, Dr. Shaima, for the interesting presentation. In your study, you have mentioned, the presentation and the study, you mentioned that the IVF have a risk of 7-fold of pulmonary embolism, but you did not mention if the patient being covered under anticoagulant, which is usually the reproductive medicine specialist give this. Just clarify this point, please. Thank you.
According to this study, it is uncovered by antiplatelet therapy or anticoagulation. They just prove that there is a role in the platelet function disturbance during IVF therapy. And it is better to cover the patient by antiplatelet and anticoagulations.
Yeah, because I think now it is a practice. Maybe Dr.
Yes, because
Salam
I don't know the
can answer
practice.
this, yeah.
I have too many comments on
Yes.
the talk, all of it. Anyway, very important in infertility treatment, those patients, we screen them for thrombophilia.
Yes.
And you haven't mentioned anything about thrombophilia. The patients who are having ovarian hyperstimulation, I haven't seen any of them having any risk, because the protocol for those who are having even moderate type of ovarian hyperstimulation is to have anticoagulants in 2 forms even, not only the Clexane, which we are giving, the fractionated heparin, we are now giving them the aspirin, pediatric aspirin, the small tablet, in addition to the Clexane. Talking about the hyperstimulation as a risk, now we are having different protocols to minimize this by less triggering of those cases who are under stimulation. The guidelines now is very clear how much to give, and the infertility treatment juniors, let me say, are abiding to these protocols and guidelines. I haven't come across any patient who was fully investigated that they are having a high risk. I remember one of my patients who is an IVF patient. I did C-section for her at time of birth, and her recovery from anesthesia was difficult, And when we have echo for her heart, they told me that she is borderline cardiac myopathy. She should have been investigated earlier than that. The problem is that nobody dared to speak to her because she was the wife of a prime minister. At that time, everybody was telling her, you are fine, you are fine, you are fine. But those medications, even the hormones, are not bringing females to be a high-risk category of cardiovascular disease. I disagree with the Turkish study. I have to read it first before passing my final judgment about the cardiovascular diseases as a consequence of infertility treatment.
I think all of
Mind
this
you-
study, I wanted to comment this. Cardiovascular view, not from the IVF therapy view, they are finding what is the problems that found during IVF therapy, and they should investigate and study it. I think this is the article upon it, that there is maybe recurrent VTE complications or cardiomyopathies, as you said. But what is the cause for the cardiomyopathy with this patient? Maybe previous, before IVF? Or peripheral?
She had previously had no full investigations of her cardiovascular, and when she had anesthesia, she couldn't recover fully from the anesthesia.
Yeah, I mean, thank you for your presentation. I think, I mean, it's very important, before saying that, the treatment or the infertility is associated. I mean, we don't know the characteristics of patients. I mean, or take about the patient in their 30s, or take about young women. I mean, we have to be specific about, the population we are diagnosing. And then, regarding like Salam has done, post-delivery cardiomyopathy it can come on its own. I mean, she doesn't need to be beforehand having an issue. That happened after delivery. So I mean, these issues, I think, of course, we have to be careful about, those patients. But as Salam has said, we do investigate those patients are at increased risk of thrombosis. Those who have recurrent miscarriages or old age, we do check their thrombophilia, and if needed, so we give them the anticoagulation therapy. Thank you so much.
Thank you. But my question to you, doctor, about the aspirin and the anticoagulation like Lexan. When you start with the IVF patient?
When do I start?
Yeah.
When we see the fetal heart.
From?
When we see the fetal heart, we start Clexane.
Okay.
If they are hyperstimulated cases, we start them from the day of pickup. When we take the eggs out, we start immediately.
Great. And this is along the pregnancy till delivery?
If they are thrombophilia, yes. If they are antiphospholipids, yes. We have to, not only pregnancy, 6 weeks after delivery even.
Yes.
6 weeks, very important.
Yeah,
6 weeks.
Pericardium period, around about 6 months.
Yes.
Yes. Thank you for this informative topic and discussion. If there is any more question, I'm ready. Thank you all.
Thank you, Dr.
Thank you,
Shaima.
Doctor.
Thank you very much. Next, it gives me pleasure to introduce Dr. Sarah Faour. Sarah is one of the youngest IVF, new generation. She's enthusiastic, and I predict she will be very good in the assisted reproduction technology field. Dr. Sarah graduated from American University of Beirut as a medical doctor in 2010. She then continued her 4 years specialization in obs and gynae at AUB and graduated in 2014. She continued 2 years fellowship in infertility and reproductive endocrinology as well, in the same place, AUB, and finished that in 2016. She was highly respected by her peers for the high ethics and standards in patient care. I agree totally with this. Dr. Faour was involved during her training in several types of research and has lectured previously. She was with us in MAC1 as well, at several local and international meetings. Currently, she's working in Royal Hospital for Women and Children. And I'm all ears to hear what Sarah is going to tell us. Please, Dr. Sarah.
Thank you so much for this lovely introduction. It gives me an honor to be here today. So today I'm going to be talking about the role of metformin in PCOS patients. As we all know that metformin is an insulin response sensitizer that has been an important drug for the treatment of diabetes since the 1950s, being one of the most widely prescribed anti-hyperglycemic compounds. And around 15 years ago, it was reported that insulin resistance was abnormally high in most PCOS patients. So starting from that moment on, increasing numbers of studies were performed to demonstrate the efficacy of metformin in controlling the several aspects of PCOS. So where do we stand now, and what does the evidence tell us about the role of metformin in PCOS patients? So as a general introduction, we know that PCOS is a state where we have an increase in insulin resistance, and this affects the body in different ways. And the central mechanism, we know that we have an abnormal LH pulsatility, and we know that in the peripheral mechanism, the liver will start it will start decreasing the sex hormone binding globulin synthesis, leading to an increase in the free androgen. The adrenal gland also will have an increase in the androgen production. Also in the ovary, we do have from the theca cells an increase in the LH-mediated androgen production, also affecting the granulosa cells, leading to an antral follicular arrest and amenorrhea. And we know, on the other hand, that metformin acts by increasing insulin sensitivity, decreasing hyperinsulinemia, possibly regulating the LH secretion from the brain, leading the liver to increase the sex hormone binding globulin, decreasing the free androgen, the adrenals to decrease the androgen, and also affecting the ovary to decrease the androgen production, decreasing estrogen production, which will lead to a better menstrual pattern and a decrease in the infertility. The first study actually that was published about metformin therapy in PCOS was in 1994, and the aim of the study was to assess if metformin would ameliorate the metabolic abnormalities of PCO patients like hyperinsulinemia, blood pressure, and hyperandrogenemia. And it was found incidentally that actually patients who had an amelioration in these metabolic abnormalities, 12% of them had spontaneous pregnancies. So from that moment on, many trials were set up to test metformin as a treatment in women with PCOS. And in our region, we know that PCOS is very common, so it is very important to update our knowledge on metformin in PCOS patients to help us in our clinical practice. So in this presentation, I'm going to go over the use of metformin for oligomenorrhea or amenorrhea, for hirsutism as an ovulation induction agent, for IVF pretreatment, and to prevent the pregnancy complications associated with PCOS. So to start with oligomenorrhea, we know that most of the patients we do see in GYN clinic, they present with PCOS, present with oligomenorrhea or amenorrhea. So we know that the first-line treatment is actually OCP because they decrease the LH secretion, they increase the sex hormone binding globulin, they decrease the adrenal androgen secretion, leading to regular withdrawal bleeding and the prevention of endometrial hyperplasia. But when studies were done comparing, when studies were done comparing metformin to placebo, I'm very sorry. Okay, so when studies were done comparing metformin effect on PCOS patients with placebo, it was 23 subjects were included, and it was found that yes, metformin patients have a better amelioration in their menstruation, and actually out of patients who had who had regular cycles on metformin, only 80% of them were actually shown to be ovulatory. But comparing metformin to placebo, yes, metformin treatment was shown to reduce hyperinsulinemia, reduce hyperandrogenemia, and it was shown to lead to an amelioration in the menstrual cycle. But when a meta-analysis was done to compare metformin to OCP concerning the hyperandrogenism and the menstrual pattern in PCOS patients, it was found that metformin was less effective in improving menstrual patterns. For amenorrheic patients, it was shown that for BMI less than 25, metformin was less effective in improving menstrual pattern, and for the higher BMI, there was no statistical significant benefit of using metformin. So up till now, still OCP is the first line for the treatment of irregular cycles in PCOS patients. But for patients who have a contraindication to OCP, then metformin might play a role in association with progesterone for the first 6 months. For hirsutism and acne, also using the same Cochrane review, it was also shown that there was no statistical significant benefit whether metformin or OCP was used in patients who have a BMI less than 25 or a BMI more than 30. And for the range of BMI between 25 and 30, it was shown that metformin is less effective in improving hirsutism. And patients who took metformin had a higher GI side effect. And also for the acne, there was no benefit. So we can conclude that metformin doesn't really play a role in the treatment of hirsutism or acne. And for the amenorrhea, it's better still to go with the OCP. Now, what about ovulation induction? 80% of PCOS patients suffer from anovulatory infertility. And usually the first-line treatment for these patients is to give ovulation induction agents. So where does metformin stand in all of this? According to the ASRM, according to their published guideline, metformin alone should not be used as a first-line therapy for anovulation because the oral ovulation induction agents such as Clomid and Femara or letrozole are much more effective in increasing ovulation, pregnancy, and live birth rate in women with PCOS. There was a Cochrane review about metformin for ovulation induction that was published in 2019. And it showed that when comparing metformin to placebo, yes, metformin may improve live birth rate when compared to placebo. But when comparing actually the use of metformin to Clomid, it was shown that when we combine all the studies together, there was no benefit of metformin versus placebo. But when we divide them comparing to their BMI, in obese women with a BMI more than 30, metformin was shown to have a lower live birth rate. In the non-obese group, there was a possible benefit of giving metformin alone, but it's worth mentioning that you can see that the I-square is 78%, so there's a high heterogeneity and a low quality evidence in this group of patients. When comparing adding metformin to Clomid versus giving Clomid alone, also it was shown that metformin didn't offer a significant benefit. So as a conclusion, metformin may be beneficial over placebo, but still giving Clomid or letrozole are superior than giving metformin alone, and there was not much more benefit of giving metformin in addition to Clomid, and patients who took this had a higher GI side effect. So as a conclusion, letrozole and Clomid are more effective than metformin for live birth rate for ovulation induction. Now, what about IVF pre-treatment? Up until today, the most challenging part in actually inducing, putting PCOS patients through IVF is the risk of OHSS. And, I'm sorry, one second. And it was shown that there's several possible mechanism that could explain why giving metformin might prevent OHSS. Metformin will significantly lower the intra-ovarian and androgen concentration. It will reduce the estradiol blood concentration at the day of ACG application without really influencing the number of the obtained oocytes. It improves the endothelial function in women with PCOS. It reduces the soluble vascular adhesion molecule and soluble intercellular adhesion molecule that are main factors in the OHSS cycle. It decreases blood glucose, giving glucose, we know that it increases the vascular endothelial growth factor, which is also part of the OHSS. It plays an antithrombotic effect in patients with metabolic syndrome, and it reduces the follicle entry and the smaller follicular size range, which we know that puts the patient at the risk of OHSS. So would giving metformin as a pre-treatment in IVF in PCOS patients is beneficial in decreasing OHSS, and would it influence the live birth rate? There was a review in 2020 about metformin treatment before and during IVF in women with PCOS. 13 RCTs were included involving around more than 1,000 PCOS patients, and the data was stratified according to what protocol the patients received. If they received the long GnRH agonist or the short GnRH antagonist protocol. And it was shown in the long protocol, the long GnRH agonist protocol, it was shown that metformin, there wasn't a statistical significant benefit on the live birth rate when metformin was given. For the clinical pregnancy rate, there was a possible benefit of giving metformin. There was only one study that used the short protocol antagonist and reported live birth rate. And surprisingly, it was shown that metformin may reduce live birth rate in this group of patients. When talking about OHSS, when we look at the long agonist group, it was shown that metformin reduces the incidence of OHSS in patients who received the long protocol, but for the short protocol, there was really no benefit of giving metformin on OHSS rate. So they concluded that there is no conclusive evidence that metformin improves live birth rate. Possibly clinical pregnancy rate was improved in the long protocol, but for the short protocol, we had a decrease in live birth rate with no benefit of OHSS. I'm going to talk more about the study of the antagonist because nowadays rare are the doctors who use a long protocol on a PCOS patients. Most of us, we go for the antagonist protocol, so it's interesting to look more into details into the study. So this was a randomized placebo-controlled trial. And all the patients that were included met the Rotterdam criteria for the PCOS, and the study medication, which is the metformin, it was started prior to stimulation and continued until oocyte retrieval. So it's important to know that these patients took around 17 days of metformin. And as we said before, it was shown that there's no difference in the incidence of OHSS, whether the mild, the moderate, or the severe OHSS. And it was shown that the clinical pregnancy rate and the live birth rate were decreased in the patients who received metformin. But it's important to mention that had metformin been used for a longer duration of time before giving GnRH, before starting the gonadotropin stimulation, would a different outcome have been occurred concerning the live birth rate? Because there was a study in 2006 that was published by Doldy et al., and it showed that when he gave metformin for 2 months, actually there was a significant reduction in the OHSS in favor of metformin. So maybe this study did not show a benefit in decreasing OHSS because we had a shorter duration of administering metformin. Maybe if they gave metformin for a longer period of time, this would have allowed a cohort of follicle to develop without the stimulatory effect of insulin. And we do know that it takes 3 months from primary follicle to the entire stages of follicle development. So a long use of metformin would actually help us to replace this current cohort with a normalized insulin-driven cohort. And we do know that there's a difference between the LH suppression, whether we give an agonist or an antagonist protocol. So also this might play a role in the need of giving metformin for a longer duration of time before starting an antagonist protocol. So this study does not support the use of metformin and antagonist cycle to treat women with PCOS. There was no reduction on HSS, and there's actually a rather puzzling outcome of a reduced clinical pregnancy rate and live birth rate that is not explained in any scientific way. So they said that this might be explained by chance rather than a true effect of metformin. But still, according to the ISHRE, the routine use of adjuvant metformin before and or during ovarian stimulation is not recommended with the GnRH antagonist protocol for women with PCOS. Now, what about the prevention of pregnancy complication? We know that PCOS are at higher risk of spontaneous abortion and at a high risk of gestational diabetes. PCOS, like we said, are at a high risk of recurrent abortion due to the whole insulin resistance state that we're in, and metformin might help by having a better insulin sensitivity and a lower androgen level. So many studies were actually done on this. The first study was shown that, yes, metformin therapy during pregnancy in women with PCOS was safely associated with a reduction in spontaneous abortion, and it was not teratogenic. But then, later on, a review in 2009 was published, and it concluded that overall there's no effect of the metformin administration on the abortion risk, and it was not statistically significant that metformin does decrease the abortion risk. Another also review published in 2020, a Cochrane review, showed that no, metformin does not have any statistical significant benefit on the miscarriage rate for women, and women who took metformin had a higher side effects than other women. Same for the gestational diabetes. A review done in 2016 showed that the incidence of gestational diabetes were not significantly different in groups who received metformin versus those who did not. But then also studies afterwards showed that metformin was associated with a less frequent gestational diabetes mellitus than patients who had a controlled diet. And then other RCTs showed that no, it was not associated with a benefit. So we can conclude really that metformin is still a gray area in literature. It's a lot of studies that are included are of low quality of evidence, and still there's a lot of ongoing research about it. But if we want to do just a rough conclusion that for oligomenorrhea, OCP is still the first line, except in patients who have a contraindication to OCP, then metformin might play a role in regulating our cycles. Hyperandrogenic symptoms and acne, OCP doesn't really play a role. For infertility, ovulation induction for PCOS patients, the first line is still with letrozole. Not a lot of benefit in adding metformin to Femara or to Clomid. There's no benefit of pre-treatment with metformin concerning the success rate, and uncertain results whether it is beneficial for the OHSS. For decreasing pregnancy complication, also still a lot of question marks whether it's beneficial, yes or no. So thank you for your time and for listening, and I would be happy to answer any questions.
Thank you, Dr. Sarah. That's very interesting. One comment, I have seen many patients coming to me all the time were given metformin because they are polycystic ovary and they have no symptoms or do not belong to the group of
PCOS.
Polycystic ovary
100%.
syndrome.
This is what triggered me actually to do this presentation, because I see a lot of patients who only have an ultrasound polycystic ovaries, and they are given metformin, whether to take treatment or not, and even in pregnancy.
Even diagnosing by only ultrasound had a long debate in ISHRE, very long debate. The last to be accepted was the polycystic ovary ultrasound appearance. And I agree 100%. If you want to use metformin for PCOS patients, at least it should be given 6 months before they try.
Yes.
Nowadays, all of us are going in favor with antagonist protocol for induction of PCOS, and that's the best way to avoid ovarian hyperstimulation, because you will trigger with agonist.
Of course.
And that's one other reason not to give them metformin, hoping that this will change something in the ovarian hyperstimulation.
100%, I fully agree, yeah.
Any question, please?
Thanks so much, Dr. Sarah, for your presentation. Just a question. I mean, is there any difference in the way that you give metformin, whether you give it 3 times a day or you give it the long-acting? Does it make any difference at all in across your studies or your readings?
Personally, I don't give much metformin in the clinic due to this, but according to the studies, there was different doses given in the different studies. So it wasn't only one study given 750 once per day or 2 twice per day. So studies differed, and this is why, as you can see, there's a big difference in heterogeneity in the studies, and also what they rate as low quality evidence, because not all of them gave the same dose of metformin. It was different dosage. But I don't know if, Dr. Salam, from your clinical practice, it makes a difference whether you give once or twice. It doesn't make a difference.
It depends on their body mass index, actually. First of all, I do not prescribe metformin unless I have tested their fasting insulin. If their fasting insulin is high, I encourage them. With family history, sometimes it's very important to have a family history of diabetes as well. But usually I start giving them a dose in the evening so that if they have any side effects or about to have side effects, they wouldn't notice it while they are asleep.
Yeah.
And if they tolerate it,
You increase.
and I start with 750, nothing more than 750 or 500, depending on individualized cases. Yeah. Still, this metformin treatment with PCOS, still the whole subject is gray.
Yes.
The whole subject is still gray.
Yes.
Yeah. Please, Dr. Sina. Dr. Sina.
Always when we do the insulin resistance test for PCO patients, we always find it normal. So what is the rule of the test, and what is the rule of starting the metformin if the patient is having normal fasting insulin?
You find it normal, the insulin resistance?
Most of the cases, we have the ultrasonic signs and the laboratory signs of PCO. But when we do the fasting insulin test, we find it normal.
What do you mean, the laboratory sign? This is the issue, I think, that he was talking about.
The hormonal tests. The hormonal
I think this is the issue, that we do
Yes.
have an overdiagnosis of PCOS patients
because
here.
we see many of the doctors, starting the metformin right and left.
Yes, 100%.
Without full assessment.
Yeah,
of
having polycystic ovary looking on ultrasound without irregular
It's not
cycles.
diagnostic.
Yes, so maybe that might be the reason why insulin, because in true PCOS patients, we do have an increase in insulin resistance, personally in most of the patients that we test for. But you asked me, when do we start metformin? According to all the studies, actually, I don't know how much there's benefit in starting metformin in PCOS patients, whether for regulating their cycles or for their acne or for their fertility issue. There's no really guideline when to start, yes or no. I agree with the fact that if they have abnormal sugar level, if they have a family history of diabetes, maybe then it would be beneficial to give metformin. But as a guideline when to start it, we don't even have enough evidence studies to say that it's beneficial. You know what I mean?
Excuse me, I have a question. Apart from diagnosing, overdiagnosis of PCOS, sometimes there is a patient, they are slim, and they met the criteria of diagnosing PCOS. They have typical, they met 2 out of 3, but they are not overweight. They're totally, BMI is normal, but they diagnosed and they are PCOS. Those patients doesn't have they are not overweight, so they are not prone to have insulin resistance. And even the level of blood sugar is normal, insulin level is normal. So those PCOS patients who are not overweight or obese, do you recommend to start metformin for other than for all the benefit that you mentioned?
Actually, in the studies that we saw, the only possible benefit of metformin was in this group of patients who met the Rotterdam criteria for PCOS and who were thin, so not obese. But still, as they said, this was very low quality of evidence of the studies. So for me, actually, a patient who comes and wants to get pregnant, I wouldn't give her metformin and tell her go home and come back in 6 months. I believe it's a waste of her time. If you really want to go by the guidelines, then it's better to start actively with the Femara or the Clomid. And for regulating the cycles, also OCP, if she doesn't have a contraindication to OCP is a better route. But still, in this small group of patients, if you want to give metformin, by studies there's a possible benefit, yes, of starting giving metformin only in this category of patients.
One comment added. You have to ask the patient if she has a strong family history of diabetes. Otherwise, lean PCOS patients, do not give them metformin. They will have a clear, quick side effects of the medication.
Yeah, and yes, apart from that, endocrinologists, they recommend in one of the studies.
Endocrinologists are different from,
I know,
from
and
gynecologists.
No, I know, but they said that in PCOS, if
Yes.
they are not prone to or have a high insulin resistance, it's not necessarily to give metformin.
Yes, I
And
think it depends on the
they talk about the
HbA1c.
minimal dose. They said even 500 will not work on that. The minimum of 1,000 per day.
Yeah,
This is according to their recommendation, but I know it's...
Dr. Fadila, please.
Thank you very much for interesting presentation. I have one question regarding the polycystic ovarian disease with the use of Ozempic, which is now well known in the market, and even by the endocrinologists, they use it for a patient who have impaired sugar profile and obesity. Is there any studies comparing the effect of Ozempic, the semaglutide, with the polycystic ovarian disease? Thank you.
That's an interesting question, actually, but I really haven't looked in the studies to compare Ozempic. I know it's a trend now. A lot of patients are using Ozempic to lose weight or to regulate, but I have to look it up for you. I haven't actually looked at metformin compared to Ozempic.
Dr. Salam?
Wallahi, this is a new trend, the Ozempic and all these medications. And actually, patients are using this to reduce their weight.
More than insulin.
Those patients who are polycystic ovary syndrome, they are trying their best to lose weight because we insist that they should lose weight as first line of treatment for them. The Ozempic is still very recent compared with the other categories. From the meetings I have attended, still there is a place for use of these Ozempic and other types for polycystic ovary syndrome patients. The problem is that once they stop it, they go back to their high body mass index. So what's the use?
Yeah, because they use it for long, they can use it even more than 2-3 years or even all over their life. I searched in the literature, there is one study which comparing using the Ozempic for a patient with the polycystic ovarian disease. It's improving and reducing weight and normalizing their sugar profile. So it have maybe more or less effect like the metformin.
I think this is premature judgment. We cannot conclude anything. These medications are still very recent. The experimental part of it is just 3-4 years ago. So we have to wait some more time to see the effect of Ozempic and other group of same medications in the use of reducing the body mass of polycystic ovary syndrome cases.
Okay, thank you.
I wanted to comment about this because I have many patients on Ozempic, Victoza. It's proven to have a role and a very beneficial role in cardiovascular disease and mortality. This is a primary endpoint of these medications. They lose weight and they protect it from cardiovascular diseases. And it's only once weekly and decrease the weight. But we can do study with Dr. Fadila about PCO patient on Ozempic, and we can run, inshallah. Okay, thank you.
Thank you. Thank you. Yes, Dr. Christina, please.
No, okay.
Any data regarding the long-term effect of the kids, of those moms?
Yeah,
who
they were on the mom or on the kids, you mean?
No, on the kids.
There was a study that actually followed the kids 3 months and 6 months after birth, and there was no teratogenic or any effect on the kids if they took metformin during the pregnancy.
Because now there are studies regarding the epigenetic effects of metformin on long term. So my question was, if you have a patient with metformin that it's coming to you and she's pregnant, will you keep her on metformin all the pregnancy? Because now there are data saying that on long term, the outcome for the babies is not the one that we expected. So they have, because the metformin, it's regulating the way in which the gluconeogenesis is happening in the liver, and a fetus exposed for long term to metformin in utero will have then high risk for obesity. And there are kids who are born from moms who had metformin long term. They are macrosome actually, and on life they have high risk for obesity. And there are some studies now saying that male fetuses, they have risk for subfertility and even high risk for testicular cancer.
Okay, from the ones I saw, it was followed up until 6 months, and they didn't. It was mentioned that it was not teratogenic and it's safe. But you asked me what I do. I usually, patients who come pregnant on glucophage, I stop it at 12 weeks. I don't continue it because we don't have enough benefit, enough studies to push to continue it throughout the pregnancy, and to say even the ones on gestational diabetes, gray area. So everything is gray area. But patients who come pregnant already, then I wait just until the first trimester and I stop it. But this is not proven by guidelines. This is my own practice, because as we saw also in guidelines, we don't know if it's beneficial. So personally, I don't give metformin. I rarely give metformin to any PCOS patients.
Thank you so much.
Yes, Dana.
Any more questions? Yes, please.
Actually, metformin is a chemical medicine, and metformin, I think, is the most used medicine in terms of weight loss. So I've seen PCOS patients. I have seen PCOS patients who are trying to lose their weight. I agree with Dr. Salam that patients with PCOS, overweight and obese, should lose weight for insulin sensitivity. But is there really a study that says that it really helps with weight loss? Because it's really true, when they do the ultrasound, the doctor diagnosed it's not really diagnosed as PCOS, but the doctors say you have a PCOS, you have started metformin, 750, 1,000, they go on long acting, they go 3 times a day. But do they really lose weight from it? Metformin?
I don't know, correct me if I'm wrong. I know that in general, metformin was shown when given correctly to the correct group of patients that it might help in losing maximum up to 4 kilos. This is the study that I know. But in general, whether it really helps in losing weight, and studies on PCOS that metformin helps lose weight, I'm not sure there's anything like this.
This is, some patients believe that it is from the metformin. Actually, changing lifestyle is the one which makes them lose weight.
Yeah.
Please.
I think I do agree that, the metformin, particularly in obese patients, obese polycystic ovary patients, that they do not contemplate to get pregnant. They find difficulties in losing weight. There's a lot of evidence to say that, yes, metformin does affect the BMI. Particularly, this is why I was asking about, how to use it, because if you use it the way that the dosage and how to use it, the evidence is to use it, as 500 milligrams 3 times daily, definitely reduces weight. And I use it with my patients who are not contemplating pregnancy, those, still unmarried, they're coming, they cannot lose their weight, When I give them the metformin, definitely they do lose weight. But, it depends how the dose, how you use it. 3 times a day, in obese patient. Of course, I mean, don't give it to somebody with BMI of 45 or something. We're talking about a BMI between 30 to 35. This is where it works. So you have to pick up your patient so you can find that, the metformin in such dose does help.
Okay.
Any more questions, comment?
No. Thank you.
Dr.
Thank you
Sarah.
so much.
Thank you very much. Yes, yes, please.
Thank you very much, Dr. Sarah. I was not attending from the beginning. Just commend Dr. Salam is regarding physician and rheumatologist, not the endocrinologist. But one of the very important conditions which we pass through is metabolic syndrome, which is very related to polycystic ovary syndrome. And the main concern and pathogenesis regarding this condition is about the insulin resistance, which will come regarding the metformin role. Because metformin also one of the evidently based, very important for cardiovascular risk and for this insulin resistance to minimize it. So some of the doctors and physicians and endocrinologists also, they are using it in a very low BMI sometimes, which is around 19 or 18, especially in non-pregnant ladies. And currently they're using it because the teratogenic effect, previously they thought it's there, but now at least they can using it in a very low dosages. The most important is, for example, one of our very important medication is Methotrexate. It's confirmed high risk, teratogenic, but it depends on the patient genetic predisposition, liver status, as well as how they circulate the medicine in the blood and the coenzymes which are acting on it. Many patients has been pregnant while they're using methotrexate and they forget to stop it, and there is nothing happen, no teratogenic effect, huge numbers. In one of the studies we did it in South Africa, a lot of patients went through pregnancy while they're using methotrexate. So metformin effect, it depends on the genetic predisposition, but the main use why we're using metformin is the insulin resistance and the glucose tolerance problems regarding this condition.
Thank you. Fine.
Okay.
No more?
I was expecting a comment from you. Anyway, thank you, Dr. Sarah.
Well, now allow me to present my very dear friend, Prof. Salam, who has been graduated. First of all, he's a very well-known figure inside in Bahrain. He was graduated from University of Jordan. He got his Fachart from Germany, and then his doctoral degree from Kiel. He has vast experience in the Gulf area, and he has not only vast experience in general obstetrics and gynecology, but in particularly in infertility. It gives me a great pleasure to present you to you, and he's going to present the effect of PGTA. Welcome, Dr. Salam.
Thank you, Professor Hosni. Thank you very much. I would like to thank first the organizing committee for allowing me to participate and see all my colleagues in the meeting. I think in the next 50 years, two topics will prevail: genetics and the one for the preterm labor is the artificial womb. I think the investigations now are going very fast in these two fields, and there are many things which we did not expect it will be present, like the NIPT, for example, which have changed our practice. We were doing many amniocentesis, and nowadays I haven't done amniocentesis for the last 7-8 years, maybe. The last one was the patient was insisting on having amniocentesis, and I told her, you can do an IPT first, but at that time it was very expensive. Anyway, there are many which way we should go? Okay. Many of IVF cases nowadays are asking, before putting back the embryos, they want to know, is this a healthy baby? Can we have the embryos tested? And I will talk about our work. There is still a group of cases which we did not finish during the COVID crisis the last 2 years. We are going to collect all the data because now the data is good and significant so that we can publish. Of course, I started doing some genetic studies for patients when I started working in BSH in 2006. I started there. 2008, we had our first genetic testing. We used to send the cases to SAD Hospital to screen for the genetic diseases. And of course, single gene disorders like the sickle cell disease and thalassemia came after that, and patients were asking if they can do the testing and avoid having infected babies. Okay, the study group started, we started collecting the cases from 2018, and out of 996 IVF cycles, 209, which is about 1/5 of the cases, had genetic testing during that time period. Out of 8,235 embryos, 1,416, 17%, 18% almost of the embryos had genetic testing. I will talk about the different types of genetic testing, but I will focus on PGTA. Of course, a total of the 1,374 embryos tested, we used first to do what's called multivision, which are the 5 chromosomes, aneuploidy screening by using FISH analysis. Later came the 24 chromosomes, pre-implantation genetic testing, PGTA, and of course, PGTA for aneuploidies using the PGTA via PGTA AI2 technology platform we used lately with Cooper's, and still we are using the PGTA regular one, whether on day 3 testing or on day 5. Sometimes we do biopsy for the embryos on day 3, and if we fail to detect any healthy embryo and continue observing the embryos till day 5, we do trophoectoderm biopsy, and we had something like 8-9 cases where the first biopsy was negative, second biopsy trophoplastic testing were normal, and we transferred this single embryo, and luckily, I think 8 out of 9 were pregnant, single embryo transfer, which I'm encouraging nowadays, single embryo only. Also, we have 87 embryos who were tested for BGTM, which is single or monogenic disorders. And you see in the first, we have the 5 chromosome aneuploidy by fish. We have 105 cases, and the 24 chromosome PGS with next sequencing, we had 82. We had 9 with BGTA via BGT-AI2 technology, and we have 13 with BGTM. As you see, in the first group, we had 677 embryos tested, the same with the BGTA PGS on day 3 or day 5, and the advanced PGTA via BGTA-I2, we have only small percentage. Now I think the number has increased to more than 100. And we have the BGTM, 87 embryos at that time. Now we have 154 cases, which make the number of embryos exceeding 300 embryo. In the first group, of course, as you see, 50% were tested with fish, 39 were tested with PGS, day 3, and 5% BGTM for monogenic disorders, and 6% were with BGTA on day 5. Why we are choosing day 3? Because it gives the patient a chance. Within 36 hours, we got the result of the lab, and we can do fresh transfer. For those cases who are at risk of ovarian hyperstimulation, we freeze all, and then we can test on day 5 with trophoectoderm cells, and that's more accurate and precise. The average age for patients was 36.8 years. Those above 35 constitute 2/3 of the cases, and those above 40, almost 1/3 of the case. And this is the age distribution of all cases. The drop lines around the 33, the number 33, I think comes from the calculating the date, the birth date of the patients only. And this is the different categories of the tested embryos according to the age of the patients. And as you see, the number of aneuploidy increases with age, and the presence of aneuploidy as well. If we go to the late 40s, we will see that the percentage of the aneuploidy embryos are higher. On the other hand, the euploidy, the healthy, normal embryos are with the younger age. You can see on the 25th year of age, almost 100% of the embryos were normal or euploidy. And these are the different genetic types. The value of doing BGTA via BGTA-I2 is that you can check on mosaicism, and with mosaicism, you can transfer some of those embryos if the lab tells you that they are fit for transfer. These are the 4 different categories, 4 different groups. The 5 chromosome aneuploidy screening by fish, the 24 BGTA and the BGTA aneuploidy via BGTA I2 platform, and of course the ratio of the tested embryos in the study group as well. Sorry, here we'll go back to the aneuploidy group. Among the first, we can see that the BGTA group is only 1% of the whole, while the BGTA day 3 are more than half of the aneuploidy. The euploidy, almost they are 50-50% of the embryos in both the BGTA and the BGTA2. And some of the embryos had no result in the study group, and that's why we moved to the second choice, which is BGTA AI2, because that can tell us more about the how healthy are the embryos. The 5 chromosome analysis with fish, the total number of the embryos were 656, and you can see that more than half of them were normal, and only 1/3 were abnormal. We couldn't get any idea about 12% of the cases because of different testing issues. And the percentage of the embryos tested in each group were almost 1/3 at that time. The cases were undetected chromosomal abnormalities in the embryos. There were no result, chaotic type of embryos, and chaotic type of chromosome, complex type of chromosomal problems, and no conclusion. You can see almost 212 cases we couldn't get the result, and this is almost 1/4 of the cases when we do biopsy on day 3. And at that time, we can see as well that the most common is Turner syndrome, XO, among the abnormal group of embryos. Trisomy comprises of 10% of the embryos tested with using fish. And of course, we move to the PGA or PGS and PGD. They existed since the 90s, of course, and still they are relatively new procedures at that time. And the first one to start the pre-implantation genetic screening and pre-implantation genetic diagnosis was Handicide. The BGD itself, this type of genetic screening looks for specific genetic conditions such as cystic fibrosis and some other cancer and hereditary medical conditions. These are rarely guarantee that the baby will develop the disease, but can simply indicate that the gene is present. For the PGS, this type is the most commonly used now. It's solely screening all chromosomes. The 23 pairs of chromosomes are screened, and the test will tell us about each and every individual chromosome in those cases. The pre-implantation genetic testing, there are different types, as I said. Pre-implantation genetic screening for abnormal chromosomes in number, and the pre-implantation genetic testing for monogenic diseases, and also for structural rearrangement, the BGT-SR. Who are the candidates to do PGT-A? Couples who have had previous pregnancy aneuploidy. I had 3 cases who are very young. Patients, the female is around 22, and those 3 cases, one had Down syndrome, the second diagnosed to have Down syndrome, the second one, the child was having Marfan syndrome, and the third one was Edwards syndrome. And those patients, they insisted on having PGT-A for their embryos before having any further pregnancy. Also, for women who have had 2 more miscarriages or recurrent miscarriages, unexplained most of the time, women who have experienced previous failed embryo implantation. Of course, implantation failure is not only doing genetic testing. There are many other factors. So this is not a guarantee. If we test the embryos and we transfer them, that doesn't mean they are going to have a pregnancy. But if the embryos are tested, they have 25% chance of having implantation success. Women who are diagnosed with unexplained infertility, and of course, advanced maternal age, the cutoff is around 35 years of age, and those who are undergone numerous unsuccessful fertility treatments. What do? If we first do IVF, then we culture the trophoectoderm or take one biopsy, one cell, and send it for genetic analysis, and then they will send us the result. I'll show you 1 or 2 examples of the reports. Either we do on day 3, we open the zona of the embryo. Either we use laser, as in our lab, sometimes they use chemical, and then we aspirate 1 or 2 cells, 2 blastomeres, and we fix them and send them to the lab, to the genetic lab to test. On day 5, what we do, we open the wall of the embryo, the shell, and then we aspirate some of the trophoectoderm, and we use laser to cut these tissues. And this is very safe procedure and does not affect the future of the pregnancy and the baby. This is again how we do it. We fix the embryo, we open the wall of the embryo, and then we use the laser to cut, and this is the trophoectoderm sample to be sent to the lab. Of course, this is the way we are sending the specimens. We arrange with one of the genetic labs. We are doing our cases with more than one lab. We are doing with Cooper's, we are doing with Viafit, who were first in SAD hospital. We do with Economics. They are different, but they are all doing the same procedure. Alan Handyside was the first in 1990 to use this procedure, BGT, to identify the Y chromosome to reduce the chance of a child having a sex-linked recessive disease. And of course, after that, things spreaded. And of course, they have used that in hemophilia case. The BGTA has shown to increase the implantation rate. That's true. In our cases, we have increased something like 17% when we are doing the BGTA. It reduces miscarriage rate. That's true as well. Increase the ongoing pregnancy rate, of course, because it reduces both, reduces the miscarriage and increases the implantation. And eventually, it will increase the live birth. It also reduces the time to pregnancy, meaning instead of doing 6 transfers, if you have a healthy embryo, the chance of successful pregnancy is less. Patient might not get pregnant from the first time, but after doing 3 trials, the success rate is more than 93%. Of course, we always advise patients, if they have the embryos tested for BGTA, to have single embryo transfer, which we are all encouraging that. We don't like twins. Of course, the chromosomal abnormalities increases with the age, and testing those embryos have proved to us that it is true. As well, the miscarriage increases with age, and the testing of those embryos as well have reduced that chance. And of course, if you look and compare the IVF without BGTA and with BGTA, you will find that the pregnancy rate increases and the miscarriage rate is reduced. This is the way we receive the report. You can see the comment, aneuploidy you can see the report, aneuploidy, female embryo with in chromosome 9, monosomy in chromosome 16, monosomy in chromosome 22. This is not suitable for transfer. That's how we exclude. Of course, if there is complex abnormalities, it's excluded. Those 2 cases, for example, no result, we observe them. The embryos, we are taking the test for the embryos on day 3. If we observe that they are progressing to blastocyst, we take the trophoectoderm and send it for second testing, rebiopsy the embryo. And of course, as I said, we have successful cases when we have one of these tested again and transferred. Of course, this is, for example, a male have trisomy in 22 plus 1 chromosome in 22. And this is a female embryo, which is euploidy 1. You can see with advanced age, out of the 17 embryos, we only got 1, which is suitable for transfer. As well, the younger group, the younger the patient, the more euploid embryos we have, and the more aneuploid embryos we will get. Of course, we can see the scoring of the embryos themselves. The higher the score, which is A, the more chance of pregnancy for those cases. Yeah. Now, with the new technology, the BGTA via BGTA-I2, the technology can give us a chance to test for mosaic cases. And in our group, the 22, we have 18% of the cases who are having mosaic, and we transferred embryos who are mosaic, and they were successful, and they were healthy babies. Again, if we look at the chromosomally abnormal embryos in their constitution, we can see, as I said, the most common is the Turner's among those embryos. Other chromosomal problems you can see here as well. This is day 3 as compared with the fish. Okay, and this is again the same. Of course, the trisomies, we can see more of the trisomies detected by the BGTA, and the same for the undetected embryos. BGTA on day 3, 36.5% of the embryos were normal, and the rest were abnormal, while in the fish, the number of the percentage of the abnormal were more. If we look at the normal male and female embryos, you can see that it's almost equal. I have collected all the normal healthy embryos. The number of baby boys and baby girls are almost the same. There is no difference. Okay? This is the BGTM testing for single or monogenic disorders. Let me show you, like Huntington's disease, sickle cell anemia, muscular dystrophy, cystic fibrosis, BRCA1, BRCA2 mutations, Fragile X and Tay-Sachs disease. You can see from this that the chances is almost 1/4 for each, almost each group. And it is the case. In conclusion, next generation sequencing has become the most appropriate technology for aneuploidy testing. In trophoectoderm biopsy, clinical outcome for different indications, there is evidence of improved delivery rate per transfer for patients with advanced maternal age, comparing with BGTA versus non-BGTA plus to cis transfer, and decreased miscarriage rate at the time to pregnancy, despite cumulative pregnancy rate were not different, but the time to pregnancy was shortened. We should bear in mind that the decrease of both miscarriage rate and the number of transfers to achieve a live birth, and therefore the time of pregnancy is the reason. This is the first twin with genetic disease. Mother has a hemophilia. She was successful on the 6th trial. On the 6th trial. Thank you.
Thank you so much, Salam, for
I
this.
expect questions.
Thank you, Salam, for this very informative
Thank you very
presentation. Now opening for questions, please.
Yeah, please.
Thank you for your presentation. Obviously, I know an extensive experience you have all these years and the number of embryos that you tested. So my question is, how you select the women to whom you offer, or the couples to whom you offer PGT, and how you select those to whom you will go directly for the NGS and the SNP, the PGT AI 2.0, for example, and those for whom you consider that you'll just stay only with the fish, if you still use fish.
No, we are not.
Okay. So then how you select those to whom you say, okay, you need PGT or you don't need PGT? Because from what you presented, the rate of aneuploidy, yes, it's true, it's increasing with the maternal age, but there are plenty studies now that it's increasing with the paternal age, something
Yes.
that the public is not aware of. And also from your graphs, there are clear data that aneuploidies are happening with early ages too.
Yes.
So why not for all couples who are coming to IVF, because if they come to IVF, obviously they were not able to conceive naturally, and this means there is a problem there and might be a genetic problem.
I wish I can do that to every patient coming to us.
So part of the
Actually-
cost, right? That cost
Yes.
is a big barrier indeed.
Actually, those patients who are coming for IVF, we explain to them, if you do IVF, you must do NIPT at 10 weeks. That doesn't mean we are seeing a good, healthy looking embryo, which is transferred to you. That doesn't guarantee a healthy baby later on.
Yeah, but
Genetically, but
that's
you-
true. But the NIPT, it's already in the pregnancies. I'm discussing before the pregnancy.
Yeah, I know. Those who cannot afford doing PGTA, we tell them at 10 weeks, please come to us. Let's do the NIPT for you, because that will confirm at least that the chromosomal constitution of that baby is normal.
Yeah.
I have one case. The mother is having endometriosis, and it was very difficult for her to conceive. We offered her IVF, and she conceived from the first trial, twins, 2 boys. We have done the 20 weeks ultrasound scan, level 2 ultrasound scan, and the babies were completely normal. I did C-section for her. Babies are completely normal. The pediatrician passed them as free. The mother noticed at 1.5 years that one of the babies is lagging in developmental, motor developmental, and it turned to be that the baby is having XXYY.
Yeah.
And I was really annoyed to know that the baby is having this chromosomal problem. We offered them to do NIPT, but again the question, if she has twins, what's the answer? What's the solution for those cases? That's why it's not easy to decide from the beginning. If it is up to me, I would do PGTA for all cases before putting the embryos
Transferring.
back.
Another question, if I may, I don't know if other colleagues want to ask. Regarding the mosaicis, what's the criteria that it's letting you to decide to transfer it or not?
Okay.
Yeah, a part of the clearly scientific one, that the mosaicis can be confined only to the cell that was biopsied, yeah?
True.
But what is your criteria into that?
Well, I have transferred only 2 cases after discussing the issue with the family and with the genetist who did the study, the biopsy study. And I was hesitant at the beginning, but the family insisted that they want the embryos, they don't want to waste time, and we were successful. They have, the father went to USA for a scholarship. They made the tests in USA, and they assured me that they are fine.
You've been lucky.
I am. With that, I agree with you 100%.
Thank you very much. Thank you.
Dr. Said.
Continuation of the same question. Me, as a maternal-fetal medicine, how I will follow this patient? Is there a rule of mosaic transferring embryo?
Yeah.
What will be our role? Means, do we have to follow, do it with nuchal translucency or just normal follow-up?
No, for all cases. Now, it's a standard. We do for them first trimester screening, we do for them second trimester screening, we do for them third trimester screening. We have to be very vigilant for these things. The IVF cases, as I said, we cannot be sure that they are chromosomally normal. The only way is to screen them before with the PGS or to screen them later with the NIPT. But we should be very cautious, and we explain this to the patient, to the husband and wife, that if she is pregnant, that doesn't mean that they are chromosomally normal. We have to do tests later on. Yeah. Dr. Hasina.
Well, I mean, thank you so much for the presentation. I mean, this opens, a very big question. I mean, for us as IVF people and for you. I mean, if we're going to test all the patients to see whether they have chromosome abnormalities, after the pregnancy, and what are we going to do to them, I mean, those patients, in Europe and outside, we used to terminate pregnancy, that's fine. But here, I mean, these people would be under a lot of stress throughout their pregnancy. You cannot terminate their pregnancy. I had only yesterday somebody called me and said, look, I have a Down syndrome baby. I'm 11 weeks pregnant. Do you terminate pregnancy? I said, no, we don't terminate for such cases, So it is very important that you have a unified policy in Bahrain to deal with this issue. I mean, not simply we are testing, we are dealing with human beings. I mean, you have to consider their psychological status, So, I mean, this is why, if you want to do it, you have to have the facility to terminate the pregnancy. Or if you don't terminate the pregnancy, you have to find a way how to deal with those patients, refer them to psychiatrists or whatever. I mean, it's not a simple answer, I mean, yes. I mean, now in the United States, for example, that, the people that are discussing that, they are against the termination of pregnancy, and they are against terminating these embryos, the abnormal embryo. They have you cannot destroy them. You have to keep them. It's against the termination policy. It's a big issue.
Yeah, there are still gray zones with there are many ethical problems involved in this, many for discussion. We cannot do termination for patients if they are having a chromosomally abnormal child. What to do with them? What to do for them? True, this is a problem. We spend hours talking to them and discussing things with them, but at the end they want a solution. We don't have a solution at the end. Dr. Hasina, please.
Yes.
Thank you so much.
Thank you, Dr. Salam, for the interesting study. So, do you check for all those patients routinely the endometrial factors to improve the receptivity?
Yes.
Do you check the endometrial factors?
Yes, we do for the patients.
As a routine for. Did you notice that there is an improvement also in the pregnancy rate for the group of patients who had done the PGT testing?
Yes. 2 tests have changed the success rate in our center. One is the BGTA, and the second one is the ERA test. ERA test is endometrial receptivity analysis. We do that for the patients who are having recurrent pregnancy failure, and if you combine them together, I have reviewed 250 cases of ours. The first 250 where we have done ERA test for them, the endometrial receptivity. If you combine BGTA with ERA test, the success rate was 67%. If you only BGTA, the success rate was increased by 17%. If by ERA test alone, it was increased by 23%.
Well, thank you so much. I'm sorry.
Are very important.
Shukran, Salam.
Thank you.
Thank you. We are ahead of time, please, so we're going to terminate here. Okay, our next speaker is Dr. Anastasia Salam. And I think she'll be online.
Yes.
She'll be presenting One Fits All, It's Time to Change, sponsored by Merck. Welcome.
Good afternoon. Good afternoon, everyone. Are you hearing me?
Dr. Anastasia, please.
Yes, you're hearing me? Hello? You're hearing me? Yes, okay. So, good afternoon, everyone. I would like to thank you for the invitation provided today. And the topic today will be the importance of individualization in treatment of a specific group of patients, which are the high responders. My presentation is hosted by Merck. This is my disclosure. And individualization actually starts at the time that the patient enters your clinic, because the treatment that we are going to provide will depend on the age as well as on the duration of the infertility that the couple are suffering from. And why did we mention it? Because the older the couple gets, the lesser the chances are for this complication. And from this point, we need to know what to offer the couple as a treatment modality. Is it going to be a simple lifestyle modification, ovulation induction, or is it going to be So here at this point, it's going to be patient safety at the most important focus. Why? Because whether it's a natural cycle, ovulation induction, or IUI, we don't want to follow the trend of ovarian investigation and hyper-responders. And that's why the patient comes first on the choice of medication. Just to remind you, responders are PCOS patients, whether they are young at age, have low BMIs, and high age. Concerning the cutoff limit for the AMH, some reports or some
Dr. Anastasia,
5,
please,
some
Dr.
say it's
Anastasia.
4.8,
Hello,
ASRM
Dr. Anastasia.
3.4. So basically, this is clear cut.
Dr. Anastasia.
By the end of the day, the combination of the AMH with the indicated AFC or recommendation has a history of increased lymphocytes and that might classify her as a responder. And the main of this individualization in this specific age group is to avoid the multiple gestation the HSS So is it a one-size-fits-all? Definitely not.
Dr. Anastasia.
Okay. So when we go, are you hearing me?
Yes, can you share your screen,
I'm just
please?
double-checking. Okay. So we are going to cover induction at the clinic, and we decide that this would benefit from ovulation induction. We should be very cautious about the plan and the choice of medication, because by the end of the day, we can that we have multiple with the best chance of success.
Dr. Anastasia, can you please share the screen? Share the screen.
Okay, sorry.
Thank you.
Okay, yes. You're seeing me now?
Yes, we are. Yes, we can see you now.
So we missed a lot. Do you want me to go back? It's just a couple of slides. Okay, so we are back at the beginning. So as we already said, individualization depends upon the presentation of the couple, and it's age dependent for the needs that they have in order to enhance relief depending on the age of duration and fertility. Our main aim is to avoid hyperstimulation and hyper-responders, and we define the hyper-responders as being young, having PCOS, with a certain level of age. And as with one size, that's why the individualization of the patient is very important for every couple. So if we decide that ovulation induction is the best treatment for those couples, we need to go cautiously by it, because the gonadotropin therapy requires expertise as well as multiple disciplines. And usually the candidates for the gonadotropin therapy are the hyper patients, the ones that have dysfunction or they feel either to bigger and pregnant, as well as ovulation. And here we need to have to know that the risks associated with gonadotropins really need screening. They are a bit more expensive, however we can start them at the period as long as we are excluding pregnancy, we're excluding morbidity and late minocycline, and the low dose metformin as allowed to explain. So we need to be cautious, and we need to explain to the patient that despite this treatment regimen, the cancellation risk might be a bit high, and she needs to be a bit patient with us. So by the end of the day, around 12, and some reports might say about 20 days of stimulation in order to reach at most one follicle which is ready to deliver, because if we have two or more size 60 millimeter or 3 or more millimeter, the chances of multiple gestation is almost 85%. So that's why we need to be very strict when the cancellation is like this. The HSS, actually ovulation, induction, they are there, but we don't have any good data on the incidence of those on this HSS. So we need to mention the patient to be on the safe side. Concerning medication is better. At this point, in the latest review that we have since 2019, we don't have any difference between the urinary purifier or the highly purified or the recombinant FSH. They have a similar safety profile as well, a pregnancy profile. But when it comes to like we need to provide like very small increments of medication. So the patient's convenience with the use of the gonal F pen, for example, with the 12.5 increments might be a winner in this case. Moving forward to IUI cycles, we did mention that IUI cycles are one of the things that might cause us to use the gonadotropins. And in this field, we have actually multiple studies that do mention in hyperresponders using gonadotropins low dose with the IUI might provide us with a shorter duration and a lower dose of gonadotropin medications, which would be more cost effective and patient convenient for the treatment. But by the end of the day, it's all about patient safety. So keeping in mind that we might have a higher chance of canceling, higher chance of having multiple follicles. So considering IVF in hyperresponders is not such a bad idea. And this is as per the ASRM committee opinion in 2020. So it's not about the more the oocytes, the better it is. It's actually more individualization of a stimulation in order to deliver a pregnancy, or actually in order to deliver a positive pregnancy test, the safest way possible for the patient, the most cost-effective way, as well as the most convenient way. We all know that there are multiple formulations in the market. The gonal F is not the only one. We have the beta, the delta, the epsilon, we have the long-acting. However, I'm going to show you the first study in 2020, which is actually, it's not a study, it's a review of all the recombinant FSH molecules in the market. And as per this publication that was done in Italy, it did show that Puregon, which is the beta component, it showed as if it's almost equivalent. However, when we go for the dates of the data or the publications, they all date back to 2000. So I'm going to present the data later on that actually the alpha one is better than the beta one. For the delta, it did show that it had higher number of cycle cancellations of the poor response patients in hyper response, which is the younger than 35 years of age. For the long acting, I don't think it's placed to discuss it in hyper responders due to its risk of having the hyper response to HSS. So that's why we prefer not to use it. So in 2009, Infertility and Sterility by a group Ervietto and al., they did do a study in comparison between the gonal F and Puregon, and did actually see that there is an actual lower clinical pregnancy rate when we use the folitropin beta in comparison to the alpha, which is basically the Puregon to gonal F. So basically, based on this study, and until we have any newer data with the newer comparisons so far, I think it would be safe to say that gonal F is better for convenience for pregnancy than Puregon. So now we're going to compare between the highly purified, which is the Menopure, and the gonal F. So the turning point was in 2020, where Witz and al. Performed a comparison, a randomized trial between Menopure and the gonal F. However, there were two major important things in the design of the study. The first one, they started like with a fixed dose, which is the 150 And I will remind you, this is in hyper-responder patients, so it might be a bit dangerous to say so. The second thing is their OHSS criteria for, or the OHSS risk criteria for which you would consider giving a GnRH agonist trigger instead of HCG. So for them, the cutoffs that they used were actually very high. And for me, and you will see that the numbers or the percentages of HSS cases, they're actually high and to be actually discussed in the 2020s with all the things that we have and all the guidelines and the data. So we will start with the parameters. So as we all agree, and it's already known that the recombinant FSH, yes, it does give us more oocytes at a lesser dose given during the ovarian stimulation. And we don't have significance, like we don't have the p-value, but given that the confidence interval does not include the one. So I would assume that this is a significant value. However, we don't have the statistical analysis provided by the group. So this is a question mark why this did that. And when we move to the ongoing pregnancy rate, the live birth rate per fresh and per frozen transfer, because in their discussion, they were like, oh, Menopur is better because it gives us higher pregnancy rate, whether it's fresh or frozen. So if we look at the numbers, you would say, oh, okay, yes, they are a bit higher. But when you go ahead and you look at the confidence interval, so the confidence interval does pass through 1, and this, statistically speaking, is not a significant value. So it's a huge question mark for this group, in order maybe they later on can provide us with an explanation, but up to this point, we cannot safely take, or I would take this information with a grain of salt, basically. The second point that I want to highlight is the OHSS incidence. So even let's disregard the FSH arm. So we'll look at the Menopur. So it's 9.7. 9.7 when we have the Cochrane and we have the ASRM, and they're saying that, the incidence of HSS should be less than 2.5 to 5. So 9.7 is actually a very high number. So that's why I'm going to disregard even what's written in the FSH branch, which is like the 21.4 or the 12.6. So because in their the way they prepared their study, they actually predisposed their patients, their hyper-responder patients, to OHSS, which is, in my humble opinion as well, in other online commentaries to this study, they thought it is like an error in the formulation of the study. And just to highlight by Batista et al., which is the online commentary to this study, by the ASRM as well as by the ESHRE, the cutoff values for GnRH agonist trigger in order to decrease the chances of having OHSS are way less. It's not 4.5 or 5 what they used, it's actually 3.4. The AFC is 24 and the estradiol is 3,500 and not 5,000 as they did. So at this point, you would really think, did they do the right study design in order to faithfully and clearly compare between the two formulations? No, they didn't. And that's why the conclusions that they had, that Menopur is better, pregnancy-wise, miscarriage-wise and stuff, it's not very accurate. So my conclusion to their study would be, actually, it's very important to individualize the FSH. Why? Because we already know that FSH, even with lesser doses, it can produce a good number of eggs at the expense of the decreased OHSS. Actually, it's not an expense, it's something very good for us and something very positive. So I think if they've individualized the FSH doses, they would give us more accurate data and more accurate answers to know whether Menopur is better or gonal F is better. So far, we are in an era where gonal F is more, let's say, safer at this point. So why did I mention the individualization? Because we have multiple studies out there. Let's say for this is the private study in 2016, where they did mention if we include the age, the AFC as well, the AMH, we would be able to avoid the hyper response in patients who are actually hyper responders. And in their study, they were able to show that their OHSS cases were actually very, 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 very low. It's less than 0.3%. So it makes you really think about the 9 and 10 and 21% that they actually presented in their study. And this is an example of one of the calculators that are there. So the gonal F, the Merck, they provide a calculator called Maestro. It includes the age, the AFC and the FSH, and you just put the data or the information of the female patient that you have, and it will provide you with an FSH starting dose. And usually those dosages are almost 70 to 80% enough in order to provide you with the anticipated number of eggs, which is between 9 to 15 to avoid any OHSS. And in the 30% remaining of patients, you might need to increase or decrease the doses depending on the response. But if you have like almost 2/3 of your patients responding to this dose without any risk, so I would say this is a very good one, and we might all need to follow it at some point. The other point that we need to discuss is the highly purified medication. So even if it's highly purified, we all know the origin of this preparation, so it cannot be like 100% pure. And that's why with all the foreign proteins and the batch-to-batch inconsistency, it might explain why at the same dose, which is 150 minopure and 150 here, the doses are a bit different, but I just want to throw back to the original presentation. So 150 of minopure, 150 of gonal F, the gonal F was able to give us more eggs. And again, taking that into consideration, they should have started at a lesser dose, knowing that the FSA, the recombinant FSH or the gonal F in this setting is more active, is more specific, it can give us a consistent response with a higher number of eggs. So again, to highlight the number of eggs, we have lots of studies throughout, like 2020, 2012, the 2006. So all the studies, they agree on the fact that yes, gonal F provides us with higher number of eggs. And again, in the setting of hyper-responders, we're not looking for 20, 30, we just need 10 to 15. So the individualization at this point is important. So just to highlight the incidence of the OHSS, so we have a study in 2020 as well as the Cochrane in 2018. So both of them didn't provide the numbers that were provided in the study. So in the Cochrane, it's like 2.5, and the study provided in 2020, it's almost 5%. So, okay, we'll take the 5%. So the numbers that were provided by the WITS study are quite high. So we need to make sure that if they are going to reproduce the study, they need to change the criteria as well as the safety criteria for the patients. Economically speaking, so we're going to go back to the WITS study, which is the Megaset HR, which said that the menopure is better. And they did calculate, like financially, they found like with the FSH, it's supposedly more expensive because they needed to transfer more embryos, because as per them, the pregnancy rate and the menopure was higher. And however, when they did the calculations, they only limited it to the first cycle, which is a bit incorrect, because when you have a couple that's being treated, we all know that there's a percentage that they might not get pregnant from the first trial. And there's also a chance of having a freeze also. When you go ahead and you want to calculate everything, you need to do it per the started cycle till the pregnancy, so which includes the number of oocytes, the doses of the gonadotropins, the cancellation rates. So all that needs to be taken into consideration. There is another study that actually it's in press. I'm not sure it's actually there yet, but you can find it online by Buller and al. in 2022, and it's based on a large German registry, and they did find actually that with the gonal F. Okay, so this is the gonal F, this is the menopure. The pregnancy rates, the live birth rate are higher, with the cost of actually reaching that pregnancy rate and live birth rate is less, and they're speaking over 3 cycles in a row. So this is a more updated study based on the data that it's there. It is retrospective, yes, but still by the end of the day, we need to take all the information that's there in order to be able an informed decision and thus provide the best information to our patients. Here, just to remind you that one of the most important features of the gonal F, it's actually the feasibility of the use, the patient's satisfaction with its use, and that we can really control the amount of the medication that we are administering, because by the end of the day, we know that the medication, it's a recombinant one, so we are really sure of the concentration of the mass that it's there. And by the end, the conclusion that we have, we need to select our patients, we need to individualize our patients as soon as they enter our clinic, because the pregnancy rate, the complication rates will depend on that. We can use the gonadotropins in ovulation induction, and definitely by the end, it's going to be the patient's convenience and TSI cycles. For the IUI cycles, the recombinant FSH did show that it's much better. For the controlled ovarian stimulation, please do consider that with the FSH, the response of the ovaries is going to be much better oocyte-wise. That's why try to avoid the higher doses of the stimulation of the initiating dose to avoid OHSS in case freezing is not an option, whether it's financially or whether the cryopreservation system is not really working. And by the end, it's a cost-effective treatment, and that was based on the latest data that was provided by the German registry. Thank you for your attention, and I'm open to any questions. Yes.
Well,
yes. Okay.
No.
Yes.
ما في حدا لا. Okay, that finished. There's no question. Thank you so much. So we come to end of our morning session, and that's going to be a break, and then later on we'll do the afternoon session. Thank you so much for attending, and have a nice day. Thank you.
Thank you. Thank you. Thank you.
everything that's related to
He will manage first from his side. Rohan.
Okay, and then I can change it from here? Ah, no.
He
let
managed.
let him just do like.
So I let this here. Christina Skripnik.
Good afternoon, everyone, and welcome back again. For our general session, and which will be the next session, I would be grateful to introduce Dr. Christina Skripnik. She is Assistant Professor Consultant in Medical Genetics, Arabian Gulf University, College of Medicine, Molecular Genetics Department, and she has a European Certified Board in Medical Genetics since 2019, Certified in Genomic Medicine Clinician 2019 as well, Consultant Physician in Medical Genetics, Ministry of Health, Office of Professional Qualifications, Romania 2009, Doctor in Medicine, PhD in Medical Genetics, University Medicine, GT Papa Lassi, Romania 2007. The floor is yours, Dr. Christina, and welcome.
Thank you very much for the nice introduction, and I would like to thank organizers for inviting me to have some talks for this very important event. My first talk is about preconceptional and prenatal genetic evaluation and counseling. And the outline of the presentation, we will just have a short overview of the genetic disorders' impact into health. Then when we shall consider preconceptional and prenatal genetic referral, and how we do counseling and what are the most important aspects we need to focus on. So as was highlighted yesterday, prenatal care begins obviously before conception, and it's so important to take care of the germ cells of the future mom and future father before the miracle is happening. So why to focus into genetics? Because genetic disorders are having a very big impact into the health. 50% of all recognized first trimester pregnancy loss have a chromosomal abnormality. 2 to 3% of neonates have at least one major congenital abnormality. And 0.6% of all neonates have a chromosomal abnormality, and 50% of the childhood blindness and deafness and all cases of severe mental retardation account for a genetic disorder. Then over the life, 30% of all childhood hospital admission and 40 to 50% of all childhood death are caused by a genetic disease, and 1% of all malignancies directly due to genetic factors, and 10% of common cancers such as the breast and colon cancer and ovary cancer have a strong genetic component. And it's believed that 5% of the population by the age of 25 years old will have a disorder in which genetic factors play a very important role. So just a very, very short overview of how genetic disorders are classified. We have like monogenic disorders, chromosomal disorders, polygenic multifactorial disorders, and embryofetopathies, and that their phenotype is resembling a genetic disease, and so important to differentiate in between. So why preconceptional and prenatal genetic evaluation and counseling is important? Because nowadays we can do genetics and genomic prevention, and this is possible, it's available, it's applicable, and it's efficient. And it's starting before the couple is considering to marry, and then before they consider to conceive, and obviously during the pregnancy and after the pregnancy. And through all these very important steps of a life of a person, genetic counseling shall bring an important contribution. So what are the goals of the preconception care? Obviously to optimize the woman's health, to minimize the risk to her and the fetus, and improve pregnancy outcome. And very, very important is to provide information necessary to make informed decision about future reproduction. Prenatal care begins before conception, as I already said, and in obstetric and gynecology, you are the experts who are most frequently in contact with women of childbearing age. So then you have to be aware of all possible outcomes before the conception. And you have this big advantage that you can improve the pregnancy outcome because you have the knowledge and you can apply it. And if we work in a team, not only the OB/GYN consultant, the gynae and the other experts who are seeing the couple who is considering to have children, then together we can bring a better contribution. So the most important elements of preconception care are the risk assessment, and then education and health promotion, and obviously how we can intervene on the medical and psychosocial aspects. Of course, there are plenty components that are recommended for the preconception care. Through all of this, the most important that I will focus today are how we take care of the genetic issues that can lead to very high risk for the reproduction outcome. Now, when you see a couple or a woman who is considering to conceive, of course you pass through all guidelines that you already know, but I want to focus into having a family genetic history. So why a genetic evaluation is important? Because the geneticist is highly trained into screening for personal or family history of congenital anomalies or genetic disorders. So what I want to highlight through this presentation is that we can work in a team, and then geneticists can see you patients to assess better the risk and the methods that we can rule it out, avoid, or diminish the risk for having affected offsprings. Nowadays, we discuss about genomic precision medicine or personalized medicine, where we move from one size fits all, I mean, the guidelines that are available for any pregnancies, to particular measures that are to be implemented for only that couple, only that woman, or only that wife and husband. And everything is starting, as I said, before they marry, before they conceive, before the birth, prenatal, during the pregnancy, and after the pregnancy, with a lot of tools and interventions that are available nowadays. So when we shall consider the preconceptional and prenatal genetic referrals. You know how visible is that? But obviously, you are already aware that there are some categories considered with risks in high risk in genetics. So if you have a woman who is borderline with the advanced maternal age, so from 35 years old onward, at the time of the conception, and then if there is a consanguinity, if there is a positive family history of any kind of disorders in the family, and someone is affected or not. So now here there are very important aspects, because when you ask the couple or the lady, if it's anybody affected in your family, generally they will say no. So you need to ask precisely about particular disorders that can reflect a genetic pathology. So you have to ask if there are people who lost pregnancies in your extended family, if there are babies who have been born dead, if there are kids who die early in the first months or year of life, or kids who are not able to go to normal school because they were not able to hear, to process, their cognition was not okay, were not able to see, and so and so. And then children who have regression, or adults who passed away suddenly, but not because of accidents, if there are cancers in your family. So more and more, if you go in details, then people will recall saying, oh yeah, actually there is someone, there is a cousin of mine, there is someone in the family. So pay attention into taking the family history and the antecedents of the couple, because these are very, very important, and they may highlight many times a possible genetic background. A very important aspect is to pick up consanguinity, because consanguinity is increasing the risk to have affected offsprings. And something that a lot of people are not so much aware is that being consanguineous doesn't mean necessarily being married with a first or second degree cousin, can be far related cousins. And also, Middle East, and there are other parts of the world where the carrier status for very rare, severe or lethal genetic disorders, it's higher because of the particularities of the gene pool. So therefore, it's so important to rule out the carrier status, not necessarily to identify the consanguinity. People can tell you, no, we are not related, and we know this very well because we ask our parents. But then if you consider the particularity, the ethnicity, the part of the world the people are coming, they might be carriers. And I don't know if you are aware, for example, spinal muscular atrophy, that it's a devastating lethal disease affecting the anterior motor neuron in the column and the spine. It's having a higher incidence of the carrier status in this part of the world. I mean, if the carrier is 1 in 80 people in other parts, in Europe and North America, it's proved by studies done in this part of the world that the carrier status can be up to 1 in 25, 1 to 30 30 people. So then even they are not related, they might carry mutations or variants, severe variants in genes that can lead to high risk for affected offspring. So when you ask about if is anybody affected in your family or if you are related, please just go in deep and consider that. Even people are not directly related, they might still be carrier of serious disorders, and therefore carrier testing that I will just discuss soon will be very important. So nowadays we practice genomic medicine. We look beyond the signs and symptoms of particular disorders and we go back deep into the genetic material. So we know now the human genome and we are able to run amazing tests that go to the level of a single nucleotide polymorphism, and they are able to identify copy number variation in the genes. So how you do the genetic counseling, and obviously you have to focus on a lot of aspects, as I already said, the family history, and then to assess the mode and risk of inheritance, the age of onset, the penetrance and explosivity. So many times one of the partners in a couple might be affected by a disease, but the symptomatology is so mild and less, and they are not aware of. But then the disorder can be transmitted to the next generation and manifest with even much higher and severe phenotype. So then obviously we start with the pedigree, as I already said, so pay attention into going extensively. If you are able to create at least a 3-generation pedigree, this is good, but if you can go extensively, it's more. And then it's so important the questions you ask in order to pick up the relevant data that can help you to assess what kind of inheritance it might be in that family. So genetic counseling can be done prospective or retrospective. So prospective, this is what we want. We want to prevent the genetic disorders and then identify and avoid the risk. But also retrospective, when in a family someone is already affected, so you know that there is a particular disease in that family, so you want to avoid this to be sent to the next generation. And for that, you need always a very accurate diagnosis. So why I entitled the presentation Preconceptional, Prenatal Evaluation and Counseling? Because very rare in practice, and I'm practicing here since 12 years, you have to do a pure genetic counseling. You do actually genetic evaluation. You are trying to identify which are the possible genetic backgrounds in the family, who is affected, and what kind of disease you are dealing with. So very rare you have patients who already have been assessed by a particular disease, they have a diagnosis, they have already a genetic test done, and you just explain what is that disease and how they can avoid it. And in the genetic counseling, you shall present all available options. You have to calculate the risk to explain how this happened, which are the new developments, what is the course of the disease, the treatment availability. Now, you have to do this very non-directive. I mean, you present all information and you let the couple to decide what will be the best for them in terms of reproducibility. So this means being non-directive. You have to present them to all available options, and then you have to take in account their culture, their religion beliefs, the law of the country where you practice, and we just discussed in the previous session with the big dilemma, ethical dilemma of the prenatal diagnosis, that it's possible to be done, but then the hands are tied if the pregnancy is affected. Still, the legislation didn't move forward into that to see how this can be helpful for the people. Also, economical status and the capacity of the family to go ahead with particular tests, it's very important, because genetic testing, it's not cheap. This is the truth. A lot of prices are decreasing because now technology is improving and there are plenty labs who are offering all over the world, but still it's remaining an expensive test. So therefore, it's not yet, unfortunately, covered by insurance for people. Only they have private insurances. So not all people can afford to pay this kind of test. So then you need to really discuss in deep what will be the best option for them. So what you discuss during the counseling, which are the risks that genetic abnormality can exist in all pregnancies. So there are two big categories when you do counseling. Either you have a couple who is considering to marry, they are already married and they are healthy, nobody ever had anything in their families, and that's very good. What I can say, it's called like white sheets planning pregnancy, and that's ideally, because that's you can do like preventive genetics and preventive medicine. And then the other category that it's more frequent in practice when you have a couple who unfortunately either someone is affected in the family, or they already lost pregnancy, or they already are facing infertility, or they went for plenty IVFs and none of them are successful, or they lost kids. So there are two categories, and in this way you need to be able to explain to them what means a genetic disease. So you need to focus on explaining what are the risks in the general population, that there is, among live births, the incidence is 0.5 for numerical or structural chromosomal disorders, so this can happen to anybody, and can be 1% of a monogenic disease that then can happen to anybody, or multiple gene polygenic disorders. And then, of course, if there are stillbirths or others, the risks are higher. Also important aspects are that most malformations that are involving a single organ system, like the neural tube defect, congenital heart disorders, they are polygenic multifactorial. And probably you already experienced that in your practice, that you have a pregnancy that it's ending up with, ventricular septal defect, or one kidney, or spina bifida or others. And then, it's bringing a lot of stress for the couple who is having a child like that. But this is polygenic. You cannot do plenty things into purely genetic testing, but you can modify through the genomics, and we can discuss this a bit in the end. Now, chromosomal disorders are more likely to be present in miscarriages, in fetuses with major malformation, and in stillbirth. And then what we know, and everybody now, especially in your specialty, you know very well that the risk is increasing with the advanced maternal age. But as I just said before, there are more and more data now from extensive studies that are supporting that also paternal advanced age, it's linked with aneuploidies risk, not only maternal one. We know that paternal advanced age is linked with the increased risk for monogenic disorders like de novo spontaneous mutations like achondroplasia and other disorders. But we have to pay attention on both partners' ages, not only the mom but also the father. A very important aspect are that a part of the aneuploidies, there are submicroscopic chromosomal changes. They are called microdeletion or microduplications, and their occurrence is completely independent than with the age-related non-disjunction. So then anybody can be at risk of that, having a child with DiGeorge syndrome or Williams syndrome or Piquet-Wiedemann or others. And also there are some very complicated things if you deal now with the second category, when you have couples who are coming to you for IVF because they are facing subfertility or infertility, primary or secondary, then you know that IVF is also associated with some changes in epigenetics, and there are increased risk for imprinting defects. So all these things need to be explained in the counseling for the couple who is considering to conceive, or for the couple who came to you because they are having reproductive problems. So you know that if it's autosomal dominant disease, the risk is 50%. If it's autosomal recessive, the recurrence risk is 25%. But even though there are variants, sometimes you might have a variant expressivity, you might have non-penetrance or incomplete penetrance. So therefore you need a geneticist who is able to go in deep into that, because that's our expertise. And if it's X-linked disorder, the risk depends on the carrier status of the mom, and also if the father is affected or not. Now, if it's mitochondrial disease, this is very complex, because there are two categories of mitochondrial disorders. There are purely mitochondrial one, where the risk is high increased if the mother is affected or she has a heteroplasmia. But there are also mitochondrial disorders who are caused by variants in nuclear genes, and the risk is like then for the recessive disorders. So you see, the genetic pathology is very complex and very wide, and therefore we need to work in a team in order to help people. Now, I will just take some minutes more, just focusing on embryofetopathies. That's very, very important to differentiate in between what looks like a genetic disease and what looks like an embryofetopathy. And you know there are some toxic substances like alcohol, chemicals, drugs, medicine. We just discussed about methotrexate, viruses and radiations, and the way in which they can affect the developmental embryonic and fetus sometimes can resemble a genetic disease, but then the recurrence risk is completely different than a purely genetic disease. So preconception genetic testing, it's very important, but need to be individualized according to which category you are dealing with, so people who are healthy or people who are having a positive family history. And on both categories, please focus on the carrier testing, so even they are related or not, to rule out if they carry common genetic variants that can put them at high increased risk. It's very, very important. So how you do the screening, there are different methods to do the screening. Sorry for that. I'm advocating for the, for the integrative, extensive carrier genetic screening, that it's looking to variants in all genes that are reported nowadays associated with severe and lethal genetic disorders, so pathogenic and likely pathogenic variants in these genes, and overlapping, so you test both partners in the same time, husband and wife, and then you overlap it, and then you pick up those variants who are in common, because then they will be at risk to have an affected child. Now, this kind of extensive integrative screening is bringing very good results. So far now we run it in the genetic clinic for a lot of people, and as I expected, everybody is carrier of something, but important is to identify the common variants. And identifying that, it's helping not only the couple, but their relatives. So you can go then and doing testing for the other people in the family. It's reducing anxiety and has indeed very good clinical utility, because in the moment when you identify, you can help the couple to decide what will be the best option for their pregnancy. Either they go naturally and then they do prenatal diagnosis, or either they go for the IVF in order to do pre-implantation genetic testing. Now, in the moment when you identify that people are both carriers, you do exactly what I said. So you can classify if they are a medium risk, high risk, or low risk, and then you do the preconception genetic counseling. The other important aspect, the second category, when you have a couple, when one of the partners, either the wife, either the husband, is affected by a particular genetic disease, that will be very, very important to have an extensive genetic counseling before they consider to conceive. And then there are now guides for particular disorders, and this is just an example about osteogenesis imperfecta, because I had a patient in the clinic with osteogenesis imperfecta, and she wanted so much to understand what would be the risk to have an affected pregnancy. But here there are two different things: the risk associated with the disease itself, the genetic risk to send to the next generation, but then it's the risk associated with being pregnant and having a particular disease. So then there are two different aspects that you need to take in account. So not all people who are having a genetic disease are fertile, and then if they are fertile, they might not be able to carry the pregnancy at term, and they might be under particular medication that can affect the pregnancy, and so on. So prevention is the best way, and now we have tests that can help us to identify the couples who are at risk and to offer them the best options. So this can be the carrier detection, as I said, premarital or preconceptional, and then on the pre-implantation, as you already heard in the previous presentation. And of course, other methods that then you can optimize the outcome of the pregnancy. And I will just pay attention 2 seconds into that. So it's not only about looking to the genes, but it's also looking into how these genes are expressing. A lot of disorders are caused or by changes in the gene expression, and we are discussing here about epigenetics. So the way in which DNA methylation is done, the way in which oxidoreduction is done, detoxification, and so on. Also very important role in the maternal health, it's playing the gut microbiome. And now there are tests that are called genomic nutrigenomic testing, that when you can assess the particular variants a pregnant or a future pregnant woman might have in order to prepare her body and optimize the outcome of the pregnancy. So nowadays we move from the let's say classical genetic approach to the genomic approach, and we can do much more for the pregnancy and for the pregnancy outcome and the development of the future baby. And I think you all know that it's important to have folic acid, but then I will just say that folic acid, it's not for everybody, because if a person has a variant in the methyl tetrafolate reductase genes, that person might not process at all folic acid, that it's a chemical synthetic form, and it's needing folate. But then if you recommend folate and you over-methylate that person, you put that person in severe undermethylation. So then it's so important to know the genomic profile of a person when you recommend supplements. So all of this is requiring knowledge. That's why we are here today. That's why in this profession permanently you need to update. And I think beyond of understanding how genetics and genetic counseling is done, we all need to be updated with correct information, because sometimes it's not possible to find fast a geneticist, but the information that you'll give it to your patients might really change and turn for good the outcome. So updating and understanding and asking colleagues and referring cases, it's the way in which we shall do medicine today, and to work in collaboration as a team, not only in between us as scientists, highly trained people, but also in partnership with the couples and the future parents. Thank you very much for your attention, and I will be willing to take questions.
Thank you very much, Christina, for the talk. Any questions? There is online questions, how to avoid prolonged induction.
I don't think this is for me.
Maybe. I don't.
That was for the previous.
From the previous. It's still pending. Anyways, any questions? Comment? Yes, sure.
Yeah.
Thank you. It is elevated in XC babies, and is there a way to test the methylation?
Yes, there is.
In PGT, is it possible?
Yes, it's possible to test. It's not easy, but it's possible to test. Another way is to test during, if the pregnancy was initiated, to test it. But yes, ideally is to test.
So you can do it either before pregnancy or during?
Or during the pregnancy. Ideally is to do before you do the transfer.
Yes.
In order to assess the methylation defects. And yes.
And confirm.
And confirm later on, obviously, like all preconceptional testing.
Right.
And all, you know, the target one are Biquit-Wiedemann, for these are the main things, and Prader-Willi and Angelman. But there are others imprinting defects that can appear. And I'm very glad that Dr. Mariam raised these questions, because that's something that very rare people who are going through IVF are taught about and explain. They think that if they go to IVF, it's a miraculous thing. They go to the clinic and they go out pregnant and everything will end up after 9 months perfectly. They ask you if it's guaranteeing. If you recommend them to do IVF plus PGT in particular circumstance that you assess that that's important for them and recommending, they said, can you guarantee me 100% that the child will be 100% healthy? And I said, with all respect, nobody can guarantee.
No guarantee. Yeah. Always you look for something specific. But this issue is very important because we don't know.
Yeah.
I can check for aneuploidy, I can check for point mutation, for familial inherited diseases, maybe it's multifactorial, but or multigenic. But with imprinting defect,
it's very difficult.
I don't know. And
it's very difficult because imprinting defect, and that's heavy genetics, Dr. Mariam knows, there are multiple changes leading to the same phenotype. It's either you have uniparental disomy, and this is quite easy to be tested, even if it's in pre-implantation genetic testing, uniparental disomy, but you might have imprinting center defect, and that's very complicated, right? And so that's not easy. So therefore, the estimated outcome, it's never 100%. Because you cannot cover everything. And PGT, indeed, it's an amazing tool, but we can test only what we can identify, not everything. And a lot of changes are appearing de novo in our genetic material, so we cannot cover everything.
Thank you very much.
Thank you.
Any further questions? I think today we brought us or myself to a place where the gynecologists are here beside geneticists. So it's a very difficult situation.
So I'll go further with the session, and it's my honor to introduce Dr. Hassan Yusuf, who is an Euler PCP rheumatology from South Africa. He has more than 14 years experience in his field, in internal medicine and rheumatology, practicing as a rheumatology consultant. So he is specialized in rheumatoid arthritis, lupus, gout, back pain, antiphospholipid syndrome, scleroderma, and other very severe autoimmune disorders. And currently he's working in Royal Hospital for Women and Children in Bahrain. So Dr. Hassan, the floor is yours.
First of all, Assalamu alaikum and good afternoon, everyone. This is actually like the disease itself, which is antiphospholipid syndrome, which is a very complex, rare autoimmune disease. And if you can see the first slides, which showed the thrombosis, which the side we're looking mainly after, but as well there is a pregnancy, comorbidity, and mortality. So regarding the thromboembolic disease, which one of the major cause of maternal death and maternal morbidity and mortality, it's the incidence is quite high, as well as antiphospholipids, which later I will mention that, and the IVF itself increasing these three folds, which very significant effect in a patient with the presence of auto antibodies like anticardiolipin antibody, lupus anticoagulant, as well as beta-2 glycoprotein, and is associated with a very poor outcome of reproduction, like implantation failure, as well as IVF with imperial transfer problem, which we have to consider thrombophilia one of the major causes. Classification, definitely, as you know, it's hereditary one and acquired one, and the major is antiphospholipid syndrome or antiphospholipid antibody syndrome. Definitely, when we mention antibody, which antiphospholipid syndrome, which previously known as the Hughes syndrome, we have to mention Professor Hughes, who's recently retired from St. Thomas and Guy's Hospital, the one who discovered this syndrome and autoantibodies in a patient with recurrent miscarriages and unusual antiphospholipid thrombosis and thromboembolic presentation. Antiphospholipids is a very rare, as we mentioned, which 2.5 in 100,000, the incidence and the prevalence up to 40, but with the recognition and with classification, the new classification like Separo modified one, the recognition has been increased and the cases increased, which mainly presented with venous as well as arterial thrombosis, in addition to mortality and morbidity in gynae. The three autoantibodies, which is recognized for us, is functional lupus anticoagulant, anticardiolipin antibodies, which is IgM and IgG, anti-beta-2 glycoprotein. So odd ratio is quite different for venous thromboembolism, as well as very poor risk of reproduction outcome, especially in the presence of lupus anticoagulant. Anticardiolipin antibody as well is contributing, but mainly in cerebrovascular and stroke and others. But the presence of two will increase the risk of thrombosis as well. what's the clinical validity of thromboembolism? Why we have usually thromboembolism in a patients with recurrent miscarriages? To recognize antiphospholipid antibodies, actually we have to have like patients, we have to screen, especially in the presence of antiphospholipid antibodies, and sometimes in very rare cases of seronegative antiphospholipid antibodies, when you find a clinical presentation similar to antiphospholipid antibodies, but with a repeated serology and test, there is no positivity for any antibodies, which we call it seronegative. We have to increase the clinical suspicions in the presence, for example, of persistent thrombocytopenia not responding well to the treatment in a patient with autoimmune or non-autoimmune diseases, or just ITP recognized, and then subsequently there is no response, normal response to that persistent thrombocytopenia. We have to look for the patient who's young, presented with stroke, ischemic heart disease, massive infarct. All of these might indicate there is a problem, and we have to look for antiphospholipids. So I think this is sometimes might be boring. So normally in intrinsic antiphospholipid antibodies, it's interrupt the normal coagulation profile and fibrinolysis, so it will interfere with phospholipids. It induces inflammation when it's activated, and a platelet aggregation. So this also increase and exaggerated during the normal pregnancy, even without antiphospholipids, and we know that pregnancy is a risk for thrombosis. So ovarian stimulation, IVF also, it might induce that and exaggerate it so much, so we have to consider sometimes in such patient starting anticoagulant like heparin, low molecular weight heparin. So antiphospholipid antibodies, as we know, it's the most important, either can be presented as a thrombosis anywhere or recurrent pregnancy loss. But we have to have persistently positive antiphospholipid antibodies, especially anticardiolipin, as well as beta-2 glycoproteins, which consider comparable recently discovered. Why? Because infection, medications, malignancies, hematological disorders, all of that might lead to positive antiphospholipid antibodies. So positive antiphospholipid antibodies can be positive due to. So previously, due to classification criteria, which will help you in diagnosis, they consider 6 weeks is quite enough to repeat the antiphospholipid to confirm your diagnosis, to say this is definite antiphospholipid antibodies, not probable or possible antiphospholipids. Recently, we have to repeat it 3 months apart, which is different from the previous SOPARO classification. This is the new modified one, which consider we have to repeat it 3 months apart as to exclude there is no infection which causing this positivity or persistent, to have at least persistent autoantibodies. So we have a laboratory criteria, definitely thrombosis and pregnancy-related morbidity, and I will go just mainly through the pregnancy, very quick through lupus anticoagulant, anticardiolipin, IgM and IgG, and they have a different assay to measure them to confirm, and there is a percentile also assays. Thrombosis, which arterial, venous, and small vessel thrombosis, and pregnancy-related morbidities, which unexplained miscarriages more than 10 weeks of gestations, premature birth before 34 weeks of gestation, and more than 3 unexplained, which is one of them, consecutive miscarriages less than 10 weeks. So all of them we consider as might be caused by antiphospholipid antibodies. Definitely when we mention antiphospholipid antibodies, more than 40% are associated with lupus patients. And also this is one of the classifications which we called it the SLIC classifications, systemic lupus erythematosus consensus classifications for diagnosis of systemic lupus, which is different from the previous one of 1987, to help you to detect lupus as early as possible. And we included antiphospholipid antibodies in the immunological part, as well as also we added different clinical presentations, also hematological, subdivided, as well as a rash or a skin manifestation, all of that to detect lupus as early as possible and to start your treatment. And definitely lupus, especially if there is like cerebral or neuropsychiatric manifestations, there is abnormal thrombosis in lupus, there is hepatitis presentations, you have to exclude antiphospholipid antibodies, and this is an adverse event or adverse effects of lupus during pregnancy. Definitely, if anyone asks me about patient who's going to go to conceive and she's lupus diagnosed, we have to do one thing. The patient should be stabilized at least 6 months prior to conception. So there is no sediments in her urine. The disease activity clinically and laboratory should be stable patient 6 months prior to admission and on a lower dose of steroids. Then she can conceive, because the maternal mortality and morbidity will increase significantly in the presence of a renal or lupus nephritis. Outcome of pregnancy, definitely significantly different, especially between the newly onset lupus, stable lupus, which you can see the difference, and flare of lupus during pregnancy. And the most important is the flare of a disease, which can be catastrophic on the patient as well as a baby. Pregnancy and a fetal loss is quite high, and the lupus actually, and this is very important, by the way, point. Previously, because there is a limitation in the medications, when we start treating patients with rheumatoid arthritis, we see the patient are improving clinically during pregnancy. But there is a flare postpartum during the postpartum time, a huge flare. And this is indicate that there is, while there is a flare of disease, there is an activity, but silent activity during pregnancy. So the most important is to continue treatment during pregnancy. Lupus patients, clinically, actually very overt, they are flare during pregnancy. And this is very important, we have to consider. Flare during anesthesia and surgery as well. So antiphospholipids, there is a lot of complications and side effects and clinical presentation. The most important is cardiovascular, cerebrovascular, as well as avascular necrosis, which is very significant. Any patient with lupus and develop avascular necrosis is not mainly from the effect of steroids, it's mainly from the effect of antiphospholipid antibodies. We don't know why, because the steroids, if we're using it even for a very short period in a patient with rheumatoid arthritis, it will cause avascular necrosis, osteopenia, and osteoporosis. because rheumatoid itself is interrupt between osteoclast and osteoblast activity. Otherwise, in a patient with lupus, doesn't have that effect, so they might use a cornerstone treatment, which is steroids for a very long time without evidence of osteopenia and osteoporosis in a follow-up DEXA scan. So all of these are, and we can see here, a very significant, very characteristic features of what we call it livedo reticularis, as well as digital ischemia, which is one of the major complications, and especially we can see it in postpartum time. When we should ask for thrombophilia screening, despite is like a little bit more expensive, when we have like recurrent pregnancy failure, miscarriages, and when we have like unexplained thrombosis, this should be considered. And in systemic manifestations or autoimmune, you have to have systemic autoimmune diseases, the women which miscarries, recurrent miscarriages, intrauterine growth restrictions, and stillbirth, hypertension, and preeclampsia is quite significantly should be mentioned. Treatment, very important, because now the questions will come when we have to start treatment, when the patient presented with a definite diagnosis of antiphospholipid antibodies, or we have to start it as a prophylactic treatment for such patients with a positive autoantibodies, but no clinical, no previous history of thrombosis, no miscarriages, when we have to start it. So if there is a venous event or arterial event, thrombosis, pregnancy without prior thrombosis, heparin should be started when the patient planning to conceive. And with thrombosis, heparin and aspirin has an effect because we are avoiding warfarin. But the questions, if we have patients already on warfarin, and the target was 3 to 4 INR, and we have to start warfarin, what's other options? Definitely warfarin, according to many studies, even in a very rare conditions, we can start warfarin even by the end of the first trimester, because now the safety to avoid the mortality of the patient, thromboembolic events, if the mechanical way of obvious thrombosis can be avoided. So medications also, just a reminder, and I think Dr. Christina has mentioned that to me, there is a very high risk of autoimmune medication or immunosuppressing medications with a low risk. There is some has no data or at least comparably safe, and there is a high risk. Low risk like steroids, up to 25, 30 milligram of steroids can be safely used during pregnancy, despite concern of placental hemorrhage, placental bleeding, but still safe. Azathioprine, safe. Cyclosporin, we can use it. And tacrolimus, as well as an aspirin, heparin, low molecular weight heparin, IVIG, and TNF with special consideration. Other biologics is still, there is no valid data to continue on that. High risk, methotrexate. My point, which I mentioned, a lot of patients has been got pregnant despite all of the advice as to stop methotrexate 3 months prior to conception. But sometimes we found them already using still methotrexate with no any congenital or teratogenic effect. We don't know why, but that's what's happened. But anyways, methotrexate definitely, leflunomide, MMF, and cyclophosphamide and warfarin. Also, this is summary when you have to use it. Aspirin is still considered query as to be effective if not used with heparin. And this is, just to summarize, I will go, there is a strong evidence of low molecular weight heparin if you treat the patient with antiphospholipids with previous or no previous history of pregnancy morbidity with heparin or anticoagulant as early as possible, the outcome will be quite good. So until now, we have to consider if we have to start aspirin as early as possible, prophylaxis. There is no conclusion. Thank you very much.
Thank you, Dr. Hassan. If there are questions.
Is there any study that comparing antiphospholipid antibodies in a pregnant patient with or without COVID-19 since we are in a corona era?
I'm not aware of that, but possible they might be, because COVID-19 definitely one of the acquired or something which might induce thrombosis, definitely. But it depends on the presence of the antiphospholipid antibodies, if they are present, if they are persistent. Because as I mentioned earlier, antiphospholipid antibodies can be positive in the presence of infection, drug-induced, as well as malignancies. That's why, to confirm this is antiphospholipid antibodies, you have to have like a persistently positive autoantibodies. But COVID tests comparable in the presence of COVID, I'm not sure, but definitely it will worsen the condition because COVID is a recognized cause of venous thromboembolism. You're welcome.
Dr. Hassan, there is a question from online. When to start methotrexate after delivery?
Methotrexate?
Yes.
Okay. This is a good question because always there is questions about methotrexate. Methotrexate, if there is a surgery, I will come to pregnancy. If there is a surgery, we are not stopping methotrexate pre, intra, or post-operative at all. Good with healing, good with surgery, there is nothing to do with induction. Post-operatively, we can start it, and postpartum, but then depends on the breastfeeding. And for the breastfeeding, usually any dose less than 25 milligram, it will not that be ejected as much in the breastfeeding, so it's comparably safe during. The concern is about azathioprine and the others, but methotrexate comparably is safe during breastfeeding, so we can start it immediately, and there is no problem at all. The problem is the first trimester, first 3 months.
Okay, thank you.
You're
I
welcome.
hope that the person who asked is content by the answer. Any other questions from the audience? No, okay. Just.
Hydroxychloroquine is one of the cornerstone, actually, not because it's an immunomodulator, because hydroxychloroquine is an immunomodulator and very safe and does not induce infection and has antiplatelets effect, which is very good in a patient. But according to studies, the role in antiphospholipid is controversial. There is no direct that should patient with positive antiphospholipids antibodies, not clinically with previous thrombosis or pregnancy morbidity or mortality, has to start on hydroxychloroquine because it will neutralize antibodies. But in rheumatoid arthritis and lupus, Hydroxychloroquine can neutralize antibodies, we don't know why, and it can be the minimum dose and the background to start a minimal dose of steroids, as well as azathioprine or any other drug modifying. But for antiphospholipids, we're using it, especially for antiplatelets effect, and it's safe during pregnancy. But we don't know for how long and how, and the dose and the effect. So we have to use an aspirin, definitely heparin. So it depends on the school. Dr. Saida. This is our طبعا انتوا اللي عارفين اكتر. لكن this is I will do it in two things. Patients with thrombophilia or with no thrombophilia, like she developed VTE during pregnancy or pregnancy problem, I have to at least continue anticoagulation for 4 to 6 weeks postpartum. Not like currently some people, they just started 2 weeks, 3 weeks. It should be at least 6 weeks. It should be continued like this. And definitely when the patient on anticoagulant, the validity of, for example, lupus anticoagulant will not be significant. So the preference is to start screening at least when the patient is stable regarding homeostasis. There is no massive anticoagulation, no مثلا warfarin or whatever. Suggestion is 6 weeks and beyond, postpartum. Okay, thank you. Dr. Christina for the second presentation.
So I came back to discuss a bit more genetics. So my second presentation, it's about NIPT, non-invasive prenatal testing, as a standard prenatal screening for chromosomal abnormalities. You already heard about that in the previous session in the morning. So I will focus on what means NIPT, what is the background, what are the indication and recommendation, the methodology for the test, how we do it for aneuploidies and microdeletion, how reports are looking, and what kind of counseling is required for this test. So NIPT, it's a screening test, and that's very, very important. It's not at all related with diagnosis. You just screen if the fetus is at risk or not for certain genetic anomalies, especially related with aneuploidies or some structural chromosomal abnormalities, and some monogenic disorders now the test is developing. So NIPT, it's analyzing small fragments of fetal DNA called cell-free DNA that are circulating into the pregnant woman blood. The role is to evaluate the risk for some genetic issues and to test the pregnancy non-invasive and to offer it to all women. We have different kind of screening. We have maternal blood serum, prenatal ultrasound, and NIPT, and the international guidelines are going nowadays on combining 2 and 3, prenatal ultrasound with an NIPT. And again, NIPT, it's screening, not diagnosis. For diagnosis, you need to invade the pregnancy and to confirm or rule out particular genetic problems. And it's offered when screening methods indicated that the pregnancy might be at high risk. So in 1998, the first non-invasive aneuploid diagnosis was done by John Lake Simpson and Sherman Elias. They've been able to identify the trisomy 18 in a male fetus. And you see here 3 dots on aqua color, chromosome 18, and an X and an Y. So that was the first time when things have been identified using fluorescence in situ hybridization on fish, because 1 year before, the team of Law published in Lancet the presence of fetal DNA in the maternal plasma serum, and from there forward, amazing things happened in medicine, and nowadays we have a completely different way of looking to the pregnancy. So what are the properties of the fetal DNA? So the possible source is placenta, but that's very important that cell-free fetal DNA are increasing in a variety of pregnancy-related pathologies, is highly fragmented, less than 200-300 base pair, represent about 3 to 6% of the plasma DNA, and it's differentially methylated. 90% of the cfDNA is of maternal origin, and only 10% is of fetal origin. So therefore, it's a small amount, and it's still difficult to detect fetal point mutation. Now the technology is improving, and some monogenic disorders are able to be tested if they are de novo. De novo means new, are just happening into the fetus. The main indication is a high-risk combined first trimester screening result, because this is the truth, still expensive. And in plenty parts of the world, the first trimester serum screening, it's still practice. Advanced maternal age, this have been an indication since 2 to 3 years back, when the international guidelines said no NIPT shall be offered to all women, disregard of their maternal age, and then we'll discuss why. A previous pregnancy with a fetal abnormality, a previous history of chromosomal abnormality, a family history of chromosomal abnormality. Now, these are debatable, because if you have already identified a particular chromosomal abnormality in a previous pregnancy, then you go targeted and you go directly invasive. You don't go on an NIPT. So there are WHO criteria for NIPT. Obviously, the condition shall be very important health problem, and it is. Chromosomal disorders are devastating. The natural history of a condition should be adequately understood, facilities to exist, benefits to outweigh the harm. So the main reasons, the same criteria that are for any screening program are the same for NIPT, of course, particularized for the pregnancy. Now, there are a Medical College of Obstetrics and Gynecology recommendation that, of course, all these options like prenatal screening and also diagnosis testing shall be discussed and offered to all pregnant patients regarding of the maternal age or a risk of chromosomal abnormality, and I think we all know that. We do this in practice, because every patient has the right to decide if they want to go ahead or not having the test, but they need to be informed accordingly. Patients should have only one prenatal screening approach, and this is not to create too much anxiety and not to be confused. I had in practice patients who done a biochemical first trimester screening, and they got very, very stressed. And then till the NIPT came back, they really passed through a lot of stress, and they even wanted to go directly invasive. And when the pregnancy have been waited for 10 years and the lady it's 40, you really think twice, because it might be a healthy pregnancy, not necessarily an affected one. And opposite, right? So the 40, the risk is high because of the advanced maternal age, but it's not always like that. It's science, that real life is different. Cell-free DNA, it's not equivalent to diagnostic test. I already emphasized that. A positive screening test result for fetal aneuploidy requires genetic counseling and a comprehensive ultrasound evaluation. I will say it again. I might be biased because I'm a geneticist and I do that since 25 years, but please, NIPT is a genetic test. It's looking to genetic material. It's requiring genetic counseling. And unfortunately, still in practice, there are tests like that who have been run without being explained what this test is. Luckily, in some situation, the result came with very low risk and everybody was happy. But unlucky, I also faced cases when patients came to us because they saw it's a genetic center, very in huge distress, shaking, do I need to stop this pregnancy because it's saying that it's affected? I said, no, nobody said that it's affected. You have not been explained what this test is. No, they said it's good to do it for the pregnancy. So we have to be very careful into that. It's a genetic test, it's testing genetic material and has tremendous implication for the outcome of the pregnancy. In the same register, negative screening test results substantially decrease the risk of a targeted aneuploidy, but does ensure that the fetus is unaffected. The same. When I asked, did this pregnancy was tested? Have you done any investigation before? Yes, I done. They tested all genes and all chromosomes, everything, it's perfect. And as we just discussed before, there isn't a test that it's covering everything, that it's guaranteeing that everything is perfect. This is not true. But it's because people are not understanding the limits and the capacities of this testing, and nobody explained to them. And then when we do extensive counseling and we explain this is a test who has limits, can do this and that, then they understand, but they go into opposite, realizing, oh, my pregnancy still can be affected, actually. The truth is that. So all patients should be offered a second trimester ultrasound for fetal structural defects, no matter if you run an IPT or not. And that's very important to highlight. It's true that NIPT can be performed in twin pregnancies, but it's difficult to determine with accurate detection rate, especially for trisomy 18 and 13. Now there are different tests and different companies with good resolution. I will just present shortly. The test is quite standardized for the twin pregnancy and trisomy 21, but not so much for 18 and 13. And multifetal gestation, if a fetal demise, vanishing twin, or anomaly is identified in one fetus, there is a significant risk of an inaccurate test result. And unusual or multiple aneuploidies detected by NIPT require genetic counseling and maternal fetal medicine consultation, because might be serious issues there. Now, if a test is coming with fail result, generally the lab who is performing something like that, it's asking you for the second sample. So that's not a big issue. You can do it again. The only issue is that you lose time. If the pregnancy is affected, you lose another 10 days till the result is coming back. But if they repeat it and the sample was harvested in the right way and sent in the adequate amount of time to the lab, and it's still without any result possible, that's a high probability that the pregnancy is affected. So take this in account. Now, if the nuclear translucency is higher and there are other anomalies identified by fetal ultrasound, obviously you need genetic counseling and diagnostic. You move from screening directly to diagnosis. And this, again, the recommendation, as I already highlighted, BGI, it's one of the companies who is offering non-invasive prenatal testing, and they've been the first, one of the first on the market, but there are plenty other companies. The fact is this, again, highlighting that NIPT shall be offered to all pregnant women. Let them decide if this is good for them or not after detailed genetic counseling. And again, the recommendation from International Society of Prenatal Diagnosis. There are countries who already incorporated NIPT in their national plans, and in Europe you have Belgium and Netherlands in green in the cartoon that are offering that for all people in the national plan. Other countries in Europe depicted in yellow who are offering that for people at high risk, and others who are never offer it. So slowly we move into that all over the world. The main indication is that for trisomy, because the rate to detect trisomy it's very high, mainly the one for which is standardized, and they are associated with increased probability that the fetus can survive, that means 13, 18, and 21. Also for the sexual chromosomal abnormalities, also for microdeletion syndrome, and now slowly for other application, I mean monogenic disorders. And if you compare with the serum screening, the detection rate for trisomy 21 by NIPT, it's much higher. It's 99% comparing with 80 or 60 in different kind of tests. So obviously you go directly to NIPT. Now there are plenty publication all over the world from different labs and different research group that indeed NIPT is superior to serum screening, so we don't need to prove this again. And the global market for NIPT, it's increasing, and it's estimated that by 2027, the market size will reach more than 13 billion all over the world. And in light blue here on the cartoon, it's Middle East region. So the test, it started to be used more and more in this part of the world too. But again, we need to update, adjust our legislation. So if we do indeed prenatal testing, non-invasive and invasive, then we need to see what we will do if the results are coming positive. Indeed, legislation need to be updated, and I think it's also our role to raise these issues. Because what's the point of identifying if you cannot do anything? It's true that a lot of couples are deciding that no matter what, they're a part of religion or their personal life conviction, they want to keep the pregnancies, especially if they never had any other children, they didn't lose pregnancies. But it's devastating to see couples who lost children affected by serious disorders, and they go for testing and nothing can be done for the next pregnancy. So NIPT, it's an amazing test, has the potential to offer early results during pregnancy, and it's substantially reducing the number of invasive procedures over the years. And you heard Dr. Salam Jibril, who said that he haven't done amniocentesis in the past years. Only if it's highly required, obviously. 50% more trisomy cases, it's reducing invasive procedures by 88%, and obviously the iatrogenic fetal loss associated with invasive procedures, and much better than the serum. Of course, there are different algorithms to offer prenatal screening to all pregnant women, and to go on NIPT now for everybody if they accept that. And then if it's negative, obviously you go ahead with the ultrasound, morphology scan, and follow-up of the pregnancy. But if it's positive, it's mandatory to have a genetic referral. But again, I will say NIPT needs genetic counseling before and after. There are different methods that you can go ahead on testing if the pregnancy is at high risk on an NIPT, but this depends on what NIPT is saying, if it's an aneuploidy or if it's a structural chromosomal abnormality, or nowadays with the update of the test, if it's something on the monogenic. If you go invasive and the test, if it's QF-PCR or array or whole exome, if it's negative, then there is no need for further testing, and then the pregnancy is going on smoothly. But if you identify, then again, you need legislation. How you pick up the people, again, there are different, still people who are going into considering the high indication for NIPT. You need to filter that. What do you feel it's right to offer it to everybody or only for those at high risk? I have surprise in the clinic when people are at high risk and they say, no, I don't want to do it. I want to go directly invasive because I don't want to lose time in case the pregnancy is affected. And others who want to do it no matter what because they read in Google that it's very good to be done. But then when we discuss the genetic counseling and implication and pro and con of what this test can do and the limits, they are reconsidering. And especially these are healthy young couples of the first pregnancy, and a lot of them are deciding not to do and go ahead with the OB/GYN consultant, ultrasound, and follow-up. So I want to say that that's the autonomy of the couple to decide what's the best for you, but you as an expert and scientist, you need to present this information. How an IPT test is done, you need 10 ml peripheral blood, maternal blood, then you isolate the plasma, and then particular plasma DNA, and then you do a PCR testing. This was initially when the test was created, but nowadays it's NGS. NGS means next generation sequencing, massive parallel sequencing, and you sequence the entire genome and you focus on what you are requiring, what is your interest of. So important is, especially for now, you are all experts in OB/GYN, so it's important to know that this test, it's needing a particular fetal fraction to give reliable results, and the fetal fraction shall be more than 4 nanograms or 4%. And if it's below 4%, this is increasing the chance of getting no report. And then if you have no result, you've done it for nothing and you lost time. And also, of course, no result can also signify that the pregnancy might be affected by high risk for preeclampsia or gestational diabetes. And you need to know that the fetal fraction percentage is proportional with the gestational age and inversely proportional with maternal weight. And you probably saw that in all requests. It's asking not only the age of the pregnancy, but also the weight of the mom. For small placentas, the risk of getting no results is increasing. So then if you have, through your examination, you see the placenta is small, then you can suspect of trisomy 13/18. And if the NIPT test is coming with no result, then you might be already on the diagnosis and you need to move fast to go invasive. Also, the fetal fraction depends on ethnicity. Seems that it's lower in women of Afro-Caribbean origin compared with Caucasians, but that's that the studies have been done. And we know that this test started first in Western Europe and then spread all over the world. It's also lower in IVF pregnancies and increase with fetal crown rump lengths, serum pregnancy-associated plasma protein in others. So how this is done? Again, as I said, it's NIPT. It's done by NGS. There are different methods. It's either a SNP-based approach, single nucleotide polymorphism, or a chromosome selective one. I mean, you look only to the particular chromosomes and you know are at high risk, or you go directly to the whole genome, and probably this will be the approach in the years to come when the test will be standardized for that. And it's in this cartoon, it's depicted very simply how it's happening. So actually you have two types of DNA. You have the maternal DNA and the fetal DNA, and they are differently methylated, so that it's helping you to make the difference in between, but you always compare the maternal genotype with the fetal genotype. And obviously the mom, it's healthy. Your mom, it's not having neither of these aneuploidies and trisomies. There are different companies all over the world who are providing different kind of tests. I think you are familiar with some, Harmony, Maternity 21+, Nifty test offered by BGI, Prenatal test, and Harmony or others. Now they use different technology or similar technology. Now we work in UMC and Al Johara with Nifty since many years, and they do MPS, massive parallel sequencing for that. But it's good when you recommend an NIPT, look on the method to know the limits of the test and what the test can report to you. Here again, it's a cartoon with different kind of companies offering and what kind of methods they use. Is that they go targeted for sequencing on particular chromosomes, or they go on massive parallel sequencing. Either they go for the whole exome or whole genome, not yet all of them. So there are two capacities into that. It's either your test is coming normal, so then you go further with your regular follow-up, or the result is coming abnormal, so in this way you need to go invasive, so you move fast with CVS, and hopefully only with CVS. So the idea it is you need to do the test from 10 weeks. 10 weeks it's perfect because you have an enough fetal fraction that can be reliable for a good test result. Again, obviously this is needing a geneticist in the picture. So we use NIPT mainly for aneuploidies and microdeletion, and the main aneuploidies used are trisomy 21, 18, and 13, and the sexual chromosomes. I just want to check. Yeah, I will finish soon. This is a sample report of a patient of mine. The ultrasound was done at 11 weeks, 2 days prior to the test. And the result is coming like that. It's, again, screening test. It's telling you about probability and risk assessment. So if you know the incidence, the risk in the general population, you can compare where your patient is staying, if it's low or high. But anyhow, the report is telling you what means low and high. And it's also very important also to check the fetal percentage. So 8.2% is quite very good. So they mean they had enough fetal material to analyze, and that's increasing the chance the pregnancy is healthy. And that's another report. This is a twin pregnancy. I wanted you to know that if it's a twin pregnancy, you will not have probabilities because you don't know to whom, which fetus to calculate probability. So it will be just an overall report with saying low or high risk, but you don't know which fetus you analyze because it's a maternal bloodstream. Microdeletions. Now, microdeletions, the NIPT is very relevant for this kind of very rare syndrome, not so rare as we think. So they are in the books like very rare, but in the general practice, for example, DiGeorge, congenital heart defect and immunodeficiencies and developmental delay caused by microdeletion of chromosome 22. It's the second chromosomal abnormality in frequency after Down syndrome, so it's not so rare as we think. So they are appearing in more than one pregnancies, and they are not related with maternal age. They are related with particular genomic architecture that we all have as humans. So in some particular spots in our genome, there is a risk for breakage. So that's why these microdeletions are appearing. So therefore, NIPT, again, this is another criteria that you shall offer for everybody, not necessarily for women above the age 35 or with positive history. So you see here what I was saying, trisomy 21, it's the first and the highest chromosomal abnormalities in incidence, but then deletion on the chromosome 22. And then you have 1p36 or 36 microdeletion and Cri-du-Chat and others. And also you have microdeletion or imprinting defects syndromes like Prader-Willi and Angelman that are quite frequent. Now, if it's an Prader-Willi or Angelman caused by a microdeletion, you can identify by NIPT, but if it's, as we discussed with Dr. Mariam before, if there are imprinting defects with mutation in the imprinting regulatory center, you will not pick it up by NIPT. This is the same thing as I said. So a list of microdeletion syndromes. Now, some of them are extremely rare and you maybe never heard about. Therefore, you need a geneticist to assess if there is a risk for those syndromes or not. And when you recommend an NIPT, look please on the leaflet what kind of microdeletion syndrome that test it's testing. Because if the result is coming with suspicion of high risk, then you need a geneticist to explain that syndrome. And you need to decide to work in a team to decide is you go invasive immediately, what kind of test you do for that invasive, you go for array or not, or you use a whole exome that it's also including copy number variation. So again, different companies who are offering non-invasive prenatal testing in microdeletion syndromes. You have Maternity21, Illumina, Harmony, Natera, or others. So please look what kind of resolution they have, because sensitivity, it's not the same for all these companies. So this means in two ways. The probability to pick it up might be high or low, but if the result is coming with low risk, doesn't mean necessarily it's low risk, because these microdeletion syndromes have some particularities. I mean, in the region when the chromosome has a breakage, there are rearrangements, so you don't know where you look, in the beginning of the rearrangement, in the middle, or in the end. Therefore, in the beginning, only some companies started to test DiGeorge, and there are two types of DiGeorge, I mean deletion, DiGeorge syndrome or congenital heart defect, velocardiofacial. It's type 1 in chromosome 22 and type 2 in the chromosome 10. So initially, a lot of these companies started to offer DiGeorge 2, so you need to know there are two different things. Okay, so if you order an NIPT, look what kind of microdeletions are there. And again, because this is just telling you if is or not there, cannot calculate the predicting risk, you will not have numbers, you will just have detected or not detected. And then again, you shall continue with follow-up the pregnancy with all your expertise if you find symptoms on the fetal development that can reflect that maybe something is there, right? Again, this is a screening test, not a diagnostic one. So again, NIPT shall be done with genetic counseling before and after. And this means you respect the autonomy of the couple, you lead them the capacity of having an informed choice and an informed consent, and obviously, you know, you keep the confidentiality and everything you do. And the keep in mind that the main justification for any prenatal genetic test is to promote reproductive autonomy and informed decision-making by the pregnant woman. And again, as I said, it's proposed to be as a replacement for first-level screening in both high and average risk population. And as you saw already, there are countries all over the world who already took that. So this is NIPT, no other biochemical screening. A positive NIPT screening result should always be confirmed by an invasive, and you know this is international guideline, by CVS or amniocentesis. Again, I'm opting for CVS. Limited evidence is about performance in twin or triplet pregnancies because you don't know which twin or triplet you test. There are also false positive results in confined placental mosaicis, vanishing twin, or a maternal tumor. And up to 3% of NIPT have an inconclusive result. And this can be related, as I said, with the collection, transport of the sample, because this fetal DNA circulatory one, it's very sensitive to temperature, and you have to send the sample very fast and storage, but can be also a sign of a fetal mosaicis or a maternal malignancy. So you see, indirectly, you can identify something else. Again, NIPT doesn't detect neural tube defects, only chromosomal things, and some monogenic things, right? So there are some, have been studies done all over the world why people are willing to do NIPT. Mainly it's to eliminate the risk for a procedure, invasive procedure, and this is the main worry. Then second is to if the results are accurate or not. But the couple, especially the lady, will tell you, no, I don't want to touch the pregnancy. So what is happening after the NIPT, what I shall do and what will be the options. So as we discussed, there are a lot of guidelines into that. If it's negative result, this is low risk, so then you just follow the pregnancy. And if it's a positive result, then you need to confirm it. Now, there are some studies done on reduction of number referred to genetic counseling following the introduction in IPT, and thinking that everything can be managed fast, we will do an IPT, we don't need any geneticist into. It's true, many times the results are coming negative, and then through the follow-up of the pregnancy, nothing bad is there. But this doesn't mean that if something is not okay into the routine ultrasound, you should consider genetic things, and again, do genetic counseling before and after the test. So that's my ending slide. It's crucial that providers carefully counsel patients about the test advantage and limitation, and if the test is coming with a high risk, then you need to go invasive, so we need to work in a team to see exactly which test we do and how we help the couple to face the result. Thank you very much.
Thank you, Christina. Any questions? Yeah.
Dr. Christina, I have one patient. Actually, she did the NIP just to know the gender very early.
Okay.
Unfortunately, she did it in one of the private hospital, and it's found to be trisomy 21. She's young, she don't have any problem. I did for her even when she came for me the normal scan, first trimester, the NT, everything, all the markers, but the ultrasound was normal, but the NIP result came positive for trisomy 21. Is there any rule like to repeat the NIP, or should you
Yes.
directly?
No, you can. You can repeat it, because again, false positive can happen because of the sample transportation or something, and can be some associated factors, maternal one, that can lead to that. So you can repeat it. No issue into that. So if you want to prefer not to go invasively immediately, and you still have time, I mean, if you've done the NIP very early, like in 10 weeks, and then the result came 11 weeks, so you are into the window in between 9 and 12, then you can repeat it again, and you speak with the lab. I want the results very fast. I want to confirm if indeed this is high risk. And if it's, but again, you need to, to trust your expertise. Go back on the ultrasound, search there NT and any other things?
I'm fetal-maternal, Dr.
Okay, right. So
I-
can be a false positive, can be.
Yeah, actually, it is false positive but the patient was very anxious and all these.
And repeat it again, or you went invasive?
I went to amnio because she
Yeah,
was so worried.
that can be.
And the result came normal things. And another question, the previous lecture for Dr. Salam.
Yes.
He said they will do the GBTIA. What is the NIPT will add if it is done by 10 weeks after conception, more than the GBTIA? Especially the NIPT is only screening test, not a diagnostic test.
That's true, but PGT, pre-implantation genetic testing, has limits because you test one cell, and this might be the changes that you find or no changes that you find might be confined only to that cell because you didn't analyze the entire mass and you are early on the embryogenesis when cells are starting to divide. You know what I'm saying? So you might have a blastocyst with changes that happen spontaneously, but the cell that you done the biopsy is healthy or is abnormal. So therefore, if it's healthy and you selected the healthy embryo, you still need to go to monitor the pregnancy. And you start with NIPT because it's easy and it's not invasive. And if NIPT is telling you high risk, you go invasive even if it is a pre-implantation genetic testing pregnancy.
Thank you.
Okay. I think Doctora can comment more into that, right? So, okay. Any other questions? No?
If no further questions, we have to proceed. Thank you, Christina. To the next speaker with Dr. Mariam Dashti. Dr. Mariam obtained her PhD from King's College, London University. She is a senior scientist in the field of in vitro fertilization and fertility genetic testing. She worked as an assistant professor, Department of Microbiology, between 1989 up to 2004, the Department of Molecular Medicine between 2005-2017, College of Medicine and Medical Sciences, Arabian Gulf University. Dr. Dashi has been working in the field of assisted conception since 1989 and was one of the main founders in the first IVF unit, the military hospital, and the main founder of Al Jawhara Fertility Hospital in Bahrain, where she occupied the position of scientist managing director in both places. Also, she was actively involved in licensing the IVF labs and centers in Bahrain as an evaluator through the Ministry of Health. Currently, she's working at King Hamad University Hospital. Very impressive, actually. And welcome to hear from you, Dr. Maria.
Thank you so much. Really, it's an honor to be here with you. Thank you. Thanks. Okay. Actually, after all these genetic tests, we need law to regulate the application of all these tests, yeah? I started IVF in Bahrain in 1990, 30 years ago, and there was no regulation. I'm glad Dr. Saida is with us today. There was no regulation. Actually, I was the scientist in the lab, but I had to do everything. I used to do embryology, andrology, swapping the floor, truly. And also, I used to do marketing through the journals, local journals. And I had to do bioethics, because in those days, IVF started in 1979-80. I didn't do IVF in my PhD. I did clinical immunology. But when I went back to Bahrain in 89, they wanted to establish the first IVF center in the BDF hospital. Because I was a good technologist, they acquired me. They asked me to join them, and I did a good job, thank God. This field of IVF cannot be done or applied without bioethics. Because in Muslim countries, not even in any country, you have to follow ethics to produce embryos in the lab. It is between husband and wife. Although we can apply certain rules which are not important in European countries, but they are super important for us. Today, I am involved in pre-implantation genetic testing because there is a huge need for it. And this involvement started in 92, 2 years after establishment of the IVF. And we all started by application of fluorescent in situ hybridization, which was the simplest technique. All right. Today, I will be talking about regulation and licensing of pre-implantation genetic testing. And I would say that I started in IVF the same way in 1990 or 92. And I hope one day, today we have a law protecting IVF application. We have a proper committee made of many disciplines in NHRA controlling IVF application in Bahrain. I hope within 3-4 years we have the same for pre-implantation genetic testing. Before I start my presentation, I would like to disclaim that I don't have any conflict of interest and any commercial relationship to the content of this presentation. Right. The major aims of this presentation is several-fold. First is to introduce basic and essential information in relation to PGT, such as terminologies, techniques, indication, and legislation, especially for people who are not acquainted with this field. Second is to define the types of registration or licensing and accreditation certificates required for competent PGT facilities, which are offered as per global standards. Third is to describe the requirements of an efficient and authentic genetic testing, and last but not least, to present the standards used for protection of IVF facilities and their patients during PGT process. There are several points to be addressed in this presentation. Basically, they are in the form of questions. Is PGT a mandatory part of ART? ART is assisted reproduction technology, including IVF and ICSI, intracytoplasmic sperm injection. Is it regulated globally? If yes, how? Is PGT legal in the GCC countries? Are we referring our samples to the right PGT lab? Because there are so many of them, they are all over the place, but you have to be careful which one to trust and which one to discard. What standards shall we follow to improve the quality of our services? Are our services cost-effective to patients, which means you have to avoid commercialization of the test? Are we following the right protocols for embryo sampling? Embryo sampling is very tedious and very sensitive technology. It has to be done in the hands of safe embryologists. Safe in the sense that you do not harm the embryo. Can we get financial support from health services and medical insurance? At the moment, fertility doesn't get any support from medical insurance. Even the country, in the government in Bahrain does not provide or support any fertility treatment. But because they they consider fertility not a medical disease or medical condition, but with genetic disorders, I think there must be a way to convince the medical insurance companies to cover the testing. How to prevent abuse and commercialization of the test and services. This is by the centers which provide the service, by us, by doctors, by clinicians, by scientists. We have to be able to stop commercialization of the test, and you will know in the next few slides how this happens. Dr. Hatem yesterday talked about history a little bit, but I will start from 20th century. In 1967, Edwards and David Gardner described the use of PGD for sexing of rabid blastocysts. In 1986, Merlin Monk demonstrated the use of PGD in a murine model, murine mouse. And in 1990, Alan Handyside introduced a test for the first PGD for X-linked disease. Actually, he used fish, but he used them for sexing of the embryo, and he tried to avoid X-linked disease by choosing the male embryo. Also, the same person, Alan Handyside, used the same fish technique, for point mutation to diagnose cystic fibrosis in 1992, and Yuri Valensky in 2001 designed the first savior baby, which means a baby who can be helpful or help for the sibling. I have a problem with this. I hope this presentation and the figure is quite clear. Fertilization occurs between sperm and egg the moment the sperm enters the egg. Now, with entering of the sperm into the egg can happen by IVF, traditional IVF, classical IVF, putting egg and sperm together, or it can be achieved by putting a sperm inside the egg by injection. Usually for genetic testing, we use injection of the sperm inside the egg to minimize the contamination of the test by maternal DNA. So after the first day, you get 2-cell embryo. Then second day, you get the 4-cell embryo. Day 3, you get 8-cell embryo. And then day 4, you get a morula, collection of cells. Day 5, beginning of day 5, you get a blastocyst. You leave it for a little bit later, you will see the hatched embryo, and you will see hatched the blastocyst very clearly. You see the trough ectoderm, and you see the inner cell mass. The inner cell mass will give you the embryo proper, and the trough ectoderm will give you the chorion in the future, after implantation. Now, that biopsy can be achieved or performed on day either 3 or day 5. Day 3, you can take 1 or 2 blastomeres. In day 5, because you have a lot of cells, you can remove a collection of cells. Is there a laser here? Where? Where is laser? This one? Laser. This one? Okay, thank you. See here, this is the trough ectoderm, and the trough ectoderm, actually we remove between 8 to 10 cells from this side by using laser and suction, okay? And this is done very, very carefully, and it can work very nicely in the hand of good embryologists. Nowadays, we are talking about non-invasive sampling. Okay, it's like NIPT, but it is taking the culture media around the embryos because they contain some embryonic DNA, which is really a brilliant idea. You do not touch the embryo, you do not expose the embryo to the laser, and you do not harm the embryo. You do it, take a little bit, and the time is very little, minimal time. Few seconds, you take the culture medium, put it in the tube, send it to the PGT. Now, there are two types of mutations really we deal with in pre-implantation genetic testing. The first one is point mutation, and usually point mutation happens when there is a problem with base pair substitution or frame shift mutation. In our lab in Al Jawhara, we have screened about 15 sickle cell, 19 beta thalassemia, from peripheral blood, of course. What we have found that the mutation which are found in sickle cell almost are the same, okay? But with beta thalassemia, we have found different mutations in addition to deletion of introns. And once you have deletion of the intron, you get frame shift. So you lose certain part of the DNA, either by coding or physically, when it comes to globin gene. And the diseases which are produced can be like sickle cell anemia, cystic fibrosis, Tay-Sachs, and color blindness. But if you have chromosomal abnormalities, you have mutation which affects either the chromosome number or structure. Now, this number can happen because the mechanism which results in these kind of abnormalities can comprise non-disjunction during meiosis, chromosome breakage with deletion, duplication or inversion, and also translocation. Some genetic diseases involved and caused by this non-disjunction is Down syndrome, Turner, Klinefelter. All these three diseases are compatible with life. The techniques which are used in pre-implantation genetic testing can be fluorescent in situ hybridization. We call it FISH in short. It could be array CGH. It could be new generation sequencing. Also, for point mutation, we use PCR with linkage analysis and sequencing, like Sanger sequencing. Today, FISH is used minimally, really minimally, because it's dealing with 5 probes. And 5 probes does not give you any information apart from chromosome XY, 13, 18, and I can't remember the number 5. But array CGH came in the market about 2014, 13, and it stayed for 3-4 years, then it went out of the market because it was replaced with new generation sequencing with very high resolution and sensitivity. Definitely PCR sequencing are very important for studying the point mutation. The services can be provided under the same roof, which means your IVF center and PGT lab can be in the same place. And we're hoping that we'll do that in the Al Jawhara Center. Or it can be separate, which means I have an IVF center, you have an IVF center. We both can send our samples either to another lab in the country or abroad. This is a very interesting slide. Look here. This line shows you the number of abnormal embryos in patients gone through IVF, and this shows you the number of, see here is the legend, how many healthy embryo you have, how many patients have at least one healthy embryo. This is donor egg. Of course, we don't do donor egg. This is a research, okay? Donor egg, usually donor eggs obtained from women between 25 and 30 years old. They are very young and very healthy. So basically, you see abnormal embryos, only 35.9% of their embryos were abnormal, while at least 96.4% of the embryos, at least they had one healthy embryo. And this phenomena, you see, with abnormal embryos increases with patient age, and also the percentage of patients who have one healthy embryo comes down with age. So the older the patient will be, the more abnormal embryos will be obtained. Each embryo may have several types of cells. All cells. They can be normal. We call them euploid cells, and there is a very, very good chance of scoring successful high pregnancy, and it is definitely recommended for transfer. Or they can be aneuploid, abnormal, definitely. It will not give pregnancy because aneuploid. Even if it gives, it will come down. It will be miscarried. Then you have another situation when you have the whole embryo composed of two types of cells, normal and abnormal, and this is mosaic. And there is a big debate about sending back this kind of embryo. Definitely you need to counsel the patient and tell the patient all aspects of returning back mosaic embryos and what can happen in the future. Generally, the genetic data have certain characteristics. Definitely they are personal. Definitely they are predictive. They are permanent because the gene stays in your body until you depart from this world. It is prejudicial because people can judge you because of your genetic makeup. It is pedigree related because it runs in your family, and it is very, very sensitive issue. Sensitive to the limit that it can affect your personal life, your work, your career in the future. So this topic must be dealt with in a very, very careful way. The genetic test can be used in different ways. It can be diagnostic, it can be predictive, it can be used for screening, or it can be used for personalized medicine in pharmacogenetics. What is the difference between ethics and legal? Medical ethics, I am sure everybody knows here what medical ethics is. It's a system of moral principles that apply values to the practice of clinical medicine and scientific research. It is referred to in presence of conflict or confusion. في مشكلة, we go for medical ethics. Now in Bahrain, we have the ethical, which is regulatory, legal, which is law, and social, which is education. They are all amalgamated together to form for you the medical ethics. And in Bahrain, the NHRA is responsible for dictating this kind of law. IVF license is mandatory for any center to do practice. But in addition to IVF license, is there a need for extra licensing for PGT? The types of licensing, can be part of assisted reproduction policies or separate. And both of them, who will decide on that? NHRA, obviously in Bahrain. If it is separate, what are their requirements? What are these policies? How to regulate and control PGT practices, i.e. implementation of these regulations. How to assess the implementation later, and how you evaluate. It is like any other biological or medical lab that you have to design, to develop, implement, analyze the data, see if there is any defect, then you have to evaluate and correct. Like any ISO program. So when do we start? I am a provider of IVF. When do I start doing PGT? If your success rate is 10%, forget it. If your success rate is 20%, forget it. You have to bring your success rate to the international standard before you tell I am providing PGT. Because if your success rate is low, this means you're not going to get a woman pregnant. So it's all waste of time and money. So never offer PGT unless you are or you have a highly successful unit with good success rate as per international standard. Don't use PGT for commercial reasons, please. Now, what are the requirements for practicing PGT? PGT counseling must be available. It doesn't need to be available in your institute or in your center. You can always refer your patients to the expertise. Now, if we have a patient who wants to go through PGT, it must go through counseling with the right geneticist, with the right clinical geneticist who knows ins and outs of the procedure. Biopsy should be performed by trained embryologist. If the embryologist is not capable of doing it and is not competent, then damage will happen to the embryo. Diagnosis performed by a well-trained molecular biologist or cytogeneticist or scientist, but this person should have preferably the degree and experience. Rigorous quality control and quality assurance programs should be applied to the lab. The lab should be accredited by either local authority or outside authority. Then we have patient information leaflet and consents. They must be available. Excellent communication between IVF lab and PGT diagnosis lab, because I have come across certain laboratories. The clinician talks to the PGT lab like a restaurant. I have a patient wanting this and that. It doesn't work like this. Your embryos are going to stay in the IVF lab. The embryologist goes somewhere else, clinician goes somewhere else, doesn't matter. But the data should be in the system of the embryology laboratory, because these belong to the patient, not to me or not to the clinician. And every single data, starting from the order of PGT, setting up the lab to detect the mutation or the problem, until the embryo transfer, this information should be in the system of the embryology lab, or at least IVF center. Commitment to follow up the born babies. You know, in 1990, we started the IVF program in BDF. To about 15 years later, we did follow-up of the children born by IVF by Dr. Babakar Kambalawi and Professor Hafez al-Shadhili. I don't know, Dr. Kristin, if you met Hafez al-Shadhili, but God bless his soul, he went back to Sudan and he passed away only 2 years ago. We had beautiful, we screened something like 200 children, and we had very good results. Unfortunately, after that, nobody followed up the babies born by IVF. Also, the people who work in PGT should have comprehensive ethical review. Now, is this the right slide? Okay. When I looked through the literature, I was surprised. In USA, there was no regulation. There is no regulation in USA. No policy specifically allocated for PGT. In Europe, yes. There are some laws and directives. In Italy, it's called Law 40. In Switzerland, it's called VERS 2015. France, Agence de la Biomedicine, and so on. In UK, everything comes under HFEA. In Australia, there is National Pathology Accreditation Advisory Council. And in India, there is only restriction on sex selection. Now, when it comes to our countries, in the Middle East and GCC, almost all Arab countries, in addition to Israel, provide genetic services under the legislative process from the Ministry of Health, and they can collaborate with genetics, the directorate if available, like in Dubai, Emirat, but no specific regulations exist. In the line there is a lot of information free for you. You can retrieve it from the net, ESHRE PGD Consortium. They give you guideline for fish. That was published in 2011. ESHRE PGD Consortium Best Practice Guideline for PGD, published in 2011. Quality Control Standards, published in 2016. And ESHRE PGD Consortium Best Practice 2004, plus College of American Pathologists, who's now in charge of accreditation for IVF and PGT laboratories. So what happens if the PGT practice regulation is absent? It can result into absence or improper counseling of patients prior to the treatment cycle. It can give inadequate investigation of the family disease history for the genetic lab setup. It can result in lack of proper communication between IVF center and PGD lab. Also, unfortunately, it can cause misuse of technology and medical service abuse. Just a few slides to show you the results of my research. If you see the orange, these are histograms showing use of fish, fluorescent in situ hybridization. Although this technique using only 5 probes and 5 chromosomes, it's been in the business, look, from 2008 until 2017, most tests used in Bahrain is fish. For what? For sex selection? I don't know. For IVF failure? This is not the right test. So if we go to the second one, look, this is gold standard, this slide. See the yellow, 80.6% of the test made by fish technique is made because of recurrent IVF failure. How can you do this? Recurrent IVF failure needs 24 chromosome study, not 5. So you have also 13% for sex selection, which is not allowed in Bahrain for non-medical indication. And then you have 6.2, they just did it, they like it, they do Metformin PGT. For what? For what reason? Not known. Let me skip this because it needs more analysis. This is also a nice slide, shows you the comparison between the two groups. One group done XE with pre-implantation genetic testing, the second group without. So this is XE with PGT, this is XE without PGT. And if you can look into the pregnancy success rate, you will see significant difference in the chemical pregnancy and clinical pregnancy between this group and the second group. Today we know pre-implantation genetic testing increases the success rate of pregnancy in most categories of patients. And that's why we try to provide this test for 2 categories of patients, basically, recurrent IVF failure and patients who have a lot of miscarriages with and without IVF. So in conclusion, I would like to summarize the information into the following. PGT has been legalized by default, like any other service, medical service, following the evolution of technology and weighing out its benefits. The same thing happened to IVF. PGT-A for aneuploidy has become a valuable tool to resolve problems of recurrent IVF failure and recurrent pregnancy loss due to chromosomal aneuploidy. PGT facilities should acquire professional respect by accreditation, certification through specialized reputed institutes. We also need guidelines or bioregulations set by health authorities for establishment and regulation and improvement of PGT lab practices. Under umbrella of health authorities, licensing of PGT labs must be a joint venture between at least These three disciplines: molecular biology, ART, and genetics. I recommend heavily that licensing of PGT labs should be considered. Also, accreditation of PGT labs must be encouraged. Meanwhile, preparation of bioregulation draft should be prepared by the authorities to put down the important points under the umbrella of international guidelines, and also, last but not least, existing accredited experiences can provide a role model for new ones. So if we have any laboratories in the area or globally, maybe they can help us in setting up our PGT labs. One question remains. This is for the audience to think about it. Would you return affected embryo if parents insist on embryo transfer? This is in absence of jurisdiction. The embryos produced for this couple, all of them are affected. And these patients have difficulty to produce embryos. It's very complex. It is very difficult situation. This is open for people to think and to judge. I am not saying yes, and I'm not saying no. But it's up to the community and authority to decide what happens in this situation. I thank you so much. Sorry if I took more than my time. Huh? And thank you for your listening. Hi, Mubzin. Hi, Kharab.
Dr. William, thank you very much for a very informative, excellent talk. And really we enjoyed it, especially the ethics part. Because I'm not a gynecologist, they will enjoy the other parts, but really about the ethics, cost-effective, and the preclinical validity of the test which we need. Because recently I got patient with antiphospholipid syndrome. She has like 6 or 7 miscarriages, and they did like a lot of genetic tests and whatever, while the patient has a confirmed with a repetition of the test that she has antiphospholipid antibody. So the validity is of the test will be very important if she passed through the clinical examination, history, and true assessment, and then you request the test, not to request screening and test prior to the assessment. So, and she has like a very persistent low platelets, which already recently sorted. The other thing is a cost-effective, as I mentioned to you, and also we might face in coming future, especially in the Arab world and the country of GSE, the issues of and the dilemma of embryonic stem cells, because the inner cell mass, the ethics, the regulation of such things, which will be very difficult regarding the morals of, anyways, the religious part. So, yeah.
There is already legislation in Bahrain regarding embryonic stem cells, and it's not allowed. It's already with NAHRA, it's clear stem cell cells and research, and later on if therapies will be only an autologous one, not on embryonic. To be absolutely sure that everything is under control.
Yes, of course, there is a lot of research in this lineage. Patients, when they come to you, they are desperate. They are psychologically down. They are sad. It's not that you get involved emotionally. You can't help it. You will get involved emotionally. But I think in our practice, there is a list of tests that should be done, especially when the patient presenting IVF failure several times, or pregnancy loss due to immunological. Actually, we had several patients when I was in BDF. This opened the door for the clinicians to add the test which you are talking about today to the list of the initial list. Pre-IVF, is it screening or is it testing? I don't know, but they are there. Maybe we can add some more with your knowledge, because immunology is a very complex issue. It is antibody mediated, yes, but also there is cell mediated in the uterus.
Sure.
And nowadays there is a lot of modulation of the immune procedures to stop immune reaction in the uterus, in the endometrium during implantation. So, yeah, thank you very much for your comments.
Any questions? I think there is questions online.
There is one question here. Day 3 versus day 5 biopsy. Day 3 versus day 5 biopsy. What do you think?
Personally, I think day 5 biopsy is more safe for the embryo. I would like to do non-invasive using the culture media surrounding the, and I'm working on it. But day 5 biopsy, which we are doing it currently, is much better because first of all, it is protecting the embryo from laser and invasiveness of pulling the trophectoderm outside. The second thing, you have so much DNA, not from 1 or 2 cells like day 3. You have 8 to 10 cells. Even if there is mosaic, you will see it. You will see it. The second issue is it will give a lot of time to the lab, PGT lab. PGT is very labor intensive. People don't realize. I am working with them for the last 3 years. The sample comes today and the doctor there says, I want the result within 48 hours. Believe me, the technologists run. They are working 48 hours to give you the result. Why you should do this? I think you do the biopsy, freeze, cryopreserve the embryos, leave them in the protection, wait for the result to come to you because the more time they have, the technologists, the better result they give you. Sometimes they have to repeat certain processes. So it is day 5 for me. Okay. Freeze, return later, 2 or 3 months later. Is there another question?
No, I just want to highlight something that you presented regarding the bioethics. I think many times people are forgetting that all this amazing high-tech technology, it's done to make things right, to really help a couple having a child affected by a severe disease. Now, one is the screening, one is the diagnosis. But you highlighted that all these labs or centers who are offering PGT testing shall be licensed, accredited, and people who are working in these centers are highly trained and they have expertise.
If they are doing PGT, yes, PGT.
Yes, yeah.
If they are doing IVF, they are collaborating with another center outside.
Yeah, anyhow, I think
but
IVF is already
there is
regulated.
No PGT center
yes.
in Bahrain, unfortunately.
Yeah, but even the people who are referring testing, referring couples or pregnancies or for testing, they really need expertise, because if you do not ask correctly what shall be tested and the lab it's not testing correctly, you can end up transferring embryos who are actually affected.
No, here comes the role of the counseling. Somebody like yourself, the patient should be referred to you. You counsel them, you get all the data. Then you can communicate with the lab outside regarding this particular patient and their condition. The results come, then again you can go back and discuss it with it's a teamwork.
It is a teamwork, and the fact that you highlighted,
doctor,
yes.
there is embryologist,
Absolutely.
and there is yourself,
yeah.
the geneticist, clinical geneticist. Together you can come to a decision. It is not one man's
It's not,
decision.
and it's the expertise that count. This I wanted to highlight because you presented that. So expertise is very, very important and working in the team. Because in the end, what we want all together is to help that couple have a healthy child, not in the end saying that the test was done right and everything was well and the child is born affected. That would be a terrible mistake.
Yeah, bioethics is for protection of the patient in the first place, protection for you and me,
Absolutely.
for people who work. The field actually, the center, the doctor, the clinician, it is protecting all of us.
Yeah.
But in the first place, it is the well-being of the patient and protecting his rights. Because there is a lot of, as you know, unfortunately, there is abuse in the system. And I hope that by a few years later we'll have
clear
proper
legislation,
legislation for PGT.
Yeah, thank you.
Thank you very much. Yes.
With this or complicated technique with the PGT, I've seen your nice graph, like comparing the norm embryo related to the maternal age. It's an embryo. What is the role of the paternal age? And although we had earlier lecture that the maternal age can affect all these things, we are always comparing the maternal age for all these things without considering the maternal age. And in counseling, if I'm going with the patient, how can I counsel her with the maternal age if the maternal is young? This is also will affect the PGT for
Maternal age is one of the most important factors to decide whether the patient should go for PGT or not. Because
so
of
it is going more with the maternal age, not with the paternal. It's an embryo.
maternal,
So
maternal. See, with after 37, the disjunction increases in the formation of the gametes. And if the egg is having extra, chromosome 21, then the embryo which is produced, it will have Down syndrome.
But the translocation will be more with the maternal.
No.
No.
These are two different things here. So what Dr. Amaria was trying to explain, it's related with the aneuploidy. So the risk that the egg that is coming from the mom or from the father, it's having an abnormal number of chromosomes. And this is mainly related with advanced maternal age. I mean, everything is okay, people are healthy, they don't have any translocation, nothing. But if any of them, either the mom, either the future father, are having a translocation, and translocation means a chromosome from one group, it's translated in another one, and they stick together, then it's not related with the age at all. Then they must go for the PGT because the risk is very high. And with the paternal age, this is more related with the de novo things, changes that are appearing only into the DNA like a new mutation. It's not related with the age of the mom, but it's related with the age of the father. As advanced the age of the father is, mainly above 45, then it's increasing the risk that a new mutation can appear spontaneously in the DNA that is coming from the sperm.
See, if there is a translocation in the family, which means one of the parents is carrying balanced translocation, like Robertsonian, then in this case, this balanced translocation will travel to the next generation and will cause trouble.
Yeah.
Okay? But if it is de novo, then we'll find it in the embryo, but they are not found in the parents. That's what we call it lab setup, which means I investigate the parents and their families or siblings to find any abnormality. If the woman is carrying the baby and every time comes down, this means there is a serious problem. That's why we have to go and investigate the parents, their families, in the form of lab setup, then I will know what I'm looking for. Okay? واضح?
Thank you very much once again.
You want to present? We'll invite our next speaker, Ms. Tana Quintana. She has a BSc in Nutrition and Dietetics from Philippines. With more than 15 years of experience in the Gulf region, she graduated Bachelor of Science in Nutrition and Dietetics from the University of St. Thomas and implements individualized tailored meal plans and follow up until the nutritional plan of care is met. Currently, she is working at Royal Hospital for Women and Children in Bahrain.
Thank you very much, Doctora, and good afternoon to all of you. My topic is very common and very old. Gestational diabetic mellitus has been a very common and very old perinatal complication of pregnancy. And in 2019, the International In 2019, In In 2019, the International Diabetes Federation reported that there were 20 million women globally that were diagnosed or that were showing glucose intolerance, and 84% of them was from a gestational diabetic mother. And during this time, there is 1 in 6 births that have been affected by gestational diabetes mellitus. What's GDM? Everybody knows what's GDM. It is actually any degree of glucose intolerance in the onset or first recognition during pregnancy. This is a previously undiagnosed diabetes that can be recognized or can be diagnosed at the 2nd or 3rd trimester of pregnancy. And this is heavily linked to the hormones that causes contra-insulin effect like estrogen, cortisol, and human placental lactogen, which usually begins about the 20th to the 24th weeks of the pregnancy. What are the main risk factors of gestational diabetes mellitus? These are pregnant women aging 40 years and above, obese, personal history of gestational diabetes mellitus, delivery of a macrosomic baby, first degree of relatives with diabetes mellitus, personal history of polycystic ovarian syndrome, medications such as corticosteroids and antipsychiatric drugs, multiple births, races such as Asian, Middle Eastern, African American, and Pacific Islanders. Okay. For gestational diabetic mothers or gestational diabetic women, there is an allowable weight gain. And as per the Institute of Medicine, the 2009 recommendations that is based on the pre-pregnancy weight of the mother, ranging from underweight, normal weight, overweight, and obese. The 2009 recommendation has been updated. It's not only single fetuses anymore. They added the allowable weight gain for twin births. And it is recommended that for underweight women in the 2nd and the 3rd trimester, they can have an allowable weight gain of 1 pound. This is per week. For normal weight, it's 1 pound per week again. And for overweight, it's 0.6 per week, or obese patient for 0.5. There is no recommendation that says that any gestational diabetic mother should lose weight when she's diagnosed with it. As clinical dietitians, medical nutrition therapy, in all the researches and all the recommendations, especially in the American the Academy of Nutrition and Dietetics, the American Diabetes Association recommends that medical nutrition therapy is the first line of treatment for GDM. This is actually an individualized meal plan based on the particularities of the mother, her BMI, her ethnic background, her beliefs, her weight prior to pregnancy, her compliance, and so on and so forth. This should be individualized. We'll be providing you with the recommendations, but we always have to consider the particularities of the pregnant woman. The goal of the medical nutrition therapy is to achieve and maintain monoglycemia, provide appropriate caloric intake for both the mother and the fetus, avoid ketosis, promote optimal fetal growth, and avoid mother's excessive weight gain. The caloric intake of a gestational diabetic mother doesn't differ from a normal pregnancy. And no recommendation or no guide again would say that they need to lose weight during this time. There are so many studies from way back. GDM was first diagnosed. They were giving very restrictive diets, which causes maternal ketonemia, which has a very negative effect to the baby and the mother, or a very liberal caloric intake that doesn't really help with the glycemia of the mother. And the recommendation says, this is from the Institute of Medicine, and the American Diabetes Association recommends that any underweight gestational diabetic mother is required to have 35 to 40 kilocalories per day And a normal weight of for normal weight 30 to 34 kilocalorie per kilogram per day, overweight 25 to 29 kilocalorie per kilogram per day, and for obese patients 24 kilocalories per kilogram per day, or less than 30 to 33% of the total caloric requirement of the mother, not less than 1,600 kilocalories per day. Among all the macronutrients, carbohydrates has the greatest impact on the blood sugar of the mother, and we all know that. As per the American Diabetes Association and the Academy of Nutrition and Dietetics, and even the Institute of Medicine, recommends a minimum of 175 grams of carbohydrates per day, being represented at 35 to 50 of the total caloric requirement of the pregnant woman. This can be divided in 3 main meals, but there is no strict rules that says that this is the exact distribution that we use for this patient. But it can be used 3 meals per day or 3 snacks. The breakfast should be 10 to 15% of the total carbohydrate requirement. The lunch is 20 to 30%. Dinner is 30 to 40%. And the 3 snacks would be divided into 5 to 10. The 3 snacks is 5 to 10% of the total caloric requirement. But then again, the problem lies in breakfast. The postprandial breakfast glycemia of the patient. That's why even if we follow this distribution, we always have to consider the particularities, the actual needs of the certain pregnant woman. And in breakfast, the least that we could do is to lower down the carbohydrates to 15 to 30 grams of carbohydrates in the morning, because we have to remember that cortisol secretions happens in the morning, which usually affects the postprandial breakfast glycemia of the patient. So if you're having a hard time trying to control the PPBG of your mother, try to adjust the carbohydrates and try to give them within the range of 15 to 30 grams in the morning of carbohydrates. Protein. Protein is very crucial for the development of the baby. And though it doesn't have much effect on the glycemia of the mother, for gestational diabetic mother, there is no difference from any normal pregnant women. The protein intake minimum recommendation by the American Diabetes Association is 71 grams per day in pregnant women. This is just a minimum. But then, we usually adjust the amount of protein based on the gestational age of the baby, because the demands are higher when the baby gets bigger, or when the ages gets more. So from 1.2 grams per kilogram per day at 16 weeks, we increase it to 1.52 grams of protein per kilogram per day at 36 weeks, just to fulfill the demands of the baby and the mother. Let's go to the fat. What the research has said and studies has shown is that the fat or the lipid allowance for these pregnant women is only limited to 20 to 35 degrees from the total caloric requirement. Because what happens usually is that, irregardless of the diet the patient is, if they try to restrict the amount of the amount of carbohydrates that they give to the mother, what happens is they tend to give more lipids. Because this is the easiest manipulation when we try to balance out everything, which is actually wrong. Because if the triglyceride levels and the fatty acids levels are very high in the maternal serum of the mother, macrosomia happens because of the amount of fat that we give to the baby. So the recommendation has said 20 to 35% of the caloric intake, the total caloric intake of the mother. 7% will only go to the triglyceride or the fatty acids. The rest will be distributed to polyunsaturated fatty acids, monosaturated fatty acids, and the omega-6. The vitamins and minerals needs of the pregnant women or the gestational diabetic mother can be taken from a varied and correct diet, with the emphasis that we give Iron, which are the foods that are high in iron, folate, calcium, vitamin D, choline, and iodine. But then again, in practice, we usually supplement them with a multivitamins for pregnant women just for them to meet the dietary reference intake of a pregnant woman to avoid the further deficiencies later on in the pregnancy. Sugar substitutes, these are your artificial sweeteners. The FDA approved these types of artificial sweeteners, and most of them are available in Bahrain. But you have to remember, the way we give the sugar substitutes should be on the acceptable daily intake. These are the milligrams multiplied to the actual weight of the gestational diabetic mother per day. And most of these pockets or sachets that are available in the market right now comes as a grams. So for example, for Splenda, which is very common here in Bahrain, the allowable amount is 5 grams per kilogram per day. So if you have a 100-kilo mother, it's only 500 grams. So it's just half of Splenda. So we do not tell them, or we encourage them to have a maximum of 3 or 2 sachets of sweetener per day. And again, there are other forms of sweetener, not just the sugar. There are diet sodas and so much diets that are actually have sugar substitutes. So we have to be very careful in telling them and how or the exact amount of sugar substitutes that they can have. For the caffeine content, there is no specific recommendation that they say that the GDM mother or a regular pregnant mother can have. It's the same. So an allowable of 200 milligrams of caffeine or coffee per day is given to the patient, which we usually tell them that a cup of coffee per day or two teas per day is allowed for a pregnant woman. In the new researches of interest from 2019 that they came out with, I just chose the one that has relationship to my field. So they said that plant-based diet, or what we call the Mediterranean diet, has a very high link to prevention of type 2 diabetes because of decreased gastric emptying, insulin sensitivity, and the secretion of insulin is being, insulin secretion is good. And they were saying that plant-based diet is the best diet for gestational diabetes mellitus because of its enhancement of the antioxidant compounds. We all know that gestational diabetic mothers has higher inflammatory markers and oxidative stress. And they were saying that having a plant-based diet will modulate this antioxidant stress and inflammatory markers for a gestational diabetic mother. By the way, a Mediterranean diet is a diet that is high in whole grains, nuts, seeds, fruits, and vegetables. But then, this is just an interest of research, and it needs more research and studies to prove them right. Okay. As a milestones of gestational diabetes mellitus, they have recommended that having medical nutrition therapy with exercise and frequent blood sugar monitoring is very important. And exercise was proven that it helps in insulin sensitivity. Any aerobic exercise, unless the pregnant woman is not allowed to have an exercise, can be, and these are walking, swimming, biking, prenatal exercises, and mild to moderate resistance exercises, both types being beneficial through increasing insulin sensitivity of the mother. 30 minutes of physical activity per day is recommended and can be fractioned 10 minutes per round after that. the self-monitoring of the blood sugar levels. The SMBG 4 times a day is the recommended blood sugar monitoring, fasting 1 hour and 2 hour postprandial in the first 2 weeks after the diagnosis. If over 50% of the measurement are elevated during these 2 weeks, we should consider insulin therapy, in which case the patient will need at least 3 tests a day and nocturnal evaluations of the glucose levels. If the patient does not need insulin therapy, SMBG should be performed once a day on a rotation schedule along with 2-point profile per week. SMBG is very important because this is when we try to explain to the patient the importance of the medical nutrition therapy and the exercise and their effect to their blood sugar so that the adherence to the medical nutrition therapy or their individualized meal plan would be very good. So, for the conclusion of my presentation, any patient diagnosed as gestational diabetes mellitus was strongly advised and recommended by the American Diabetes Association as well as the Academy of Nutrition and Diabetes recommends that any pregnant women should be referred for a medical nutrition therapy right away when they are diagnosed, and to have an individualized meal plan so that their blood sugar levels would be normalized. And among the high-risk factors of GDM, there is one changeable risk factor that we can help our patient, and that's being obesity or being obese. From 2019 through the pandemic, we've seen the rise of obese and overweight pregnant women. And just for every one of us, and healthcare providers and all these physicians here, it is our responsibility to help these women from anyone on the reproductive age to help them achieve a very good weight prior to conception. Thank you.
Thank you very much, Ms. Tanak, for such a nice presentation that it's emphasizing again what Hippocrates said 100 years back, let food be your medicine. And I truly believe, I'm an advocate of what food can do for your body, and I truly believe that having a medical nutritionist in the team, it's indeed bringing an amazing help to manage serious medical problems.
Actually, Dr., there's even a research that said that 70% to 85% of GDM mother who has had medical nutrition therapy were able to obtain and maintain glycemic control.
Absolutely. If there are any questions for Mrs. Tanak, I want to ask you something, because from genomics perspective, I'm also looking to nutrigenomics. I want to ask if you ever run a nutrigenomic profile for these ladies for whom you create the diet plans.
Unfortunately, Dr., no, nutrigenomics
Not yet.
have never, but I've had a series of trainings and I've read all about nutrigenomics.
Yeah, maybe we can collaborate to help them better. Because in the moment when you create a nutritional plan according to the variants in the genes, you help them, the body, to answer much better to your plan, and you can adjust your plan accordingly.
Yes, Doctor, that's very true.
Yeah. Thank you very mumuch. Any questions, Dr. Mariam?
Yes, Doctor.
We have a lot of craving habits. Thank you. We have a lot of craving habits in our societies. When I was in Europe, I didn't see that.
No, it's happening.
It does?
Yeah. I think, Doctor, that is hormones. But then what we notice, and in the research and studies, they said that if your sugar is spiking, your craving for sweets is very high. And what we've noticed in GDM patients who goes to our clinic, this is from my experience, Yani, prior to being diagnosed, their eating habits are not really very good. When we do a recall of what they're eating, it wasn't really very good. Their sodas, their sugars, it's too high. Because when your sugar spikes, your hunger for sweets, when your sugar drops, you're very hungry. So, I mean, they wouldn't want something that's salad or chicken. They would something that is sweet or glucose. So, I think even if we put them on a certain diet afterwards, like a healthy meal, their blood sugar will change dramatically.
Can I add, do you know, in my mother and my grandmother generation here in Bahrain, they crave to eat non-edible material. Honestly, like charcoal, like
that's pica,
like
doctor,
tobacco,
right?
like tobacco, burnt tobacco, charcoal, they will not lead to gestational diabetes, but my question is that part of imprinting? In genetics, you know?
There are some studies into that.
Yeah.
That there is motivating epigenetically. Yeah, can be.
It might be related to epigenetics and genetics because if you, I think, screen your Y chromosome, you might discover that you were part of Africa, your descent, because we have a lot of tribes, like Nubian tribes in west of Sudan. Their women, when they're craving, when they're pregnant, mainly to charcoal, and they're eating charcoal heavily. And sometimes different things, which is very strange from their nature, from their local nature. Yes. So definitely the same like what's happened if you have a pre-genetic predisposition, but the environmental factor will be the trigger. So it seems to be so.
This generation crave on strawberries, mangoes, you know, caviar, but...
No, Doctora, the generation now is craving is junk.
Unfortunately.
Yeah.
Thank you.
Thank you very much. There is a break of 30 minutes now, and before closing the session, in line with what Mrs. Danach presented, I want to say that we get in clinic, in my clinic, for example, patients who are referred for a genetic evaluation because of infertility and because of miscarriages. And when you do the evaluation, you don't find a genetic component, stringent one, and actually it's obesity. And people are not trained and educated to understand that that's a very, very important factor against fertility capacity, both in women and both in men, not only for the future mom, but also for the future father. So adjusting the weight, it's the first step towards achieving the normal fertility, and it's nothing related with the purely genetic changes that make that person infertile. So having the right diet and education and awareness then will really preserve the future generation, as was the right hopeful start for the fruitful future, right? The hopeful start shall be with the right weight of both parents, not only of the mom. Okay, thank you very much. Thank you to all people.
Assalamu alaikum. Good afternoon. Welcome to session 5 of the MAC2 Congress. I hope you find all the sessions are beneficial to you. This session is women and women health. I'm glad and proud to present our next speaker, Dr. Tariq Al-Ma'addawi. Dr. Tariq Al-Ma'addawi graduated in 1980 in Shams University in Egypt, which is actually the same university I graduated from in 97, where he got his master's degree in urology and psychological medicine, as well as his PhD degree in psychiatry. He got a diploma in psychiatric practice from London University before coming to Bahrain. He was director of mental health in Egypt, Ministry of Health, and representing Egypt in EMRO and the WHO. Head of psychiatric department and IHB 2002 to 2008, head of psychiatric department 2009 to 2016, Ministry of Interior. Participated, attended, and giving presentations in ECNP conferences and CCC conferences from 2002 till now. Currently working in private clinic and Royal Hospital for Women and Children. So we'd like to welcome Dr. Tariq for his next speech. Thank you.
Bismillahirrahmanirrahim. Assalamu alaikum. Thank you, Dr. Ashraf, ala great introduction. Today we're going to talk about women mental health. It will be an overview about what is going to women in general. Okay. Women mental health, or health generally, refer to health of women which differs from that of men in many unique ways. According to WHO, health is defined as a state of physical, mental, and social well-being, not only the absence of illnesses. Women and men are different in their obvious physical attributes and also in their psychological makeup. Women and men differ in the way they communicate, deal in relationships, express their feelings, and react to stress. First, what is mental health? As I mentioned previously, definition of mental health, the absence of mental illnesses. Currently, mental health it is how we think, deal, feel, and act in order to face our life events. It is how we look at ourselves, our lives, the people we know and care about. It also helps to determine how we handle stress, relate to others, evaluate our options, and make our choices. We have a lot of misconceptions about mental illnesses. We have something like, as physicians, like a dichotomy in our thinking that mental illnesses are not real illnesses. a survey was done, and I'll tell you, was done with in almost 15 years ago. What do you think the cause of depression? Number one, weak personality. Number two, lack of faith. Number three, bad parenting. Number four, being possessed by a genie. Number five, a medical condition. 5% said medical condition. This survey was done on GPs, general practitioners, in California. Imagine. So mental illness is not a real illness. So mental illness is a real brain lesion. Now with the PET studies, with the functional imaging of the brain, we see those who are having depression, for example, having an inflammatory process in the hippocampus. Those who are having anxiety-related disorder, having inflammatory process in the amygdala, OCD, schizophrenia, and so on. So we are dealing with real illnesses. Again, mental illnesses are rare. An epidemiological study done also maybe 10 years ago or so found that 48% of any population are having mental illness. 48%. So we're dealing with not rare conditions. Mental illnesses are difficult to treat. It is like any chronic illness. If we can discover the illness in the acute phase, it's curable. Any condition, even psychotic episodes. But if we leave it as usual, because we see patients third hand. First, GPs, second, traditional healers, then finally going to the psychiatrist. So unfortunately, most of the patients we see in the chronic phase. Mental illnesses are expensive to treat. Currently, no, it's affordable. And the government as well is having almost all the medication in the governmental hospital. So, as I mentioned, mental disorders can affect women and men differently. Some disorders are more common in females, like depression and anxiety. Schizophrenia, both. OCD in female more than male. Generally, mental illnesses 3 times in females more than males. Some women may experience symptoms of mental disorders at times of hormone change, like prenatal and postnatal. I'll go to this after a while. Woman, a life cycle of vulnerabilities, hormonal and biological. These are the indulging factors. Why? Why women are more liable to mental illnesses? The biological, first, a firm patriarchal lifestyle, family system, and usually when a woman becomes mentally ill, services are sought infrequently and late. The gender discrimination, woman is looked as a negative partner in any relation, and lack of dependency. According to WHO, depressive disorder account for 41.9% of disability from neuropsychiatric disorders in women, compared to 29.3% in men. Leading mental health problems of elderly are depression, organic brain syndromes, and dementias. They are more frequent, more common in females. Lifetime prevalence rate of violence against women varies from up to 50%. 1 in 5 women suffer from rape or attempted rape. We'll start with the premenstrual mood changes. Psychological, like depression, anger, and anxiety, irritability, sensitivity to rejection, social withdrawal. Physical, like fatigue, sleep disturbance, eating disturbance, breast tenderness, headache or pain in ankles and joints, and swelling of the extremities. This is the premenstrual mood changes. We have something, we call it premenstrual dysphoric disorder. This is a severe form of what I mentioned. The same symptoms, but in severe form. And it affects 3 to 5%, to 8% of women in reproductive age. It is a severe form of premenstrual symptoms, and it leads to deterioration in academic, family, and social functioning. Treatment, number 1, reduce stimulants, reduce alcohol, proper sleep hygiene, regular exercising. If these fail, we have to go to medications. And SSRIs are the first line choice of treatment here. Calcium or hormonal treatment as well. So this is the premenstrual. What about during conception? Conception is an emotional state of woman, emotional time, very emotional, especially first pregnancy. Panic attacks, obsessive symptoms, eating disorders. I'm seeing a lot of patients for the first time during pregnancy having these symptoms. If these symptoms reach the diagnosable condition, we have to start the treatment. And we can have treatment. SSRIs can be given during pregnancy except paroxetine, which is the Ceroxat. Apart from this, all SSRIs can be given in pregnancy, even the first trimester. By the way, we have a medicine, I'm always telling this story, called lithium. We give lithium in bipolar disorders. Lithium is contraindicated to be given in pregnancy, and legally, if I give a woman taking lithium certificate that she is under lithium, abortion is legal. I remember one case, she was bipolar and she was maintained on lithium, and then she told me that she's going to marry. I told her, okay, make sure that we have to switch the lithium to something else because it's 100% teratogenic. She was coming to me every 3-4 months. Maybe 6 months later, I saw her coming to my clinic, and what? Did you come? Did we change the medicine? Doctor, خليها على الله. Yes, على الله, but this is, I sent her immediately to one of my colleagues. He said to me, absolutely fine. Did the ultrasound, absolutely fine, and she delivered a beautiful baby. I can't forget this story. But we have to say that in books, yes, some medications are not allowed. Infertility. In the first conference, we have a long session regarding infertility, common manifestations, anger, anxiety, depression, marital problems, sexual problems, social isolation, low self-esteem. طبعا اللي ما بيروحوش لدكتور حاتم يعني، اللي بيروح لدكتور حاتم ما بيحصل لهمش. We have a lot of therapies regarding dealing with infertility, mainly psychotherapy. Different type of psychotherapy to increase the coping strategies, to improve the cognitive dysfunction, because we see that in the depressive symptoms something we call toxic thoughts, or thinking errors. So in CBT, we try to identify these thinking errors and train the couples or the patients to how to deal with their problem. This is counseling, psychotherapy, the examples, the interpersonal, the cognitive behavioral therapy. And psychotherapy can be very helpful for anxiety or depression, whether delivered individually or to couples or group therapy. So we spoke about premenstrual, during conception, infertility. What about postpartum conditions? We have three main postpartum problems. Postpartum blues, which occurs up to 80% women, and usually within from first week to 2 weeks, tearfulness, anxiety, insomnia, irritability. Postpartum depression, this is the most important one because it's 10% within the first month and can be delayed up to 6 months as well. Depression, which might reach to severe form of depression, guilt feelings, anxiety, fear of harming the baby. I don't know whether did you hear this from your patients, that doctor, I can't carry because I have the feeling that I might harm him or her. The worst condition is postpartum psychosis. Alhamdulillah, it happens in low percentage, but it occurs also within the first month, but up to 1 year. This is disorientation, delusions, hallucinations, and rapid mood swings. You know what I mean by delusions and hallucinations, right? Suicidal and homicidal as well. We've seen, unfortunately, many cases of mothers killing their babies and trying to kill themselves after that. What are the risk factors for postpartum conditions, generally speaking? Women with previous history of depression or anxiety, stressful event during pregnancy, premature or complicated birth, women with previous history of postpartum depression reaching up to 55% that she might develop again, or having physical illnesses. Those who are having diabetes, 50% more likely, thyroid problems, almost 30% more likely to have postpartum condition. The main symptoms of postpartum depression: depressed mood, feeling down, loss of interest in daily activities, lack of interest in the baby, inability to sleep, intrusive, obsessive thoughts, thoughts of hurting the baby, suicidal or homicidal thoughts, loss of appetite, anxiety, and panic attacks. What to do with postpartum depression? It's a serious condition. Antidepressants, SSRIs, mainly. Here we can give paroxetine after delivery, sertraline or citalopram. Very low level in breast milk. Cognitive behavior therapy is very effective in targeting the negative thoughts. It teaches the patient about automatic obsessive thoughts, common cognitive distortion, assumptions and beliefs, skills, training, and examining and challenging the cognitive distortions and thought recourse. These some of the techniques we use in CBT. It's very effective, and it is evidence-based that it helps. Not other kinds of psychotherapy, like analytical therapy or cognitive behavioral therapy is the best. We might reach ECT. ECT, as I'm always saying, the safest, fastest, strongest antidepressant we have. Safest, the only possible side effect of anesthesia. Because we do it modified way, giving general anesthesia, and then starting the session. There is no any possible other side effect. And fastest, from second session, we do it twice a weekly or 3 times a week according to the severity. And from the second session, improvement. When we give SSRIs or any antidepressants, it takes usually 2 to 3 weeks. So in severe cases, ECT is preferable. What about menopause? So we reached menopause now. Women may experience a wide range of feelings, from relief to depression and anxiety. Some women might experience significant depression before menopause, 2 to 5 years, starting because there is a lot of misbeliefs regarding menopause. How to treat menopause and mood changes? Again, hormone therapy, psychotherapy, or we can reach up to the antidepressants if it is severe enough. I told Dr. Ashraf that I'm trying to do it quickly. So, conclusion, gender differences have an impact on mental health and the experience and course of women's mental illnesses. There are a lot of misconceptions regarding mental illnesses. Mental illnesses in females are 3 times more than males. Comprehensive gender-sensitive mental health care delivery is very important. Effective preventative measures are highly recommended, like awareness programs, early detection. Early detection is very important. WHO put a beautiful program, integration of mental health in primary care, especially for early detection, to teach the primary care physicians how to early detect the mental health problems, generally speaking, and in women. I hope I didn't exceed my time.
Not at all, Doctor.
Thank you.
Thank you, Dr. Tarek. Floor is open for discussion, please.
Thank you, Dr. Tarek, for this very comprehensive and informative lecture. I just want to ask one question. Why the ECT, so long that it is the safest and fastest, you keep it the last modality of treatment?
Stigma. Because of the stigma. Stigmatized. ECT is stigmatized, unfortunately, everywhere. Because when we say electroconvulsive therapy, because we all have the memories of the old movies and the convulsions. Now it's not convulsive, by the way. By the way, currently we say it is brain modulating sessions. There is no convulsions, but people, when we come, especially parents, parents usually refuse it. But when we give it, if we have a recurrence, they ask for it.
I think that anything at the beginning will have some resistance, but why it's not taking its place in the modalities as the premium?
No. It is
why this stigma is not changing?
For the severe form, if I have a severe depressive episode, we have rating scales. We can severe. In severe, usually I tell them we'll start with ECT or psychotic, severe or psychotic depression. My first choice is ECT, definitely.
Thank you.
And ECT equals admission. So hospital, ECT.
Actually, if I may comment also from my part as anesthesia, now ECT is done under anesthesia, full anesthesia, and the patient is fully relaxed during the session, and convulsions are not a must for the effect because the patient is already sedated and given a dose of muscle relaxant. And all of this to, like Dr. Tariq said, to ensure that the treatment is neuromodulation rather than it's a torturing module of treatment as precipitated in the public mentality through the movies and the bad picture about electricity in the human body. Especially also the way of even some sentences with the electric. So any electricity touching the body, it has a big issue to the human being when you tell them it's therapeutic. So approximating the relation from therapeutic to a fatal, it's a very difficult task to be done. It needs a lot of effort and needs lots of education to the public to start accepting this very nice, very safe, very comfortable modality of psychiatric treatment.
Thank you. Why it is fast? Antidepressant generally works on a process called signal transduction. It acts on the first messenger, G proteins, then second messenger, phosphoinositol, then gene expression. So it takes 2 to 3 weeks to reach this. ECT acts directly on the second messenger. It modulates the second messenger, then the third messenger in few days. So that's why it's that fast. Sure.
Sorry, are there any studies on an ECT for premenstrual dysmorphic disorder, dysphoria?
If it is having this depression,
Yeah.
within this dysphoric syndrome is mounting up to be severe, yes. Any kind of depression.
Okay. Because it's more like a switch. It's a bit depression with a bit of anxiety, a bit of unsureness and uneasiness. That's what they usually come with, and it's not so much a few days PMS like it was encountered before. A few days before the period, it's become a longer period. This is what I see with my patients, at least. It's sometimes starting from ovulation and then continuing for 2 weeks. And it's not considered a severe form, or they go for treatment. They're like, I'm normal. It's just with age, it's just getting worse.
That's why usually I prefer the clinical and psychometric rating for the severity.
Okay.
I brought to the hospital, by the way, many rating scales. I don't know whether they distribute it or not.
Yeah.
How to assess the severity of anxiety, the severity of depression, the severity of obsession, obsessive disorder.
Okay.
So it's available.
Okay.
So we can use these.
In Royal Bahrain, in Royal Hospital, sorry.
Yeah.
Oh,
yeah.
okay. We're in Salmania.
But it is very known.
It's a scheme, yeah.
Scales.
Yeah.
We have the Hamilton rating scale for depression, Sheehan
yes.
rating is a scale for anxiety. It is worldwide validated and very, very fruitful.
Okay. So you recommend in a way we scale them first, or like rate them first, and then according to that.
Yes.
Sure. Yeah, I think so. Thank you.
Dr. Hassan?
Dr. Tariq, for this very good lecture.
Thank you.
Number one, regarding the post-ECT amnesia, how long does it last and can be permanent? This is my first question. Number two, yes, ECT, as I read before and from your lecture, it can be very fast, but the maintenance, is there any difference in the maintenance between medications, which is antidepressant, whatever the type, and the ECT, or there is no difference? Because if there is no difference, then definitely you might wait if it's not that very severe depression or depressive psychosis, something like this.
For any depression, I'll ask you the first question first. Usually, the amnesia is temporary, usually, especially if we do the ECT unilateral. The old techniques of giving bilateral ECT, this technique leads to amnesia for prolonged period. Usually, the amnesia, luckily enough, the patient forgot what happened during the episode, what happened during the hospitalization, but not short term, and usually it recovers after that. But unilateral ECT, especially if we give it on the right side, is preferable to reduce the amount of amnesia. The second question, we have something called resistant depression. In resistant depression, ECT is one of the modalities. We give ECT full course, 12 sessions, then maintenance monthly session. So there is maintenance treatment with ECT. But if we give ECT to facilitate the improvement and we'll continue with the medications, we'll go through the 3 phases. We have acute phase treatment, maintenance phase treatment, then the discontinuation phase treatment. And usually 6 to 12 weeks, the acute phase treatment. The maintenance phase treatment is from 6 to 12 months. Then the discontinuation, again, according to the severity and according to the presence or absence of psychotic symptoms. Thank you very much. Thank you.
Thank you, Dr. Tariq, for the nice lecture and nice clarification. Now we go to our next speaker, Ms. Intisar Saleh. Ms. Intisar Saleh is a Bachelor in Physiotherapy at Al-Ahliya University, Bahrain, having been physiotherapy for the last 7 years. She treats musculoskeletal disorders, sports injuries, women health, rehabilitation, after sports operations, as well as postpartum care and rehabilitation. She's also specialized in treating orthopedic and spine. She provides she's a Mulligan practitioner, CMP, facial manipulation practitioner, FMP, and post-surgical rehabilitation, medical tape practitioner, and certificate in spine mobilization technique. Currently, she is working at the Royal Hospital for Women and Children, Bahrain. So, welcome, Ms. Intisar, and good luck with your talk.
Thank you, Dr. Ashraf. Assalamu alaikum. My presentation for today, it's about the relationship between the pelvic floor and the back pain. It's a slide. Okay. This one. So, first of all, the pelvic floor is base of a group of muscles referred to your core. These muscles are located in your pelvic from in front, the buttock, to the coccyx in the back, and also side to side. So the pelvic floor work with your deep abdominal muscles, deep back muscle and diaphragm also to stabilize the spine. They also help to control the pressure inside your abdomen to deal with pushing down during lifting or during exercises. So the pelvic floor for men support the bladder and the bowel, and for women support the bladder, bowel, and uterus. So just a quick review for the layer of the pelvic floor. It's included 3 layers and also the pelvic wall. First layer, the bulbocavernosus, ischiocavernosus, external anal sphincter, superficial transfer perineal. For the second layer, deep transfer perineal, sphincter urethrovaginalis, compressor urethra, and external urethra sphincter. For the third layer, levator animuscle group and the coccygeus. And also for the pelvic floor, obturator internus and the piriformis. So, are the muscle overactive or underactive? For overactive, we have high resting tone, pain and tenderness during the palpation of the muscle, and also tightness, and this muscle to be decrease the ability to relax. This for the overactive muscle of the pelvic floor. For the underactive floor muscular, it will be low resting tone, decrease the ability to relax. So the referral pattern of the pelvic muscle, posterior pelvic floor muscle, levator animuscle group, coccygeus, and sphincter. For the obturator internus, refer to the pelvic region as well as posterior thigh, and for the piriformis, refer to the pelvic region, posterior and lateral thigh, and sacral region. For the iliopsoas, ipsilateral lumbar spine discomfort can refer into sacral and buttock region. Refer pain can extend into the anterior groin. Due to its orientation with the body, it has influence on the pelvic floor and catheter system. So, pelvic floor dysfunction is inability to control pelvic floor muscle. There can be too much or not enough tension of the pelvic floor, resulting for back pain and stress incontinence or inability to complete bowel movement. It's also something that can be mistaken for back pain. So the job for core muscle is to support the torso and to stabilize it with movement. If they are not working properly together, so the torso and the pelvic become unstable, and you are more likely to experience back pain and posterior pelvic pain in the sacroiliac joint. So what is the causes of pelvic dysfunction? Weakness of pelvic floor muscle, tightness of pelvic floor muscle, vaginal dryness caused by lack of estrogen during menopause, tight inner thigh muscle. Different dysfunction that can ultimately lead to pelvic dysfunction that the back pain itself can also cause dysfunction. People have pelvic floor dysfunction. Women make up the majority of cases since pelvic floor dysfunction can result from pregnancy, childbirth, and endometriosis. How to improve the pelvic floor muscle? One of the major goals in the physiotherapy, how to improve the pelvic floor muscle, it's about to reactivate the muscle again or wake up the muscle, the core muscle, to help stabilize and support the pelvic and the spine to prevent the pain. So we have 4 points. Find the right muscle by examination the patient, the bed examination and the clinic. To identify your pelvic floor muscle, stop urinate in the midstream. So identify the pelvic floor muscle. You can do the exercise in any position. But the last research say the better time to do this exercise in the morning before any activities. So find the right muscle, perfect your technique, maintain your focus, and repeat 3 times per day. So it's 3 steps. Squeeze the muscle, like squeeze your muscle from a urine. That will make lift the uterus up and back. Hold for 3 seconds and repeat for 3 times per day. That's it. Quick presentation.
Thank you, Ms. Tassar.
Any question?
Floor is open for discussion.
Three questions, actually. One gynae, one obstetrics, one infertility. For the obstetrics, do you recommend the antenatal exercise?
Sorry, I can't hear.
Do you recommend the antenatal, the exercises during pregnancy?
Yeah.
Or it is just a business?
No, we recommend, actually, we have in the clinic also, patient with weak muscles. They are already pregnant.
No, for all pregnant ladies, not for weak muscles. For all pregnant ladies, do you recommend an antenatal classes, antenatal program?
Yeah.
For exercise?
For exercise.
Or you have some restrictions, being afraid from preterm contractions and preterm labor?
No, we recommend to do this exercise for all.
For all?
For all.
Right. The second question, for the patients who are going through infertility treatment, do you have a program for exercise to relieve their anxiety and depression or any psychological disorder they have? You have a program of exercise or a pattern or protocol for this?
For infertility, exactly, there is no. But we give them just general exercise, like the breathing exercise, stretching, strengthening exercise for the core and for the pelvic.
Let me interrupt you. I mean, if I have an infertility program, when should I send for you the patient pre or after the management to relieve her from any anxiety of the medications or of the unfortunately, if she is not pregnant, from being psychologically disturbed? How exercise can help in overcoming this mood?
I don't think the exercise will help in this.
To not help?
No.
To not help. Okay. Thank you.
Welcome.
Well, actually, I might comment on this question because actually my next talk is related to pain and to exercise. We use a lot of exercise and physiotherapy in pain management. In preparation for pregnancy, it's not only when the woman gets pregnant, it's preparation already since the day she thinks that she is going to have a child. Then the preparation starts for her by fixing the diet, fixing the sleep pattern, fixing the sleep cycle, and going to physiotherapy to strengthen the back muscles, the pelvic muscles, like Ms. Antasar said, stretching exercises to give some laxity for the tendons of the muscles to tolerate the burden of pregnancy and the burden of delivery. So the preparation of a woman to have a child should actually start from the day she thinks I'm going to start having a baby, not when she gets already pregnant. That will help a lot. So I think with infertility, yes, a program can help them prepare their body to stand the stress, even for the hormonal changes that is given to them, to prepare their body for IVF or in vitro
This is
fertilization.
a routine. Well, we refer them just in case, and this should be, there is a protocol for this for all patients who are planning to have a baby or already having early pregnancy. Well, it is just upon the request of the doctor or upon the request of the patient.
No, actually it should be for everybody because so many exercises that we do are not related to the muscles, are intended to be strengthened for delivery. Now we're speaking about pelvic muscles per se, so even people when they think that they are athletic, they might be doing other types of exercise that is not involving this particular type of muscles needed for the delivery and for pregnancy. So I think it should involve all the patients, should have a physiotherapy visit to prepare them and to prepare their body for the burden of pregnancy. Thank you.
Doctor, even if they are athletic or they do exercise daily, but when we talk about the Kegel exercise itself, it's a deep muscle, so they need to learn how to deal with these exercises. So they need to learn exactly how to do the squeeze, because it's difficult, it's hard for the patient.
So now I think, Dr. Ansar, you have to find a program for antenatal and for the IVF to prepare them for the pregnancy and prepare them for the burden of the hormonal changes that will happen.
Inshallah. Thank you so much.
Thank you. Now we'll come to the ختامه مسك, the final presentation for this wonderful conference. Our coming speaker, Dr. Ashraf Rifai. Dr. Ashraf graduated from Ain Shams University as well, maybe 18 years after me. Got his Arab board, King of Bahrain Fellowship, Pain Management from King Faisal, very known hospital in Saudi Arabia. More than 20 years of experiences in anesthesia, intensive care. Worked nearly 11 years in pain management. Currently, consultant anesthesia and pain management, Royal Hospital for Women and Children in Bahrain. Please welcome Dr. Ashraf. He is going to give us a presentation regarding pain management on obstetrics. Please, Dr. Ashraf.
Thank you, Dr. Tariq, for the nice presentation. It is the last lecture in the conference, but I hope it's not the least. Now, when we speak about pain management during pregnancy, everybody thinks about delivery pain and the labor pain and everything, but that is, it's for a few hours, and there are techniques for managing that, but we don't forget 9 months of pregnancy. So what does pregnancy does to the body, and how does this relate to our pain? There are lots of changes. There is the enlarging uterus. It alters the body center of weight. And there is joint laxity caused because of the release of hormones and alteration in the levels of estrogen, progesterone, and other hormones necessary for pregnancy. And also the fluid retention that is very well known as an effect for the hormones and the high levels of hormones. Basically progesterone, which maintains the progesterone all over during the pregnancy. And if we look into the pregnant women, almost all women complain of musculoskeletal problem to some extent. 1/4 of them actually the pain or the problem is disabling. And spinal pain was the most common and most frequent one. But other common problems also persist: lower and upper extremity pain, muscle cramps, and peripheral neuropathies like carpal tunnel syndrome. We're going to mention them as mention only during our talk. Musculoskeletal problems have been shown as a major source for disability, loss of work among pregnant women, and also it is so much related to depressive attacks, whether during pregnancy or the postpartum period. Now, pregnant women are at risk to receive suboptimal care because there is lots of taboo information or incorrect information about so many medications and treatments and treatment modalities that will affect the baby, it will affect the pregnancy. So everybody is afraid to touch a patient who is pregnant with a baby. So this is one point. And the other point, the pain during pregnancy is actually understudied. So many pain conditions that we don't know how much is the incidence during pregnancy and how much the incidence in the postpartum. Despite that they are common pains and we have good percentage of population suffering from such diseases, but it was rarely that it's tackled when these people get pregnant, what will happen to them. So our talk today is not actually to find or to treat particular diseases per se, or when we say back pain, that's how you treat it, neck pain, that's how you treat it. It's rather like a presentation for a protocol or guidelines how to approach the patients with pain and what are the relation between the questions you ask him and the pain that you are looking for to properly direct the patient in the right direction. We're going to see now the types of pain we're going to that the woman suffers during the pregnancy. We have hand and wrist pain and elbow pain, shoulder, neck, back, low back, hip, knee, ankle, foot. These are all caused by pregnancy, and actually they progress with the pregnancy, as we can see here in the first trimester, second trimester. Most of the numbers are maximum in the third trimester before delivery. So all these pains are quite, actually they are severe and annoying to the patient. Now also we can see here a graph showing the percentages of the rate of complaints. Low back pain shows the highest. Back in general, upper and lower back, it is the second highest. Hand and wrist, hip pain, ankle and foot, knee, neck, shoulder, and elbow. These are very common pains in the pregnant woman and because of pregnancy itself. Muscle cramps, it is very important because so many ladies, they suffer from muscle cramps and their sleep at night is very much disturbed and the time when she needs the proper full sleep. Carpal tunnel syndrome is also one of the problems that happens, and it is actually in the literature, the number of the percentage or the rate of carpal tunnel is 3 times when the woman gets pregnant. Low back pain is a very common during pregnancy. It's estimated to up to 75% of the pregnant women, they complain of back pain, which is so many times mixed with the regional anesthesia they receive for delivery. Yes, we have back pain after receiving an epidural for delivery or after receiving a spinal, and they forget that they're having it actually from maybe the first day or maybe even before they get pregnant, that they have this back pain problem. And most of the women who have back pain during pregnancy, they continue to have back pain in the postpartum period. And because of the changes that happen, laxity of the ligaments and the muscles, relaxation of the rectus abdominis muscle with the anterior positioning of the gravid uterus makes the burden on the back muscles to fix the posture again. So they end up by being fatigued and painful. So still also these changes affect the hip, knee, foot pain, and leg spasm. The hip is also a most common lower extremity problem. It may be mixed with pelvic pain, it may be mixed with lower back pain, but still with all the examination done, and we can consider it as part of pregnancy, but still transient osteoporosis and osteonecrosis of the femoral head must be considered and ruled out, and before we say it's a consequence of pregnancy. Now, carpal tunnel syndrome is a very annoying mononeuropathy. It's the most frequent mononeuropathy due to hormonal changes in pregnancy, hormonal fluctuation, nerve hypersensitivity, glucose level fluctuation. So the chronic pain a woman may pass through, or there is pre-existing chronic pain disorder before she starts pregnancy. Actually, she has a painful condition. We're going to see some examples. And chronic pain associated with pregnancy itself, like we have mentioned, due to the changes that happens during pregnancy, and chronic pain associated with modes of delivery, whether it's vaginal delivery or cesarean section. We're starting with the pre-existing chronic pain. The overall prevalence of women having chronic pain before getting pregnant is not known because it is still understudied. Also, the general course of chronic pain conditions during pregnancy has not been studied in general. Some sporadic pains like migraine headaches or something have been studied. It showed some variation, which is useful in the treatment, but so many other diseases are not studied properly. Pre-existing chronic pain disorder have negative impact on the pregnancy and associated with the risk of sick leave, insomnia, depressive symptoms during pregnancy. Now, we're going to see some examples for the pre-existing chronic pains in general quickly. Migraines are more specifically present in 16 to 18% of women. Variation is that they improve during pregnancy with relapses after pregnancy or in the postpartum. There is still 1.3% of cases starts during pregnancy, and there is a percentage of 4.5% have started in the postpartum period to have attacks of migraine headaches. But why did we choose migraine headaches treatment? Because there are quite significant number of non-pharmacological measures to treat. Maybe Ms. Intisar will be interested. The relaxation techniques, appropriate duration of sleep, stress management, massages, application of cold, advice, triggers, biofeedback, physical therapy has shown a big advantage in the treatment of such cases. So they can start this before getting pregnant because you have to counsel them. And the treatment of migraine headaches, the pharmacological one, is a disaster. If we look at triptans in general, they are not associated with teratogenic effect, but they do have effect on the mother. Like if it is used in the last 6 months before she gets pregnant, it is associated with a stillbirth. And if it is used during pregnancy, there is a risk of bleeding more than 500 ml and the risk of atonic uterus. So a patient with migraine headache, if she's going to go for pregnancy, she should know what are medications that will be, should be stopped, and one of them is the triptans in general, and depend only on antiemetics to treat the attacks. But if she cannot stop, then counseling here should happen about the best way to manage her attacks. On the other hand, the migraine sufferers, they are basically treated with tricyclic antidepressant, topiramate, magnesium, botulinum toxin. They are all category C of the medications regarding teratogenicity, but the patient has to be counseled for them before administering this medication. Botulinum toxin, you have to take a patient consent before applying botulinum toxin, and this consent should state that the patient knows the side effects and the problems that may raise. Rheumatoid arthritis also is one of the common diseases that is under studies, and most common medications are chloroquine, hydrochloroquine, sulfasalazine, and cyclosporine, corticosteroids. They are all basically, we can say, class C medication, which says that class C has shown some animal teratogenic effect, but there is not enough human studies to prove that there is teratogenic effect. So still the counseling should happen, and they should know about their diseases. Now we will come now to the sickle cell disease. It's one of the diseases we have it here in Bahrain. During pregnancy, the changes happens in the oxygen content and the oxygen consumption precipitate the attacks of sickling and vaso-occlusive crisis, which are basically treated by opioids. So the treatment of opioid here has to be clarified exactly what shall we do or what we will do with the patient who is receiving opioid medication to ensure that there is no neonatal abstinence syndrome after that if the patient is pregnant. Also, sickle cell disease patients are susceptible for stillbirths and pregnancy-related maternal death. Of course, the medical advancements have improved their condition, but these risks are there, and it has to be counseled to the patient so they know what they are facing. So there is one point here I want to mention is that prophylactic red blood cell transfusion have no obstetrical or neonatal advantage. It was beneficial only to reduce the number of attacks, and this can be beneficial in cases where the patient is on hydroxyurea, and we have to stop the hydroxyurea because it is clearly teratogenic during pregnancy. So if the patient is having hydroxyurea, we have to stop it, and there is frequent attacks. In that case, I think we could think of RBC's transfusion to reduce the number of attacks. There is Ehlers-Danlos syndrome. That's a syndrome of hyperelasticity of the joint. So when these joints are already hyperelastic and the hormones come, they become more hyperelastic and more instability of the joints and the muscles. So that exposes the musculoskeletal system of the woman for so many injuries during pregnancy. And also in these cases, labor can progress very rapidly. But the effect on the baby is not known. Basic treatment for this a little bit painful condition is acetaminophen, opioids if necessary, but on the short, very short courses or non-steroidal, steroids to control the pain of this condition. Vulvodynia is also a common case that happens during pregnancy, and women with vulvodynia minimize their pain severity during preconception timing and often discontinued medication prior to conception. That because during pregnancy it improves, but it relapses after that. Women with vulvodynia were more likely to have cesarean section and increased postpartum pain with vaginal delivery that resulted in laceration or episiotomy. So the patients with vulvodynia, they have higher incidence of developing chronic pain in the pelvic area after vaginal delivery. Another pain that we can see, again, we come back here to low back pain and all the musculoskeletal pain, hip pain, and foot pain. That is also during pregnancy. It is related to the age, to the race, Caucasian and African American. And also the use of caffeine and tobacco also has effect. Exercise, whether it is present or not, again, we are back again to exercise and physiotherapy. Pregnancy, body weight, and occurrence of low back pain during pregnancy increases the risk of low back pain later in life and during other pregnancies. Chronicity also is related to older age, younger age, which is the extremes of age actually, with the higher parity, higher body mass index, higher weight gain, lower endurance of the back flexors. They are all responsible about the chronicity of back pain that may develop during pregnancy. So the changes that might happen during pregnancy precipitate the chronic back pain later on. Herniated lumbar disc, it's a case where there is a clear radicular pain on one side with weakness in the muscles. In that case, cesarean section is much more preferred than vaginal delivery because of the risk of increasing the case or increasing the condition during pushing and during the manipulation during vaginal delivery. So planned lower segment cesarean section in these cases is much recommended. For the treatment of back pain, pharmacological treatment, of course, there is, but there is the non-pharmacological treatment, which is preferred if we can manage with that. Patient education with or without physiotherapy, mechanical support, TENS, exercise, chiropractic, and other modalities of physiotherapy. Now, 5 points are associated with chronic pain and the mode of delivery. The incidence of persistent post-surgical pain after childbirth is less than a similar surgical procedure because there is protective mechanism here, and that is from the preparation of the woman's body for such event like delivery. So at the time of delivery, the nerves are a little bit less sensitive than the normal conditions. So the percentage, or actually the incidence of the post-surgical pain is much less. If we do the same surgery, they will have more neuropathic pain later on. Pain characteristics are poorly detailed. After cesarean delivery, pain is primarily low-intensity neuropathic pain. The extent of trauma is not predictive of the pain severity, as we mentioned that there is nociceptive protective mechanism that happens in the pregnant woman, especially in the last trimester. And that is what point number 5 confirms protective anti-nociceptive mechanisms. So symphysis pubis diastasis, it's also a condition known after vaginal delivery. Pain is immediately postpartum, exacerbation with weight bearing. There is symphysial tenderness and interpubic gap greater than 10 millimeter by X-ray. The exact cause and prevalence are unknown, and patients are typically managed conservatively with or without analgesia. So all these painful conditions and the situation where the female has, so when we face such condition, we should have some guidelines, especially the number of specialized pain physicians is less and the number of pain clinics is on the lesser side. So on the general for obstetrician, which pain actually management during delivery is left on their shoulder. So a little bit of a suggested guidelines or recommended guidelines and management for these cases. So guideline 1, at the initial obstetrical appointment, an appropriate history and physical examination should be completed. This history and examination should contain detailed information about the cause of chronic pain, what are the treatments the patient are receiving, who's treating her for pain management, and the history of the chronic pain in the previous pregnancies. Were there any pain in the previous pregnancies or not? These information are very helpful to know your patient regarding the pain aspect. Assessment of comorbid conditions that may complicate treatment, such as depression. Medical records from previous providers can help to obtain complete and accurate health information. And also this will at least tell us who is going to write the pain medication for the patient, because we know most of the pain medications are under so much rules and regulations by the health authorities. So who is responsible to write this medication and who's responsible about the health of the baby and the mother? That should be clarified during this visit. Now, recommendation guideline 2, all patients should be monitored for alcohol and nicotine, because alcohol and nicotine consumption complicates the treatment. The guideline 3, collaborate with patients to establish a treatment goal. Now, the patient should not feel that their life will be completely out of pain, because achieving completely pain-free, 100% pain-free might be very difficult, but we might reduce 60 to 70% hopefully of the pain, so the patient has to bear with us for the next 30%, which is actually, according to the studies, it is within the bearable part of the human being to tolerate about 15 to 20% of common normal pain. So the patient should not feel that she will receive a treatment that will give her completely pain-free, but at least it will improve her quality of life and will make at least whatever remains of pain is within the toleration of the patient. So the goals and the, like we say, the expectations of the patient has to be properly controlled. Number 4, management plan should be formulated to minimize the in utero exposure while maximizing obstetrical and fetal health. So the non-pharmacological options are morely promoted. Pharmacological management should aim to reduction of the number of medication taken by eliminating all the unnecessary medications and maintaining only the effective ones. Let's say if a patient is on morphine and oxycodone treatments, then at least one of them should be stopped, and more probably morphine should be stopped, and depending on the oxycodone, basically without paracetamol. Patients are on anti-epileptic, which is a new group of medication used to treat pain. These patients can continue anti-epileptic medication, but they should have folic acid supplement. Guideline 5, for opioid prescriptions, clinicians should prescribe at the lowest effective dose and quantity, and that is the regulations of the Canadian guidelines for opioid prescription for non-cancer pain patients. So the minimal effective dose is the one that is recommended. Of course, strict monitoring, urine testing, and pill counting is a must also. Guideline 6, pain management plan for labor and delivery should be formulated in collaboration with the patient. A visit before the delivery time to the anesthesia or to the concerned department regarding the delivery mode and the pain management during this period is helpful. Patients usually benefit a lot from the understanding of their pain and understanding how much they suffer if the pain is there, with the proper reassurance that this will be taken care of. And last but not least, guideline 7, clinicians should discuss reproductive health with any woman with chronic pain condition and provide counseling as appropriate, like contraceptive in cases that medication cannot be stopped with the risk on the baby and the decision is taken for contraception, or the decision is taken to go on with pregnancy with the risk of withholding medication or need to stop other medication, and the patient has to tolerate the symptoms of withdrawal, and all it is with agreement with the patient during this session. So these guidelines are the basic pieces of information that the patient, pregnant woman, should receive to be able to properly manage her pain, whether it was a chronic before pregnancy, or it developed during pregnancy, or it developed only in the postpartum period. Thank you very much.
Thank you, Dr. Ashraf, for this wonderful presentation. The floor is open for any question. I have one comment, by the way. 70% of cases of depression present with pain.
Yes.
First presentation, pain. 70%.
No, sir. Depression. It's purely somatic. It's not psychosomatic.
But unexplained by physical examination or but first presentation of depression is pain.
Any pain, headache, shoulder pain,
Yeah.
any pain.
Especially in rural areas. كان الدكتور عكاشة بقى الله يمسيه بالخير كان بيقول دايما في الأرياف يعني الست لو راحت لقيت لجوزها أنا مكتئبة هيطلقها، لكن لو قلت له أنا عندي ألم هياخدها يعالجها، فهو بتختار الألم body language تعبر بيه عن الدبريشن كان يعني
Well, actually, sir, the principle of psychosomatic is now more detailed because when we say psychosomatic, it's like only a psychological, but there is actual increase in the tone of muscles and actual irregularity in the movement of the muscle because of this such increased tone leading to spasms of the neck and shoulder muscles, and they develop lots of spasticity and trigger points, which we can deal with trigger point injections, or we can deal with acupuncture or dry needling, and physiotherapy also can help us. But there is actual increase in the muscle tone, there is actual trigger points, and there is actual pathology behind it. It's not like symptomizing. And for the normal and the province people with the level of education, they don't have that much of freedom to say, I am depressed, but they understand very well that I am in pain. So in that case, the depression continues, and people with depression, they have exaggerated pain sensation, because depression by itself makes pain and makes the perception of pain worse. So in that case, you cannot judge exactly which one came first. Is it the pain causes the depression or the depression caused the pain? But both are together and both have to be treated as separate entities, not as one entity under psychiatry only or under pain management only. It has to be both.
My last question in this conference is explain for me what is pain threshold. Is sometimes she is described, or he described that he has a low pain threshold and a high pain threshold. So what is the normal pain threshold?
Actually, Dr. Hatem, your question is one of the questions that led to the rise of pain management as a knowledge and science. And it was one of the questions raised by Wall and Milzak. These are the founders of the pain management science, and they have a very good book called Wall and Milzak for pain management. And they got Nobel Prize for theory, which is the gate theory of pain, by asking the same exact question you are saying. So these are two scientists, one in Europe and one in Canada. The one in Canada have noticed that patients with amputated arms are complaining of pain in the amputated part, while the other person in Europe who had the same observation, and as you say, that the same pain, same intensity, same site, with different responses from one patient to another. So that is what we call the threshold of pain here. And that is related to so many issues. It's related to genetics and even related to the experiences we face in life in general. Like when you are depressed or stressed somehow, let's say preparing business work, and you get hurt at that time, your pain sensation will be much terrible than if you get the same injury in a time when you are relaxed or when you had it during a summer vacation or something. So, and that is somehow also related to the relativity theory of Einstein, that the feeling of time and the feeling of the pain at the same time. So there is no threshold per se, there is no number we can say. Each pain should be dealt with individually, and each person should be assessed individually according to his general. Now, to ask about pain intensity, even 0 to 10 grading, it depends on the patient response to me, not my judgment. So when we ask the patient to rate his pain right now, it is 0 to 10. And he has to tell me which number from 0 to 10 is his pain. So I don't judge his pain, he judges his pain. And as we say always, pain is what the patient says, not what you feel or what you believe. So pain as the patient says. So there is no clear threshold, it's individualized. Thank you, sir.
Now we come to the end of our conference. I would like to thank all the participants. I would like to thank Dr. Mariam Jalahma for being the patronage of this conference, and on her behalf, Dr. Zahra Nasib, who attended the opening ceremony. I would like to thank all the speakers, all the attendees, either physical or online, the virtual attendees. I'd like to thank them all for their active participation and for the active discussions which have been taking place. And I would like to close the ceremony by starting the third MAC from now, inshallah, for next year, most probably at the same time. The pipe is opened for all the participants for their ideas, for their new abstracts, new studies on the website of the hospital, or they can contact our business development team in approaching us at any time for any help, either in our fields or in their inquiries for the third MAC. Thank you very much. Thanks for Education Plus. Thanks for the sponsors. Thanks for Crown Plaza. And thanks very much.
Just Dr. Hatim, before you closing, and if you excuse me just for 1 second, on behalf of the Royal Hospital, they would like to appreciate your efforts for the first and the second Congress, and it was a real effort, and it's still continuing. Inshallah, it will continue for the third and fourth and fifth and further Congresses. Thank you very much. For you as a president of this conference, Dr. Ashraf is going to award you with the appreciation, if you
Thank you
accept.
very much.
Thank you.
Thank you.
Thank you. Thank you very much. It's a very nice organization. We appreciate your work and we appreciate your effort.
Thank you very much. Thank you. Thank you.
And also on behalf of the Royal Hospital for Women and Children, Dr. Hatim will receive Dr. Suhail, because I think he's left award as well.
Thank you.
Thank you very much.
Thank you. Thank you. Thanks for the Royal Hospital. Thanks for Dr. Hassan. Thanks for Dr. Ashraf. And thanks for the management of the Royal Hospital, for Mr. Rohit, the CEO of the Royal Hospital. Thanks for Dr. Suhail. He was the president of the pediatric conference. Thanks for all the organizing committee. And again, I would emphasize that the pipe is opened with all the participants for any help or any support from our side in the Royal Hospital in all specialities. And see you, inshallah, in third MAC. Thank you very much. Bye-bye.
خلاص خلصنا كده. It is empty. It is empty. Not even designed.
Take me a picture with Dr. Tariq and Dr. سيبك من الميكروفون بقى. سيبك من تاج الجزيرة بقى كده. تاج الجزيرة بقى. بتاع فاضي والله العظيم ده ايه ده؟
عشان كده بصراحة بصراحة.
Just for the memory.
انتصار تعالي يعني شرف لينا ويانا اليوم.